Good morning to all.
Good morning, sir.
We are live.
So good morning and welcome everyone to the IAP National Respiratory Chapter brought to you by the Indian Academy of Pediatrics and powered by digital partner ClearNet. Thank you everybody for watching. It is now with great honor that I introduce the Honorary Secretary of the IAP National Respiratory Chapter, Professor Subramaniam, also the convener for the event. So over to you.
Yeah. Good morning, everyone. First of all, from all of us over here, more than office bearers and faculties, we are your colleagues and wish you all happy Diwali. And you can wish each other, and I will give 30 seconds time. You have joined on the festive mood. Before we would begin the session, I would request our chairperson, Dr. Kashi sir, can you give some opening remarks? Dr. Jagdishanappa is not joined, so Dr. Kashi sir. Anyway, I will wait for him to log in, then see. Okay. Dr. Kashi sir?
Yes.
Sir, please give some opening remarks on the chapter, you being the Vice President, sir.
Okay, thank you, Dr. Subramaniam. I think today is a very important day for this particular group of office bearers from the IAP National Respiratory Chapter. I mean, it's the beginning of a very long journey where right about 2 years back, we thought of having a module on pneumonia. A lot of things led to some delay, but I'm very happy that the module has finally taken off. And I'm sure this module will go a long way in giving a lot of information and rationalizing the treatment of pneumonia at all levels. Thank you, Dr. Subramania, and congratulations to all the people who are involved in the formation of this module. Thank you.
Thank you very much, sir. I bring greetings from, they have sent the messages from Bakul Parek, Basavaraj, Dr. Jagdish Chinnappa and all the EB members. So with these words of wishes, let us begin. Now, some of you must have attended the program on 12th. Some of you must be attending on today 15th. Some of you might be repeating some sessions, but in any case, we are all happy that you are remembering pneumonia again and again on the auspicious week and on the most prosperous week of Diwali. You know, Diwali is the time where, you know, Diya Jalai, you know, we are going to light the lamps, and the lamps are lit in such a way that we will have increased awareness and knowledge on pneumonia and transfer it on to community in a meaningful manner so that there is a reduction in the morbidity and mortality. Let me ask the audience a small question why this module was born. We were all clear by the government of India, WHO, everything about recognition of pneumonia at tachypnea level. See, ASHA worker, peripheral health worker, everybody was told count respiratory rate and then refer. Either give quarter amoxicillin or amoxicillin and then refer, isn't it? That much of clarity was there. Just recognize tachypnea and as pneumonia and then refer. What happens after referral was pretty unclear. After referral, a patient can find various ways. One, he may go back home and do not take any treatment further. He may go to a private nursing home. He may go to an outpatient of a pediatrician. He may go to a government hospital. He may go to a teaching institutions. He may go to a corporate hospital, so on and so forth. Do you all agree on one point? There is heterogeneity in the management, the way the pneumonia happens after this kind of referral. If you say yes, you type yes. Do you all agree? There is lot of heterogeneity. The protocols of various institutes, various organizations, and various pediatricians and various people differ, really differ. If you think that the respiratory chapter is putting a tremendous effort in bringing uniformity in this heterogeneity, and there is Narayan Prasad Modi from Hindi Heartland and Rashmi and Hima, you can correct me if I am wrong. You know, Dvivida mein ekata. What you call actually?
Exactly the same. Vivita mein ekta.
Yeah. So this is an attempt to. Oh, Rawat sir is there from Hindi Heartland. Okay, I forgot. You are from more Hindi Heartland than anybody else. So this yeah, this ekata or this uniformity is an attempt by us. And I do agree, many of you may stand for the heterogeneity at your place. Some of you from the corporate setup may feel, no, 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 sir, no, 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 I have to give piperacillin as a backup. Don't tell me the ampigenta. What is this, sir? Some of you from the government hospital may, sir, even MP is not affordable. I'm enough with crystalline penicillin, only that is supplied to us. Do you agree on this point? And it does happen. And it does happen. So therefore, the exercise for the persons who are sitting at this uh, bench would be very, very difficult to bring uniformity amongst heterogeneity as far as the recommendations is concerned. Yet it's a beginning step. But whenever we want to go for recommendations, we have to put our steps carefully because we look back for evidences. Mind you, evidences are there from wonderful studies in India. And one of the person whom I should compliment is Dr. Rashmi Ranjan Das, who himself is involved in one of the studies involved extensively in pneumonia. And we have also many more. I'm just taking one of the name whom I can see on the screen. Many of you might be taking the studies. And not just that, you may have wonderful experiences, which is more than what we can speak today. And also, we can also see that you may agree to disagree on some points, and it is wonderful. And for us, that is what we want. We don't want you to price the module. Rather, we want you to contribute to the science and note down the slide number. This being a TOT, you can message in the chat box, in the question box, or to my personal number on WhatsApp. This particular slide requires correction. And we will take 15 days to 1 month from both the TOTs, and we will take the feedbacks from all of you, and then we will freeze the module. This module authorship is by 31,000 IAPNs, not by 4-5 of us. So we would give you all the authorship credit because even a smallest contribution is acknowledged by all of us. So it's your module and you are going to take it back home. And we are not just happy if you just get trained and go off. We would be very happy if you conduct in small groups. Now, the second challenge was for holding on you all for the time that is given, maybe for 4.5 hours. So what we are essentially doing quickly, let me tell you, this would be broken into 2-day module. We are running the TOT on 1-day basis, probably 2 plus 2 hours. Suppose in your place, you want to do for 4 days, 1 hour each, you are welcome. So don't criticize the length of the module because it will be at the cost of its contents. Did you understand? So we don't want to reduce the contents. We don't want to make it flash, just say, that was a nice module, 45 minutes of enjoyment. No, there is no enjoyment of academics in pneumonia. We mean serious business as far as impact and reduction of the morbidity and mortality is concerned. So you can be, as a trainer, as a lead faculty in future, to customize the time divide based on the uh, local logistics and the time duration and attention span of the audience that you have got. Is this fine for all of you? Then fine, yes, then we'll go ahead. So today you have to bear with us for a period of around 4 hours plus, only because you are all getting trained. And you can customize it. Definitely we will permit you, don't worry. You can say in a particular area, for example, pneumonia in immunocompromised host. I'll give a small section, may not mean anything to a particular place. Then you can even cut off those slides and customize it for the local requirement with the permission of the chapter. Please write to us, sir, we are conducting in XYZ place. Here, the practitioners are not seeing any immunocompromised, such big challenges. We are more interested in simple recognition and management of pneumonia. We will do these many set of slides. Fantastic. We have no issues. We are not telling that you are modifying, distorting the module. But the contents within the module should have some basic discipline. So therefore, don't go without the consent of the chapter. So this is the first lesson I'm starting for you, and then I will take all of your permission to start today's session. So thanks to all the members from the respiratory chapter. And the copyright issues are there. This module is only meant for academic purposes and nothing else. And lastly, let me raise the pitch of today by asking you, what is pneumonia? Can somebody type in the chat box, and then I will hand it over to Rawat sir. What is pneumonia? Is pneumonia a disease? Do you all agree? Pneumonia is a disease? Type yes if you agree. Okay. Pneumonia is an infection. Do you agree? Yes. Infection, most of you are agreeing. Is pneumonia a shadow in an X-ray? No. Many people are telling no. Good. Is lastly, you stop typing. Let me tell you. Is pneumonia a problem? Problem for all of us. More than a disease. My dear friends, and therefore this World Pneumonia Week. If it were to be a disease, we would have had a module long back or little later after much more preparations. We had a deadline of November 12th, World Pneumonia Day and a week. And so we had to finish all the slides within this stipulated time. So please forgive us if you don't agree with part of the contents, and you should give us the feedback. So therefore, with this speech, let us first look at the epidemiology, and let me introduce all the faculties to you. I will ask the faculties to introduce themselves and the topic that they are going to discuss. This would be, the outline would be, first is epidemiology, magnitude of the problem, followed by clinical recognition, and then diagnosis, investigations, management, antibiotics, and beyond antibiotics, complications, recognition of the complications, management of the complications, pneumonia and special situations, and prevention. And lastly, we will have post-test. If you don't do the post-test, you are going to miss the button and you will not get the certificates. I have just now typed the pre-test link in the chat box. Please, all of you, do the pre-test and please submit it. Otherwise, pre-test and post-test are compulsory for all of you. So I'm sorry for taking first 10 minutes of yours for introduction and the way you have to understand the module. So please, last request from all of us is that don't put on and then do Diwali celebration. Celebrate Diwali on the desktop or on the mobile that you are doing. You will always get a lot of enjoyment. And when you see the neighboring mother, thank you for saving her child under 5. So can I request all the faculties to come on the screen for a while and introduce themselves? Starting from Rawat, sir.
I am Dr. Sanjeev Singh Rawat, consultant pediatrician from Indore, and I will be taking epidemiology.
Dr. Manjunath, I'll be talking about the etiology of the pneumonia.
The next talk by
Modi. Modi, sir.
Modi.
I am Dr. Narayan Prasad Modi from Bhubaneswar, and we will discuss about recognition of pneumonia from my part. Thank you.
Myself, Dr. Rasmi Das. I'm additional professor of pediatrics at AIMS Bhubaneswar. So I'll be taking on assessment of severity and triaging of pneumonia in children.
Good morning, everybody. I'm Dr. Hema Gupta Mittal. I'm associate professor and senior pediatrician at RML Hospital, Delhi, and I'm a pediatric pulmonologist. I'll be talking about complications of pneumonia.
I'm Dr. Usha Rani. I'm head of the Department of Pediatrics, Osmania Medical College, Hyderabad. And I would be taking antimicrobial therapy and feel privileged to be part of this module. Thank you.
Good morning. I am Dr. Sushant Mane, Associate Professor of Pediatrics, Grand Medical College, Mumbai. I'll be taking investigations part, radiology.
Good morning, Dr. Bela Verma here from Mumbai. I'll be speaking on preventive measures of pneumonia.
Bella madam, can you post the pre-test link again in the chat box? Some of them have difficulty in opening. Please try. Okay. So don't worry, again
I don't know how to do it.
And I'll manage.
Sir, sorry, I don't know how to do it.
I'll manage. Fine. So then we'll start up with the sessions by the first presentation from Dr. Sanjeev Singh Rawat. Dr. Rawat, sir, over to you on magnitude of the problem.
Yes, sir. I'll share the screen.
Yeah, please.
Can you see my screen? Okay. So, good morning and very happy Diwali to all. Before I start, my special thanks to IIT National Respiratory Chapter President Dr. Jagdish Chanappa and Honorary Secretary Dr. Subramaniam for asking me to be a part of this very important module. My welcome to all my co-faculties of this module and all the delegates who have joined this morning to understand what is pneumonia in children, short PIC module. This module is a hard work of many faculties, names which we have put here. Apart from that, as Dr. Subramanian has told, we want to involve all the IIT Respiratory Chapter members to contribute, and whatever the suggestion would be, we will try to incorporate in this particular module. So this module is divided into a couple of sections, and first section is on basics, in which you will be dealing with burden of pneumonia, global and India, risk factors, etiopathogenesis, recognition of pneumonia, typical and atypical, predictors of mortality, severity classification, and triaging. We start with epidemiology. Now you must be wondering what is the importance of learning about epidemiology in a module. So I want to caution you that this is one of the most important sessions because of two important reasons. First, it will set the right context why this module has been made. It will make you understand that what does it need for all these 20 people to slog and prepare those slides and contribute to this particular module. So you understand the context of which this module has been made. And second, very important is that it will make you realize what are the factors which you wish to deal, so as to have a significant dent in the morbidity and mortality of pneumonia globally and nationally. Because if you don't understand the factors which are causing this particular disease, you really cannot act. So treating pneumonia at a clinic, at a hospital is easy, but trying to make a dent at national and international level, that is the need of hour. Why? Because pneumonia is the second most common killer of under 5 across the globe. So if you want to make a dent, you have to understand the factors which are leading to the disease and the morbidity. So we'll understand in more detail as the slide goes. So if you see the global burden of pneumonia, it is the single largest infectious cause of death in children worldwide. Nearly 8 lakh children under 5 they died in 2017, approximately 200 children per day, and 15% of all children under 5 they died because of pneumonia. So pneumonia and diarrhea, these are the two big killer, and I think if you tackle even one of them, it is going to cause a significant dent in the deaths of under 5. It is a leading cause of poverty in young children in low and middle income countries. We will see that poverty is very important factor for this particular disease. And mortality in just 5 countries, these are the 5 big names: India, Nigeria, Pakistan, Congo, and Ethiopia. And they account for 50% of all deaths from pneumonia in children below 5 in 2017. It's very recent data. So if you want to have any global impact, you have to tackle pneumonia in these 5 countries. If you do that, you can have a visible impact globally. Now, if you see the global deaths of pneumonia by age in this past 3 decades from 1990 to 2017 in different ages, if you see the deaths from pneumonia has been going down at all ages, above 70, 50 to 69, 5 to 14, under 5. So there has been a steady decline in all age groups. Now we are more interested what is happening between 5 to 14 years. And in that segment also, there is a very significant decline in the number of children dying from pneumonia. And the number of children dying has significantly decreased over the past 3 decades. And in 1990, more than 2 million children they died from pneumonia, and the number has declined by almost 2/3. So from about 20 lakhs, the number has come down to about 8 lakhs. So if you see, there is a significant impact, significant work being done, and the things are getting better in this past three decades. And what we see that in 2017, the lowest mortality we see, it was in Sweden, and the highest mortality we are seeing in Somalia. So we have got the best country, we have got the poorest country. So, but we should not be happy by this decline, because still the numbers are so big that we need to work hard, we need to work more diligently to have a more significant impact. So if you see this segment of under 5 specifically in 2007, deaths from pneumonia, if you see the number of children dying, absolute number of children dying per 1 lakh, all this dark blue color, it indicates more than 500 per 1 lakh. If you see again, the part of Central Africa is where you see maximum blue color, where maximum deaths due to children they are in pneumonia they are occurring. India somewhere falls between 100 to 200. Again, it is although bit better as compared to Africa, but it is not a thing to be very proud of. We still figure among those 5 countries where maximum deaths because of pneumonia they are going to occur. And if you see the absolute number of percentage of children dying because of pneumonia as compared to all the other causes, more than 30% of deaths occur because of pneumonia in all these dark red area. Again, the central part of Africa is the part where it contributes that percentage of children dying from pneumonia percentage, it is very high. Again, India falls somewhere between 10 to 15%, which is again pretty high. So as you see, the disease and the death because of pneumonia, it is concentrated at few particular parts across globe. And if you want to act, if you want to have an impact, these particular areas should be taken care of very closely. So India, Pakistan, Nigeria, Congo, and Ethiopia, they are the big 5, and they have to be dealt at priority. Now, as I told you, pneumonia is a disease of poverty. This is a very good study which they had shown. They compared pneumonia deaths as compared to GDP, and all countries which had got a very low GDP, less than $20,000, they had a very high mortality. Like for example, Central African Republic, Nigeria, Niger, Democratic Republic of Congo, they all had deaths almost 500 per lakh. And as the GDP improved, as you see towards Singapore, Ireland, Qatar, the death is almost negligible. So pneumonia and poverty, they go hand to hand. And again, improvement in your general GDP and improvement in general status is going to have a significant dent on pneumonia mortality. Now, if you see specifically what is the burden in India, in 2017 data, 41% of children, they died due to pneumonia. In India, it is second biggest killer. The biggest killer is diarrhea, followed by pneumonia. So 14% of children dying, they died under 5 because of pneumonia in 2017. And again, a very recent data, 2018, almost 1.27 lakh children, they died because of pneumonia in under 5. Something to again having a good news is that in 2000 to 2018, there has been a gradual reduction in pneumonia mortality in the past 2 decades, probably because of improvement in the general economic condition, more stress on nutrition, vaccination. Things have shown a good improvement in the past 2 decades. Average reduction in mortality in India by pneumonia is about 7%. And the WHO launched a specific program known as Global Action Plan for Pneumonia and Diarrhea in about 2012, where it is targeting all these countries where there is a high mortality because of pneumonia to take specifically measures to impact pneumonia mortality. And they have set down a target for India. By 2025, they have to decrease the under 5 pneumonia deaths to 3 per 1,000, which is currently at 5. And if you see how we are doing fairly good. And the under 5 mortality per 1,000, if you see in 2000, it was about 17. Currently, it is about 4 to 5 in 2020. And the target is going to be 3, and which we feel that we're going to achieve. So if we continue this particular trend, and if we continue all the things we have done in the past 2 decades, we are hopeful that we'll attain the target in 2025 what GAPBD has set for us. Now, something I want to impress upon you that this is the information which you will be really surprised. Till now, we had this idea that strep pneumonia is one of the very common cause for pneumonia. You know, there has not been a much updation of data in the past 10 years, but now these are very recent paper which came in 2019, which specifically saw the etiology of pneumonia in low middle income countries, and what they found was that because of increased use of pneumococcal vaccine, PCV and Hib vaccine, there is an important change in the etiology of pneumonia, and Staph aureus, H flu followed by Streptococcus pneumoniae. In order of importance, they are the common cause of pneumonia. So whenever we are going to treat pneumonia empirically or in community, you have to understand this particular fact in mind that in lower middle income countries, India is also a part of it. Staph aureus and H flu are one of the very important cause for pneumonia, and if your pneumonia is not responding the way in which you think, then these organisms must be targeted. Viruses, again, they are very important cause. They contribute to about 40 to 50%. I mean, 2015, RSV and influenza, they accounted for about 20% and 10% respectively. So virus as a whole, they contribute quite significantly to pneumonia, about 40 to 50%, and about the remaining they are caused by the bacteria. Fungi, because of HIV and immunocompromised state, because we've got a huge population of malnourished children. We have got a lot of pneumocystis jirovecii also. So in a child, that particular setting, we must think of this organism and also target this, because it has got a specific way of treatment. If you don't target it, probably your child is not going to respond. Now, what are the risk factors for pneumonia? Host characteristics. Various factors are they are more common in infants: lack of immunization, lack of exclusive breastfeeding, severe malnutrition, chronic underlying disease, HIV exposure, HIV infection, and low birth weight. Whereas socioeconomic factors involved for pneumonia are young maternal age, low maternal education, low socioeconomic status, poor antenatal care, tobacco, smoke, indoor air pollution, crowding, and ambient. So, apart, including all these factors, 4 have been singled out: lack of breastfeeding, severe malnutrition, indoor air pollution, and ambient pollution. These four are the big cause for risk factor for pneumonia, and you also understand that these are also important risk factor for mortality. So if you are going to tackle these four causes, promote breastfeeding, tackle care of nutrition, control air pollution, both in home and outside, it is going to have a significant death, both in incidence as well as pneumonia mortality. If you see the global risk for death from pneumonia, according to risk factors, again, if you see, malnutrition is one of the biggest risk factor. And if you see the uppermost bar, almost more than 50% of death in pneumonia, they are contributed because of malnutrition. So out of 8 lakh deaths, almost 4.2 lakh deaths they were contributed by malnutrition, followed by indoor air pollution, which contributed to about 2 lakh deaths, and outdoor air pollution about 1.4 lakh deaths. So if you see, if you tackle these three, malnutrition and air pollution, significant of your children will not either suffer from pneumonia or will not die because of pneumonia. This is a very important factor for preventive aspect. If you see in India, again, risk factors for death in India in 2017, 53% was contributed by wasting, 27% by air pollution, outdoor, and 20% by indoor. So again, this data also in India holds true, that if you have any impact on the disease, tackle these three things very effectively. And in India, almost 20% of children under 5, they are malnourished. The data of 2017. So we are having a huge burden of malnourished children, lot of air pollution, indoor and outdoor, which is contributing to a lot of deaths and diseases. This is a very good paper which came in 2016, in which they saw what are the predictors of mortality in a child who had severe pneumonia. And if you see the adjusted odd ratio, a child who is referred late to the hospital, odd ratio of dying is almost 52%. Now, other factors are Z score below -3, indicating severe malnutrition, incomplete vaccination, refusal to feed, and hypoglycemia. So these factors were found that they are important predictors of death in a child with pneumonia. So if you have a child who is referred to your hospital with pneumonia and these factors are present, you can just be on your guard that this child is going to die, the risk is high, and you have to take care of this child more closely. Now, this is a very excellent systematic review which came in 2015, in which they tried to see the effect of malnutrition on pneumonia, both the disease and the death. And they found out, it's an excellent systematic review which indicated that this is a very deadly combination. Why? Because the disease totally behave in a different manner. It has got a different etiology. There is a very high mortality, and the disease is difficult to diagnose. We will see in more detail. The etiology of pneumonia in malnourished children is totally different. There is a very high, about 26% were caused by Klebsiella pneumoniae, 25% were caused by Staph aureus, and 18% by Streptococcus pneumoniae. So it is a totally different etiology in malnourished children. You got more gram negative. So we have to use more and more of ceftriaxone, where it is going to take care of gram negative Klebsiella pneumoniae, because that is the commonest cause of pneumonia in malnourished children. Then very high mortality. If you see in child who is having severe malnutrition, the RR, the relative risk of dying, is anywhere from 2.9 to 121 times, and odd ratio 2.5 to 15.1. Whereas in moderate malnutrition, it is still high, 1.2 to 30 something. That means indicating that children who are in malnutrition, they are at a very high risk for dying. And again, very important, all your signs and symptoms given by WHO, they are not sensitive to pick up the pneumonia. So a child with malnutrition and pneumonia, he may not come with distress, he may not come with high grade fever, he can be only dull, and he could have a very severe pneumonia. So this combination of pneumonia and malnutrition, it is absolutely deadly combination, and you must be absolutely very well aware of this particular factor when you are managing a child with malnutrition and pneumonia. Now, risk factor for death, again, one of the very important factors is lack of health care seeking behavior. Now, this chart tells you the number of children who are taken to healthcare facility after having pneumonia. And you see, this is a study done from 2006 to 2019. And what did they see? That almost 40% of children with pneumonia, they were not taken to healthcare facility, and there is not much change in the past. They compared to different decades from 206 to 2012. This dark blue and the light blue is from 2013 to 2019. And what do they follow that? There is not much change in health seeking behavior of patient. In Africa, the change has been only from 53 to 50, only 1% change. In Central Africa, 45 to 59%. So if you see, there is not much change in the over past 2 decades in people seeking health care behavior from hospital when the child is falling sick. So almost 32% of children with suffering pneumonia were not taken to healthcare facility, and in poorest country it is as high as 40%. And then same data if you see across the world, from rich to poor and from urban to rural, if you see again the healthcare seeking behavior of people is very poor. So again, if you want to have an impact across your country or across globe, people must be made aware. People must be made aware to recognize the sign of pneumonia. Very simple. If a child is breathing fast, you will understand this as the module progresses, that the people can be taught with very simple signs that if your child is breathing fast, if you are having retraction, then it is a child who is sick and he has to be rushed to a medical facility. So if this particular thing goes to masses, I think it will have a significant impact, significant dent on the disease as well as death. So in nutshell, what you have to do is that you have to recognize pneumonia promptly, recognize cases with that don't have pneumonia. More commonly wheeze. Normally we see under 5 children who are wheezing. So identify those children who are wheezing, who don't have pneumonia, because they have to be treated with bronchodilator. And those cases of pneumonia, we have to use antibiotic. Again, this is you learn in the subsequent slide. Antibiotic is the most important factor which is going to have an important bearing on the survival of children. So antibiotic should be used judiciously. And all children who are sick, they have to be referred early. Again, underline the word, they have to be referred early. How can we prevent? We'll have an entire session on prevention. But just to have it in a nutshell, childhood vaccination, nutrition and immunization of mother, they have an important dent on pneumonia. I like to single one practical factor of PC vaccination. So it has been seen in a study where if you just scale up PC vaccination to equivalent to DTP, it could prevent about 39,000 deaths of pneumonia and about 54 million episodes. So just by scaling PCV to the level of DTP, you can have a significant dent on pneumonia deaths and disease. I think this is a very important vaccine, and we should be taken up by all practicing pediatricians and all the countries as a very essential part of your vaccination armamentarium. To end my section, to summarize, globally pneumonia is a leading cause of childhood death. In India, 1.27 lakh children under 5, they died in 2018, almost 14 children per hour. Important risk factor, mind you, pay very attention on this particular fact. This factor of pneumonia are malnutrition, household air pollution, ambient particulate pollution, and suboptimal breastfeeding. So if you combat these 4 factors, it will have a significant dent on disease as well as the death. And childhood pneumonia can be prevented easily. I again another word, easily, by immunization, childhood and maternal, nutrition, breastfeeding, vitamin A and D and zinc, and controlling indoor air pollution. Thank you very much. If you have any questions, you can just type in the chat box and we'll like to answer them.
Thank you, Rawat sir, for that wonderful deliberation on disease burden and global, and as well as the problem in India. Sir, many were asking us why we always include epidemiology, but let me answer from the platform that unless you understand the problem, we will not know what to do. We as pediatricians think that examining the child, taking an X-ray and giving couple of antibiotics is all that is required for pneumonia. No. Pneumonia mortality and morbidity cannot be reduced by these 3 or 4 actions that we are doing day in and out. We need to step out of our clinics, reach out to the mob, maybe teach them, and having understood the problem globally and from lower middle income countries and largely preventable, like let's say indoor pollution, malnutrition, breastfeeding, immunization. I think these are some things which we can do at large to increase the awareness in the community. They can reduce the mortality by 50%. And is it not soothing for us? And that's the best Diwali gift that we can give to the community. So this is exactly why we are celebrating Pneumonia Week. I'm coming back to the disease burden and the problem again. So we request all of you to be active and participate. Give something back to the society. They will respect you a lot. Already there is a lot of fights amongst the public to the respect to the doctors, Vaidya Narayana Harihi. And this is something which gives a good opportunity for a few to reach out through the uh, uh, through the media as well as through the social groups and through the messages. I would go one step ahead and tell you one. We would request all of you to convert mothers into staff nurse. Convert a mother into staff nurse. What staff nurse will do? She will take temperature, she will take pulse, she will take respiratory rate, and she will do pulse oximetry. And tell me, is there any mother, even in the remotest part of India, who cannot be taught how to take temperature, how to count respiratory rate, how to do pulse oximetry, and how to count the pulse? Is it so difficult? Is it so difficult? Through the videos, through the social medias, through your ringtones, through your messages. You know, you have so many busy messages. I am not available on Sunday. All these things you will post in the groups now. Why can't you do these things as well? So that's the request from the chapter. And secondly, what was very nicely evident from the previous discussion was beautiful change in the microbiota or epidemiology as far as the etiology is concerned, which we are going to discuss more. But suffice here to tell that we are in the myth of the evidences from the West and abroad. The evidences of the organisms from the lower middle income countries include good amount of viruses, staphylococcus and gram-negative organisms, given the prevalence of malnutrition and the socioeconomic status and extensive indoor pollution that we are facing. So this is very, very important for us to understand. And many of you may be practicing in different epidemiological circumstances. Some of you may be rural pediatricians, some of you may be in the cities, some of you may be in the poor reach out cities, middle B cities, C cities, so on, towns, or so on and so forth. So therefore, my dear friends, so you need to customize and put a lot of common sense to think what could be the organisms. So this takes me to the next section by Dr. Manjunath on the etiology and the organisms for you. Over to Dr. Manjunath. Manju, unmute. Yeah, start.
As you all know, a lot of that has already been spoken by Dr. Rawat and Dr. Subramania. There's very little left over for me to talk. But despite that, I'll try to make this as much useful as possible. And so we need to know, we all know that pneumonias can be either caused by infectious or non-infectious causes. Among the infections, as we all know, it is bacteria, virus, fungi, and occasionally parasites. The non-infectious causes of are aspiration of food or gastric acid, foreign body, hydrocarbons, lipid substances, hypersensitivity reactions, drug or radiation-induced pneumonitis. So As we discussed early, as Dr. Sanjay Singh Rawat discussed about the epidemiology, he also touched upon the pattern of the various virus and bacteria. Probably I'll be elaborating a little more on that. So we categorize basically by the age. So in children who get infection in less than 3 months, between 3 months and 5 years, and above 5 years. Why this is important means by the epidemiological, by the age, we can understand what is the probable causative agent. And on most occasions, we work by the guessing the organism, and many a times we don't try to look at the exact cause of the etiology. If we get a cause, that's fine. But in any case, we don't get it. This is a clue. This is a guide for us to go ahead for our next sections. In less than 3 months, the most common causes for the bacterial of the bacterial agents are the Klebsiella, E. coli, other gram-negative bacteria, and the staphylococcal infections. And the less common causes of pneumonia are among the bacteria. We have the pneumonia, H. influenzae, anaerobic infections, organisms, and ureaplasma. Among the viruses, we have the cytomegalovirus and the herpes simplex virus. Between 3 months and 5 years, here we see the maximum number of bacteria, viruses included, because this is the commonest age where we see a lot of infections in our outpatient basis as well as on the inpatient basis. The pneumococci, H. influenzae, Staph aureus, Klebsiella, chlamydia, and mycoplasma. There is a definite pattern evolving. We saw more of gram-negative bacteria coming there, and we have the capsulated organisms coming in this section. And among the viruses, we have the next most common virus like the RSV, parainfluenza and influenza viruses, human metapneumovirus, adenovirus, and the rhinovirus. The less common in these days are the pertussis, Mycobacterium tuberculosis, meningitis. Among the viruses, we have the measles and the varicella zoster. In this section, it is clearly evident that the bacteria, the capsulated bacteria tend to dominate in this age group. The pneumococci, and then we have the other bacteria like the mycoplasma and the chlamydia. And the less common causative agents are the H. influenzae, Staph aureus, and the Mycobacterium tuberculosis. As Dr. Rawat was discussing, with vaccination, the lot of the agents have changed over years. What was most common about 20 years back has become less and less common in these days. The less common causative agents are the adenovirus, Epstein-Barr virus, influenza, parainfluenza, respiratory syncytial virus, and the rhinovirus. And depending upon the microorganisms, we have a separate set of symptoms and signs what we see. The viral pneumonias, they almost always present with a short course of upper respiratory tract infection. They are gradual in onset, and the children look less toxic. They may be associated with wheeze or bronchiolitis-like features. They tend to affect both the lungs and almost all the lobes, generally last for 3 to 5 days and resolves spontaneously, or some of them end up in a catastrophe. Streptococcal pneumonias, they tend to be more toxic, rapid progression with a lobar pneumonia, and the gastrointestinal symptoms may also manifest with a lower lobe pneumonias and in a younger child. And the staphylococcal pneumonia, it is more ominous. Along with the signs of pneumonia, we also have the empyema, abscess, necrotizing pneumonias, and the pneumatocoel formation with the staphylococcal pneumonias. Atypical. Why atypical means they don't either behave like a viral or a bacterial. They somewhere behave in between, and that's why they're considered as atypicals. But they tend to have more preponderance for the viral pneumonia-like patterns. Wheezing may be associated with this atypical pneumonias. They may not be sick. They are the walking pneumonia types, and the lung involvement is generally diffuse. So the next part is the pathogenesis and the pathology. It is seen that we generally have 4 types of the involvement. One is the lobar pneumonias, bronchopneumonias, interstitial, and the miliary types. In this picture, we can see how they are divided. We can see the entire lung or a patchy involvement, or the entire, both the lungs are affected in the interstitial types. So lobar pneumonia is again categorized into 4 stages. The lobar pneumonia here, as we can see, a section of the lobe or the entire lung may be affected. When we have engorged vessels with edema, the lungs become heavy, red, baggy from the blood and bacteria in the alveoli. And this is the stage of congestion, which generally lasts for about 24 hours. And in the next stage, when the lung starts getting a little dry, firm, and feels like liver. And between 2 and 4 days, this happens between 2 and 4 days, where there is a lot of deposition of RBCs, neutrophils, and fibrin. And this is the red hepatization stage. When these RBCs are lysed, and also there is fibropurulent exudate in those areas, the lungs become a little grayish in color, and that is the gray hepatization stage, which is generally seen between 5 to 9 days. And following that, we have the resolution of the pneumonia. Bronchopneumonia. In this case, as we can see, infection starts in the bronchi, spreads as a patchy bilateral inflammation. Exudates fill the surrounding alveoli. The lung involvement, as I said, is patchy with several lobe involvement. Interstitial pneumonia is inflammation within the alveolar wall and the hyaline membrane lining the alveolar space. Lymphocyte and the macrophage infiltration can also be seen in these cases. Miliary usually occurs following the hematogenous spread to the lung. Produces multiple discrete lesions, usually throughout both the lungs. So this is the last slide for me, but I would want to say one thing. Once we understand the bacteria, once we understand the virus, that will guide us in terms of the clinical symptoms, as well as the investigations needed, and also the treatment part. So as Dr. Rawat sir and Dr. Subramania sir were discussing, it's just not the bacteria, it is the underlying cause has to be kept in mind while we think about a bacteriological agent. Thanks, and I would like to thank the respiratory chapter for giving me this opportunity to talk in this elite forum. Thank you.
Thank you, Dr. Manjunath. I think the basic issue is simple. Let me just take 1 minute of audience, and this being the TOT, I wanted to ask one question where I would expect all of you to type in the chat box.
I did not see, sir. In the chat box, somebody is saying that the slide is not clear.
No, it's visible.
Okay.
No, it's okay. We'll proceed further. What is the best way to establish the organism causing pneumonia? Can you type in the chat box? Because we have told so many organisms, virus, bacteria, this, that, etc. What is the best way to establish the organism? Somebody wrote blood culture, ball, age, ball, biopsy, culture, history and age. Best way is lung biopsy, ball, culture, nasopharyngeal swab, age, nutrition aspect, nasopharyngeal swab, age and predisposing condition, clinical assessment, malnutrition, film array, symptoms, genomic sequencing. Now tell me, if WHO or Government of India asks me what is the best way to do, is culture possible? Is ball possible? So therefore, my dear friends, your answer will be correct. There are 2 ways of answering. Being correct from scientific point of view, Because when you find organism at the site of pathology, that is the organism that is responsible for the pneumonia. Suppose you take a direct lung puncture at the site and you grow the organism, then you know, fine. Or go to bronchoscopy and get a wash, which we call as ball. And then, you know, that particular will liquid biopsy of the lung, it will grow that particular organism. Fair enough. We take sometimes a nasopharyngeal swab and try to guess that this probably the same must have been aspirated into the chest or progressed into that. Blood culture will tell you the bacteremic form of pneumonia. What about non-bacteremic form? Do you grow staphylococcus in the pus of empyema and the pneumonia? And can you grow the viruses? Can you grow the funguses? Did you understand? So therefore, my dear friends, I'm going to summarize it for you by telling that the organism till date is a guess. It is a bitter truth, and that's why we are not able to reduce the mortality, because all of us are guessing, and my guess may be better or less better or inferior to your guess. And therefore, the battle on infections as far as the organism is concerned continues to grow, but our approach right now is it's a function of age. For empirical therapy alone, not for escalation or de-escalation or being aggressive in the intensive care. Am I clear? Only for initial treatment of pneumonia. It is largely an epidemiological guess as well as a guess as a function of age. Are we clear on this concept? Okay, that takes me to the next question. Please type in the chat box. If there is a viral pneumonia, classical, I will say somebody has done all the study in that particular case, somebody has worked up. It's a viral pneumonia. There is a patch. Will you or will you not give antibiotics? Type yes if you want to give antibiotics. Type no if you don't want to give antibiotics. Now there is a mixed response. No, yes, no, yes, no, yes. So that means, did you understand, my dear friends? So much of confusion is there as far as viral pneumonia is concerned. See, viral pneumonia, when we say not viral airway disease, like bronchiolitis, bronchitis, croup, etc. Forget them. Viral airway, lower respiratory diseases of wheeze origin. I think, am I clear? If you forget them, I'm referring to parenchymal diseases. In that case, you will give antibiotics till we reduce under 5 mortality, because we don't know whether it is just virus or bacterial, given the amount of lack of robust scientific evidence that we have got. It's very, very difficult, my dear friends. Ultimately, the killer will be bacteria as well as the viruses. We do not know. So therefore, we are going to give antibiotics till our under 5 mortality falls significantly. And let's say deaths from pneumonia is less than 1%. Then let us all rationalize and say, okay, we will or we will not give antibiotics. Am I clear on the etiology? I think the etiology is largely a guess, but I would say a smart guess, a rational guess, and therefore it is not a guess. It's an approach. Point number one. Point number two is, whatever may be the etiology, you are going to hit hard. It is like just putting bomb in the Middle East. We don't know on whom it falls. And therefore, my dear friends, we are going to hit them hard and strong. That we are going to come little later. Now, the next challenge is whom to choose for hitting hard. That is by recognition and understanding of pneumonia as a disease. Now you are a clinician and you have to recognize the pneumonia, and recognition is by history and clinical examination, which sometimes is called as by signs and symptoms. And to make you understand that, I have with me Dr. Narayan Prasad Modi, who is one of the most enthusiastic pediatric pulmonologists. So Dr. Modi Saab, good morning, and you can start sharing your screen. A recognition of typical and atypical pneumonia. Modi sir, before I would hand over to you, only one line from me. As far as the atypical organism is concerned, it is not atypical organism, it is atypical organisms. So different organisms are going to be there, not one. So there won't, it is not like typical and atypical. So what is not typical is atypical, and there is not a single atypical. So therefore, I will hand it over to Dr. Narayan Prasad Modi.
Thank you, Subhu. Myself, Dr. Narayan Prasad Modi, and I bring hearty Diwali greetings from Odisha, land of Lord Jagannath. It's so humbling to be present before the likes of my teacher, Professor Radha Tripathi, Pallabda, Pramod Jog sir, Prakash Vaidya sir, and many more stalwarts and dear friends. At the outset, when Subramaniam sir started with pneumonia as a problem, what it is actually? Is it a disease or problem? That's a very, very pertinent point raised by Subramaniam sir. Is it social? Is it economical? Is it an administrative issue? Is it because of government? Is it because of nutrition, microbes? Is it a problem of medicine? It is in fact all. That's why anything the likes of pneumonia module or training on pneumonia has happened over the years, but because of the brainchild of IAP National Respiratory Chapter generally, and Subbu Bhai, I fondly call him as specifically. Now we have launched pneumonia module on World Pneumonia Day. And I personally would like to rename it as World No Pneumonia Day. Now, this is the most important aspect, recognition of pneumonia, both typical and atypical. As Subbu Bhai told, this is one of the most important part of the training about pneumonia, which helps us in all the areas that pneumonia is a problem of. Then what to recognize? We would discuss about the recognition of pneumonia as well as what are severe pneumonias, because those are the areas we suffer the most, highest socioeconomic burden is there, and we have high rate of morbidity and mortality. Then we should always be able to know about complicated pneumonia, what are the complications and how to pick them up, as well as what are atypical pneumonia. Why? Why recognition of pneumonia? From a broader perspective, it is to detect it early, to intervene timely and rationally, and the sole objective is to reduce morbidity and mortality, which was very ably told by our Rawat sir, to prevent antibiotic overuse. That is a very, very important aspect to pick up pneumonia and the types of pneumonia, and to prevent thus the development of antibiotic resistance. From the care point of view, practice point of view, why we want to recognize pneumonia? Because it is a challenge. There is a gross disparity amongst the continents, the geography, the infrastructure, the facilities available. So it has actually remained a challenge over centuries to diagnose pneumonia. Then there is no single sign or symptom which tells us about pneumonia that yes, it is diagnostic. Now you can stamp it as pneumonia. There is not a single sign or symptom. And above and everything, most sign symptoms, they are general and non-specific, especially in early age, in infancy. Then it is really difficult. We all have experience to have a detailed physical examination in infants. Now the four classic ways of examination is inspection, palpation, percussion, and auscultation. And we all know how difficult the palpation, percussion, and auscultation is in a child. And even the inspection also, because we know as soon as a child enters in our facility, the child starts crying and runs away. So it's difficult to have inspection also properly. So we have to fall upon the history given by the parents and caregivers. So the analysis of all these is a really will go a long way to pick up pneumonia. Then the signs and symptoms, they help in diagnosing severity, triaging of cases, and putting our priorities right in dealing with pneumonia. And some signs and symptoms like cyanosis, inability to feed, drink, grunt, CNS manifestations, they predict mortality in pneumonia also. Hence, it is important to know how to recognize pneumonia. Now, what are the symptoms and signs of pneumonia? We all know these are the most common symptoms and signs of pneumonia: fever, cough, fast breathing and difficult breathing, chest retractions, chest pain, crackles, and bronchial breath. Of all these, we all know these are the three most common symptoms and signs in pneumonia: fever, cough, tachypnea. And for decades, through World Health Organization, through different national medical bodies also, studies, we have been acquainted to pick up pneumonia, both at community and our health facility level, to diagnose, to recognize pneumonia from these three. But are they actually helpful? Do they really have a final say in picking up pneumonia? Fever, cough, and tachypnea. Now, the sensitivity and specificity of picking up pneumonia will be known from a likelihood ratio of about a particular sign or symptom. If the likelihood ratio is 2 or more, then the chances of having that pathology like pneumonia is more. And if the likelihood ratio is less than 0.5, then it has got a great negative predictive value. That means this sign or symptom doesn't have a say in picking up pneumonia. We can see from different studies, fever, the likelihood ratio is 1.7 to 1.8. But the absence of fever has got a more say, because the negative likelihood ratio is less than 0.5. So absence of fever has got a better say in picking up pneumonia. Negative predictive value is more than positive predictive value. Like the other two symptom sign also, cough and tachypnea, they have got a higher negative predictive value than positive predictive value. The absence is more important than the presence, because the presence will make us pick up false negative cases, false positive cases more than negative cases. Now, coming to the most specific symptoms and signs of these are chest pain, increased work of breathing, and hypoxemia. Chest pain, we must know, is the most important symptom that has got a highest positive predictive value, because the likelihood ratio is around 2, which I told is very, very significant. So of the symptom, chest pain is very important. Chest pain present means more likelihood of pneumonia. Then coming to work of breathing, we have got three areas in increased work of breathing, that is nasal flaring, chest retractions and indrawing, and grunt. These all have a high positive likelihood ratio, because they hover around 2 and more likelihood ratio. So if they are present, chances of pneumonia being present is very, very high. Then coming to hypoxemia, this is also very important. High positive predictive value, likelihood ratio is 2.8, that is very, very significant. And the absence also is important. If saturation is not less than 96. That means if it is more than 96, it decreases the chance of having pneumonia to a great extent. So it is very specific, high positive predictive value and high negative predictive value also. Now coming to the symptoms and signs that we have relied over years to diagnose pneumonia. All the respiratory noises, the sounds, we have relied on them for long, but studies have shown they have got a very, very less say in picking of pneumonia cases specifically. Crackles, rails, crepitations, wheeze, rhonchi, diminished breath sounds. No, they have got a lot of pathologies which will present with all these sounds. So we are not able to pick up pneumonia specifically. And we all can see from the slide and all the studies that the likelihood ratio is around 1 only. So the higher the likelihood, positive likelihood ratio, if it is goes around 2 and more, higher the predictability, the positive predictive value. Because it is around 1, so they have not got a specific say on diagnosis of pneumonia. Now coming to the physiology and some beautiful videos about the most specific symptoms and signs. I told increased work of breathing, that is tachypnea and chest indrawing retractions. Why it occurs? Because the lungs are solidified. Presence of fluid in the parenchyma alveoli, full of fluid. So lungs are unable to expand because there is consolidation causing loss of lung volume, reducing total lung capacity and total lung compliance. The child or the patient uses the respiratory effort more and more to pull in air into the lungs. Then why grunt? Because it helps not to collapse the lungs after the expiration. And there is a increased PEEP against a closed vocal cord to actually keep the lungs partially open. Hypoxia. Why it occurs? Because of intrapulmonary shunt, increased oxygen consumption of oxygen by lungs, and ventilation perfusion mismatch. Now, these are some of the videos. We will show it at the end of the presentation. Nasal flaring, chest retractions, and I tell you what, in chest retractions, by convention, we should mean by lower chest retractions, because intercostal chest retractions, they don't say much about the pneumonia or parenchymal involvement. It is the lower chest retraction, work of diaphragm, that says a lot about parenchymal involvement. And grunt, it is very, very important. It tells about severity, tells about mortality. Then hypoxemia, less than 96 is the cutoff, and less than 92 tells about a severe pneumonia. Now, how to recognize severe pneumonia cases? Because we all know that it is an indicator about the length of stay, complications of pneumonia, and mortality out of pneumonia. What are the indicators? Marked tachypnea. In infancy, more than 70, and beyond that, more than 50 is really, really significant. Poor feeding, refusal to feed, severe chest indrawing, and please mark this. This is lower chest indrawing. Cyanosis, grunt, head bobbing, it tells about CNS hypoxia, lethargy, convulsions, altered sensorium, severe malnutrition, and underlying chronic condition. Rawat sir already has emphasized the importance of nutrition and malnutrition. Severe malnutrition contributes to more than half of the mortalities out of pneumonia. It has got such a huge say in management of pneumonia. Then what are the studies of all this evidences about the analysis of symptoms and signs. This is one of the most important, the largest study was in 2017. This study is transcontinental. It involved both lower, middle, and higher income countries. It analyzed a host of symptoms and signs. We can see from this table that the higher sensitivity symptom signs, they have got less specificity, like cough, fever, tachypnea. High sensitivity, they are likely to pick up false positive cases, and the likelihood ratio is also less than 1.5. So they don't say specifically about pneumonia. Now coming to the respiratory sound, from this table it says that again the likelihood ratio positive and negative, they hover around 1.8 to 1. So they also don't say specifically about pneumonia. Now the lower half of the table, we can see that grunt, retractions, hypoxemia, they have got a very, very high specificity from 80 to 95%, and positive likelihood ratio anything from 2 to 2.8. That is really, really high and tells a lot about picking up pneumonia cases. This is another study in which my dear friend Dr. Rasmi is also a part. It's a multicentric study from India. This also says that cough, fever, and difficulty breathing, they don't have much say in picking up pneumonia, whereas chest indrawing, hypoxemia, and fast breathing, they are specific and they help us pick up pneumonia more and more. This is another study from PLOS, Avasthi et al. This also says that crackles or bronchial breath, their sensitivity is less and they have both positive predictive value and negative predictive value around 80%. But if we add chest röntgen, chest x-ray, then the negative predictive value goes up. It helps in ruling out pneumonia cases. This is the summary of many of the important studies. We can see that cough, fever, breathing difficulty, they don't say that sensitivity and specificity, they have got very, very less specificity. The second column is about specificity, whereas grunt, hypoxemia, chest indrawing, they say about a specific case of pneumonia. And likelihood ratio also of grunt, hypoxemia, and chest indrawing is more than 2. Now, when and how to pick up complicated pneumonia cases. So these are the, we must know about the complications of pneumonia. And this is a huge host of complications are there out of pneumonia, local complications and systemic. From local complications, we can have persistent pneumonia, necrotizing pneumonia, from pleural effusion, pericardial effusion, empyema, to pneumothorax, pneumothorax, bronchopleural fistula, and bronchiectasis. In systemic complications, we can have ARDS, septicemia, SAD, hemolytic uremic syndrome, disseminated intravascular coagulation, secondary thrombocytosis, meningitis, pyogenic arthritis, and metastatic abscess. How to pick up them? What are the indicators? So this one slide will help us picking up complicated pneumonia cases. When there is no response, we are giving adequate dose, appropriate antibiotic, but the pneumonia cases is not responding. There is suboptimal response, below expectation. There is recurrence of signs symptoms after initial response. So the child responded for the first 2-3 days. There was remission of fever, there was decrease in fast breathing, but after 3 days again, there is a spike of fever, increased respiratory rate, heart rate, hypoxemia, then we suspect complicated pneumonia. Recurrent pneumonia, lateralization of chest pain, diminished breath sounds, dullness or hyperresonance, copious foul blushed in sputum, sudden tachycardia and shock, sudden progressive pallor, cyanosis, new onset vomiting, irritability, altered sensorium, convulsion, joint swelling, pain and tenderness, So these all presentations will go a long way in making us diagnose a complicated pneumonia case, e.g. Now, how to recognize atypical pneumonia cases? We have to suspect. The high index of suspicion is very, very important. Atypical pneumonia cases, they are otherwise told older pneumonia, they are walking pneumonia, they are never serious. The child usually go on playing, doing his daily activities, and never serious. They usually occur in school-going age. Exposure to first-hand and second-hand smoke is a high risk factor for atypical pneumonia. Background chronic respiratory illness, again a risk factor. Immunodeficiency. Then what are the organisms and in which setting they cause atypical pneumonia? Schools, daycares, orphanages, barracks, mycoplasma is the culprit. Stagnant water resource exposure, Legionella pneumophila, and if the child is exposed to mammals frequently, persistently, then Chlamydophila, Francisella, and Coxiella are the organisms. Then how they occur? They are slower in onset and usually with a viral prodrome, because viruses, they actually disrupt the mucociliary blanket and helping those atypical microbes to invade the lung parenchyma. And usually they have constitutional symptoms and most importantly headache, malaise. Chest pain is another important factor. Dry cough. Dry cough is very, very important in atypical pneumonia, whereas in bacterial lobar pneumonia, we get wet cough majorly. Extra cardiopulmonary manifestation is one of the significant indicator for atypical pneumonia. If the child has got rash, bullous meningitis, we will suspect mycoplasma usually. And if the child has GI symptoms with dyselectrolytemia, then Legionella is the culprit. To summarize from the study, cough is an important factor at typical pneumonia, usually dry cough. Then coryza, because it starts with a viral illness, and crepitations. Absence of fever is a better predictor of, absence of wheeze is a better predictor of atypical pneumonia. Now, what are the poor predictors of pneumonia, both typical and atypical? What are the bad prognostic indicators? This is one study from India, Ramachandran et al. And PERS study, international study. Now, this table shows that age is an important factor. Infancy. Earlier the age with pneumonia, more is the severity and bad prognosis. Altered sensorium is complicated pneumonia. Like Rauts are told, malnutrition, wasting is one of the vital indicator for bad prognosis of pneumonia. The need for assisted ventilation and background illness. Any background illness, specifically and most commonly congenital heart disease and pneumonia cases are bad with bad prognosis. In atypical pneumonia, what are the bad prognostic indicators? Younger age, fever with a prolonged duration, then pleural effusion, extrapulmonary complications, diminished breath sound, oxygen requirement, of course, ICU admission and lower atelectasis. In a nutshell, revised WHO classification that focus on fever, fast breathing, lacks good sensitivity and specificity. Grunt, chest indrawing, lower half, hypoxemia less than 96, increased likelihood of pneumonia. Absence of cough and saturation of more than 96, decreased likelihood of pneumonia. Severe hypoxemia less than 92% and chest indrawing tells us about severe pneumonia. If we add all these physical sign symptoms, chest x-ray, then specificity and sensitivity of picking up pneumonia goes up. Infants, malnutrition, and altered sensorium increases mortality risk. Fever, tachycardia, chill, wheeze, consolidation, oxygen requirement predicts severe atypical pneumonia. And in recent years, we are seeing an increase of cases of viral pneumonia, mixed viral and bacterial pneumonia, necrotizing pneumonia, and drug resistant pneumonia cases. Thank you so much.
Thank you, Modi bhai, for that lucid presentation on signs and symptoms. I think all our participants have understood the importance of signs and symptoms apart from the way they have been taught in the medical colleges. I think let us understand that largely in for the medical students, we have been groomed to look at bronchial breathing, to look at euphoric breathing, these signs of consolidation, etc. They may or may not be present in children with pneumonia. Do you all agree on that point at least? Do you all agree? The classical teaching versus actual problem that we are seeing, there is a gap. Fantastic. So this gap was beautifully evident from the signs and symptoms. Please understand that some of the symptoms have very high negative predictive value. Some of the symptoms have good positive predictive value, but with false positives, especially these. So if I were to take one single sign and symptom based on which we in fact pivoted the whole of science around is tachypnea and fast breathing. Do you all agree? We have somehow been biased and overemphasized that entire uh, tachypnea as an exercise. Now I want just I can see 4 of the faculties. I want them to participate in a small exercise. Are you all ready, participants, for a small exercise? Will you all be ready? Please type ready, yes. Rawat sir also I can see. Sir, please participate in this small exercise. This is because everybody has to see now. Manjunath also is logging in, good. So all the faculties, I request you, just imagine, including the participants, please imagine that slowly the concentration of oxygen in your room is reducing from 21% to 16%, 15%, 14%. Did you understand? Either you might be choked or somebody puts nitrogen in your room. I don't know. I don't ask me the mechanism. Like, let me say slowly you are becoming hypoxic. You are realizing the threat. Now I am making you die slowly. Please understand. Now what will be your response? Please do that response. Don't, no words, please. Modi bhai, Rawat sir, please do that response. Everyone. Manju, you can't smile when you are dying. Okay. Right. I think Podar sir, I should give a hands to him for wonderful. I think, are you asphyxiated really there? I don't know, but he could do the best. Now, what I am trying to show you, please understand. No, there is a difference between getting a feel of this. There is 2 things that you have done. One, you have breath fast. Second, you have breath deep. Do you all agree? Modi, can you show both for all of us? Because you are the master of that signs and symptoms. So can you first breathe deep and show them how you can combat asphyxia? Breathe deep. Breathe in, breathe out. Breathe in, breathe out. Correct. Fine. Now you breathe fast only, but not deep. Shallow and fast. Are you all seeing both the physiology now? My dear friends, what happens in children is they can't breathe deep. They can only breathe fast. As an adult, Dr. Podar nicely brought out, somebody said we can't see. I think they want to see. Modi bhai, thoda camera ko adjust kar do. Haan. Now they want to see your chest. I think you are doing good exercise. Fine. Now you breathe deep first, like an adult. Breathe deep and fast. This is exactly what this is what you can see in an adult. I will also do. Okay. Now we will do shallow and rapid. That's what happens in children. Children are shallow breathers. Please understand. So therefore, my dear friends, the point which I wanted to tell all of you, please understand that in children, they are not capable of increasing their depth of respiration or the tidal volume. They are incapacitated. So therefore, only they can breathe fast. I mean, it's very easy for you. It's common sense. Breathing deep and breathing fast. Did you understand? Now, therefore, now tell me the newborn lung, a lung of 1-year-old, 2-year-old, 3-year-old, and an adolescent. Who will respond more by shallow breathing? Younger they are going to breathe more and more shallow. Older they are going to breathe deep and fast. So they will have only fast breathing in a newborn. So therefore, you take a smallest, youngest kid, the response is only tachypnea. So as they grow older, the tachypnea becomes less and less sensitive. So my dear friends, all that I wanted to tell you, you have been given diagrams of tachypnea definitions, more than 60, less than 59 days, and and 2 months onwards, you are given 50 as the cutoff point, and later you are given 40 as the cutoff point. Do you all understand why it is being given? It is because you are going to assess not pneumonia, not tachypnea. You are going to assess the degree of hypoxia as a function, and as a function of pneumonia as a function of hypoxia. Did you understand? So this is an effort, a compensatory effort by the child to combat ongoing hypoxia. In the worst forms of hypoxia, child may not breathe at all. So don't take only the count, and therefore count has a limit. Did you understand? So the apneas can come in. So therefore, suffice here for me to tell you the importance of tachypnea, which has an overall sensitivity and specificity of around 60%. It is not good. A good tool should be having a sensitivity and specificity close to 80 to 90%. So combined signs and symptoms will give you signs. The combined specificity of all the signs and symptoms will be close to 95 to 100%. Is that fine? A simple message for all of you. And what is most important for your last word? Let me take 58-day baby with respiratory rate of 59 and not coming in definition of tachypnea. Do you think it is fine? See, your definition of WHO is 60 and the child's count is 58 now. You say it's fine? No, I think you understood the point. Fine. Second is 3 months and 1 day old. Now, do you think just by 1 day you will go by the cutoff? No, please don't be very, very mathematical. Please understand the importance of tachypnea, understand the physiology. Don't go only by tables. Please measure the tachypnea from lots and lots of common sense that you are going to apply. I would be very happy if the respiratory chapter and all the group of pediatricians come out with age-dependent chart of respiratory rate for children rather than the cutoff values. I think that's fine, like growth charts. No, we don't go by formulas. We grow by 2 standard deviation away from the normal, either up or low. Do you all agree? So definition of tachypnea should ideally be on a chart versus age based on and in a child which is otherwise fine. Now, do you think a malnourished child will breathe fast? So you have to count grace of 5 for a malnourished child. For all those definitions, earlier by 5 only, you should consider it as severe. See, for example, it's 60, 55 only. If it is 50, 45 only, even 40, I don't mind. Severe malnutrition, don't expect it to breathe so fast. It may not breathe fast. Lastly, all these things are because of accessory muscles working, and lungs are becoming stiff and stiff because of fluid filled and reduced compliance, and therefore the elasticity is lost. So it cannot expand. So when it can breathe deep is when you can expand. It can breathe deep. When it cannot expand, when it is solid, it can only rock. And that is the physiology of tachypnea, my dear friends, and that explains all the signs and symptoms. Beyond the lungs, you can see accessory muscles acting, alanase acting. Somebody was asking mechanism of head bobbing, and I will tell you, alanase starts first, and then the head bobbing starts, largely head drops, and this is related to severity of hypoxia. And there was a question I will quickly answer. If you have SpO2 of 93, head bobbing is seen 25%. If you have SpO2 of 90, head bobbing is seen 50%. If you have SpO2 of less than 85, head bobbing is seen to the tune of 50% and above. So that means every alternate child will have head bobbing. So this is related to degree of what should I say, altered sensorium or depression that the child has to undergo by degree of hypoxia. Am I clear? So it is because the accessory muscles like these head drops and accessory muscles, are working, so keeps tight, and again it drops, keeps tight. That ultimately it fatigues. So final head drops. I think I have explained you the mechanism. So don't worry about those causes of tachypnea, which are because of fever and also wheezing. Please separate them out. You are smart pediatrician who can differentiate the diseases of mimics of pneumonia from pneumonia. So this summarizes. Lastly, let me come to you to the next important session. Do you think I will ask you two questions for you before we go to Dr. Rashmi Ranjan Das. That question is an introduction for the next talk. Do the children from pneumonia die, or do the children from severe pneumonia die? Even if you don't recognize pneumonia, it could be fine, but the severe ones die. And it is not pardonable if we can't recognize severe pneumonia. So therefore, my dear friend, Modi has told you how to recognize pneumonia. What are the predictors of mortality? I will take you through Rashmi Ranjan Das. And can you applaud for this youngster? Please type CLAP. He has been instrumental in, we have spent nights up to 2 a.m., 3 a.m. with him in making this module. Rashmi, can you recollect all the days where we have slept late and, got up very early in the morning for some other reason? So we have worked day and night. So therefore, he has also been involved in some of the original studies on pneumonia, Rashmi. So we have sat together, chatted, and not just that, we have fought on many issues. Don't think these slides have come out just like that. They have been discussed quite well and over day and night of effort. So therefore, I'm taking you to the next part, which is the crux of the matter. Even if you have not understood anything else, please understand on this. Assessment of severity. And severity assessment is the only way you can prevent death from pneumonia. And severity assessment is required because you need to know whether you should keep your child in the nursing home or refer it off, wash off your hands, send it elsewhere, for better care. Or you must also be able to sense and predict who are the ones whom I can't handle. Please understand. So this takes me to two topics which he is going to cover now: assessment of severity and triaging of pneumonia, and classification of pneumonia also. Because somebody was asking about bronchopneumonia, lobar pneumonia, this pneumonia, that pneumonia. I will tell you there are 101 names for pneumonia. Don't worry about them. And he's also going to tell you what it means to us as far as classification is concerned. So over to you, Rashmi, the youngster, and Chote Bhai for severity assessment, classification, and triaging. Thank you.
Thank you, sir, for your kind words. A very good morning and happy Diwali to all the dignitaries and faculties on the screen as well as off the screen. My special thanks to IAP National Respiratory Chapter President Dr. Jagdish Chinappa sir, Honorary Secretary Dr. Subramania sir, and Central IAP President Bakul Parekh sir, Honorary Secretary Basabraj sir. Actually, this pneumonia in children module, it is the brainchild of Subramania sir. What you are seeing, it is the offshoot of faculties. They have worked day and night to make it possible. My heartfelt thanks to them. And dear friends, I will also thank Rawat sir, Dr. Manjunath, Modi sir, for opening the avenue and setting the stage so that it will be easy for me to discuss subsequently. As Dr. Subramania told, I'll be telling first on how to assess the severity of pneumonia, followed by triaging. So this severity of pneumonia assessment is just a classification. Sorry. So just to recapitulate, all of us know this is not a new thing. You can classify pneumonia in many different ways. Okay. So anatomically, it is classified as lobar when a lobe is involved, or it is a bronchopneumonia when you are getting patchy bilateral opacities in the bilateral lung fields, or a interstitial pneumonia when the parenchyma is spared and the interstitium is involved. Again, you can subclassify this interstitial pneumonia into three types, that is reticular, nodular, and biliary. Okay. So coming to the etiological classification, already it has been outlined extensively by Dr. Manjunath. So the pneumonia could be caused by bacteria or viruses or fungus or some rare organism including parasites. Based on the host factors, you can classify pneumonia into two types, whether they are occurring in immune competent child or immune compromised child, because your approach to them and management will be different, because if the child is immunocompromised, so chance of developing severe pneumonia and mortality will be very, very high. So clinically, we can classify pneumonia into whether it is a community acquired pneumonia or a hospital acquired pneumonia. I'll discuss in detail in subsequent slides. Community acquired pneumonia, you can further classify into typical if it is caused by bacteria, or atypical if it is caused by your atypical organism or the viruses. Hospital acquired pneumonia can be subclassified into early if it is occurring within 40 to 96 hours of hospital admission, or after 96 hours if it is occurring after that point of time. And community acquired pneumonia is further classified into non-severe or severe pneumonia. Please remember, hospital acquired pneumonia has only category, it is severe unless until proven. So how to assess the severity? As Dr. Subramanian was telling, almost nearly all cause of death in pneumonia is because of severe pneumonia or severe disease. So whenever you are dealing with a child, you have to identify early and refer early if you are not able to manage at your setting. Late referral or poor identification or late identification is the most common underlying cause of mortality in a child with severe pneumonia. In the early 80s, to reduce mortality from pneumonia, what the World Health Organization did, they used some simple clinical signs and symptoms that can even recognized by the grassroots worker, including ASHA workers, to classify children into 4 categories. One is no pneumonia if the child is having only cough and cold, pneumonia if there is a specific fast breathing, severe pneumonia if there is lower chest injury, and very severe pneumonia if any danger sign is present. Child may be lethargic, he may be having cyanosis, there is poor feeding, or the child is unconscious. This old WHO guideline was followed until 2014, during which time WHO came up with a new or revised guideline. This was possible after publication of 2 landmark studies in the prestigious journal Lancet. Both the studies were conducted in Pakistan and multi-center studies. The first one is API study, that is amoxicillin, penicillin, pneumonia international study, and the second study is new outpatient short course home oral therapy for severe pneumonia. So API study and MOSAR study. These 2 studies found that oral amoxicillin is better than oral cotrimoxazole for fast breathing pneumonia. Oral amoxicillin is equivalent to injectable penicillin or ampicillin for chest injury pneumonia. So as you can see, if oral amoxicillin is very effective for both categories of pneumonia, there is no point in separating these into these categories. Okay, so that's why WHO clubbed this pneumonia and severe pneumonia into one category and recoined the name as pneumonia. Okay, so now we have 2 categories. One is non-severe pneumonia, second is the severe pneumonia. Some people also use an alternative term like severe oblique very severe, but for uniformity, please remember it is severe pneumonia. So this is the new WHO classification. Whenever you are dealing a child in the age group of 3 to 59 months, if the child is having only cough and cold, you tell it as no pneumonia, you advise home care. If the child is having fast breathing and or chest infection, it will be pneumonia. So you have to prescribe amoxicillin and send the child home. Then you have to follow the child after 48 hours or whenever it is required. When any danger sign is present, as I outlined, or there is hypoxia with oxygen saturation of less than 92%, you have to classify the child is having severe pneumonia. If you are working in a referral facility, you give fast dose of antimicrobial and immediately refer the child. And if you are working in a facility level, there is no problem, you can manage the child. So already I have outlined the reason why the old and new were merged. Still, after the publication of this new guideline, there were some criticism. A study conducted in Kenya included almost 16,000 children with non-severe pneumonia, and they tested the external validity of the revised WHO classification. External validity means they sought to find how this new WHO classification is performing in the community. Okay, that is very, very important. That is applicable to all the studies. So whenever a study is being done, that is conducted in the community to see how it is performing. So if it is a clinical trial, we tell it as a phase 4 clinical trial. Okay, that is an example. So they found that this malnutrition or pallor was associated with increased mortality in children with non-severe pneumonia. So the author suggested that the WHO should take a call and include these two signs in any children having non-severe pneumonia if they want to decrease mortality. So I am quite hopeful that in future WHO may include these two simple signs into the classification system just to reduce mortality from pneumonia. So already we have discussed, please remember severe pneumonia not necessarily always be a community acquired pneumonia. Hospital acquired pneumonia and ventilator associated pneumonia, they are always assessed as severe. There is no non-severe pneumonia category for both hospital and community acquired. So hospital acquired pneumonia, all of us know, whenever a child is getting admitted to hospital and he develops pneumonia more than equal to 48 hours of admission, you tell it is hospital acquired pneumonia. Early onset, if it occurs within 40 to 96 hours. Why it is important? Because the organism are originated from the community. So it will help you in deciding the empirical antibiotic till you get the culture report. Late onset means the pneumonia has started after 96 hours of hospitalization. So this time you have to think of that the child has developed pneumonia and the etiological organism may be as per your hospital setting. So it will help you in deciding the empirical antibiotic. So ventilator associated pneumonia, when the child is on ventilator and spend more than equal to 48 hours. And there is a new term that has been coined by this Center of Disease Control, that is CDC. This is healthcare associated pneumonia. So this tells that child need not to be hospitalized. So any ambulatory child who has extensive healthcare contact within 3 months. For example, a child is having leukemia. Okay, so he has taken intensive therapy. Now he has been discharged. So for subsequent maintenance therapy, he has to be admitted on a daycare basis and take chemotherapy. So this fits into a case of hospital, your healthcare associated pneumonia if this child develops pneumonia. So this is one of the examples. So coming to the case definition of hospital acquired pneumonia. In 2017, CDC defined hospital acquired pneumonia in adults. It didn't define directly for the children. So what classification I'll be telling you, it is the extrapolation of the CDC classification. Okay, so the definition has been taken from the adults. So it has been divided into two age groups. One is infant, that is less than 1 year, and other are children more than 1 year. So in infant, we have three major criteria to define hospital acquired pneumonia. First one is the radiological criteria. Out should be there should be one. So the four criteria are new or progressive infiltrate, or a consolidation, or a cavitation, or a nematocele. One has to present. Plus increase in oxygen or ventilator requirement, plus three of the following clinical criteria. So out of the following, like fever or hypothermia, leukopenia or leukocytosis, and more than equal to 10% immature forms, new onset or increase or change in respiratory secretion, Okay, so it was initially suppose serous, now it has become purulent, or there is a change in the color. That is important. New onset or worsening respiratory symptoms. Okay, so there may be increase in cough, there may be worsening respiratory distress also. Auscultatory findings, suppose you are getting new onset wheezing, rales or rhonchi, and if there is bradycardia, heart rate of less than 100, or tachycardia that is more than 170. So this will define hospital acquired pneumonia in infants. Whereas in children, we have two sets of criteria. Okay, the radiological criteria, out of 4, only 3 is there. There is no nematocele in children more than 1 year. So the 3 criteria are new or progressive infiltrate, consolidation or cavitation. So out of this, only 1 has to be present, plus 3 of the following criteria. So there may be fever or hypothermia, leukopenia or leukocytosis. There is no immature cell in this children of more than 1 year. New onset or increase or change in respiratory secretions. New onset or worsening respiratory symptoms. Auscultatory findings that may include wheezing, rales and rhonchi. So increase in oxygen or ventilator requirement. So here there is no bradycardia or tachycardia. So this will tell you whether it's a child more than 1 year is having hospital acquired pneumonia or not. So to summarize so far, majority of death are due to severe pneumonia. So severe pneumonia needs to be picked up early by the simple clinical signs and symptoms as outlined by Dr. Modi. You have to remember that WHO classification system, it is not very less than 60% almost, but if you add oxygen saturation of less than 92%, that will fairly increase the sensitivity specificity. So WHO has told that every facility should have pulse oximeter even at the community setting, and before referring the presence of severe one. Revised WHO classification include only 2 categories as of now: non-severe pneumonia, that is fast breathing and or chest injury, and severe pneumonia, that is presence of any danger sign or hypoxia. Please remember, presence of malnutrition or pallor may need referral in non-severe cases. This has not been incorporated in this new WHO guideline, but in future it may be incorporated. And hospital acquired pneumonia is defined as pneumonia occurring after more than equal to 48 hours after admission, and ventilator associated pneumonia more than equal to 48 hours after intubation and mechanical ventilation. So now we have discussed how to assess the severity. So let us discuss how to triage a child with pneumonia. This is one of the most important topics. So that is of interest to general practitioners as well as to the specialists who are dealing children with pneumonia. So why triaging is important? We have already emphasized why severity classification is important, because severe pneumonia is the most common cause of death in children with pneumonia. So once you classify the severity, you can easily decide whether the child will require home treatment or hospital treatment. So if it is a non-severe pneumonia, naturally you have to send the child home. Or if it is severe pneumonia, you have to hospitalize the child. If you are working in a hospital setting, or you have to refer the child, you are working at a referral facility. So triaging essentially means you have to assess the child, you have to stabilize the child before referral, and you have to manage the child during hospitalization. Finally, you have to look for the outcomes and follow up the child once it is discharged. So all these will be easily guided by your triaging. So triaging depends upon basically where you are working. This is very, very important. You may be working at a referral level with poor infrastructure and resource setting, or you may be working at a facility level. So whatever level you are working, whenever a child comes, you have to look at the age of the child, whether the child is less than 90 days or 3 months, or he is more than 3 months up to 5 years of age. Why? Because your etiology will be different in this age group, as Dr. Manjunath has told. Please remember, etiology of pneumonia is a function of age. As the age will vary, etiology will vary. And second important point, small children, that is young infant, they deteriorate quickly and they may die. So you can ask, in the original WHO classification, the age group is less than 2 months. Why you have taken 3 months? So we discussed extensively in our meeting, as Dr. Subramanian was telling. WHO defined young infants as less than 90 days. Okay, if it is young infant, so you have to be very careful. So the only respiratory rate should not compel you or guide you to manage a child with pneumonia. You have to look for other factors. So So what are the coming to the steps of triaging? So there are essentially 4 steps. You can just recall GINA. In GINA, there are 3 steps. So what are those steps? You have to assess, you have to adjust, you have to review response. So we have gone one step ahead because pneumonia is a common cause of mortality. In asthma, hardly any mortality occurs. So there are 4 steps. Okay. So pneumonia is the big brother of asthma. So what are those 4 steps? You have to recognize pneumonia by using simple signs and symptoms. Already this has been elaborated by Modi sir. So after going through the module, I don't think you will have difficulty in recognizing a child with severe pneumonia. Once you have recognized pneumonia, you assess the severity, whether it is a non-severe pneumonia or severe pneumonia. Okay, it is very easy. Only there are 2 categories. So after you categorize or assess, you manage the child depending upon your in which facility you are working. So after that, you reassess the child and revise your next plan or next course of action. So let us discuss one by one. So triaging in less than 3 months or 90 days old. So if you are working at a referral level, you have to assess for fast breathing. Fast breathing is defined as more than equal to 60 per minute. You have to assess for severe chest injury. Please remember, mild chest injury is common in young infants because of the compliant of the chest pal is very compliant. Okay, so mild chest injury is common, but severe chest injury is problematic. Then, if the child is having grunting, hypoxia, poor feeding, or lethargy, if these signs are present, you will assess that the child is having severe pneumonia. So if you are working at the referral level, you have to refer the child. But before that, you have to take care of some simple things. First, maintain temperature. Prevent hypoglycemia during transport. So if the child is feeding, you can ask the mother to breastfeed. If the child is not able to suck at breast, but is alert, you can give expressed breast milk. If nothing is available, you can give simple sugar water at the rate of 10 ml per kg. And you have to give pre-referral antibiotic, that is injection ampicillin plus gentamicin, and then refer the child. So how to refer it, I will tell you in the last slide. So if you are working at a facility level, again, you have to assess those signs and symptoms, okay, like signs of respiratory distress, hypoxia, cyanosis, poor feed, and lethargy. So if the child is having severe pneumonia, you have to admit the child, give oxygen. Even if the child is maintaining saturation, please remember you have to give always oxygen in children with severe disease, because oxygen is the saturation is the last thing to fall. So don't wait for the child to develop hypoxia. You have to provide supportive treatment, that is very essential for the outcome of the child, and give injectable antibiotic. You can start with Ampi and Genta, and based on hospital policy, you have to change the antibiotic subsequently. Add cloxacillin if you are suspecting staph aureus. Okay, suppose the child is having boil or the child is having some cellulitis, any marker of presumptive staphylococcal infection, immediately add cloxacillin. So after that, you reassess the child. If the child show no signs of improvement after 48 hours or worsening at any time, rule out complications, either a air leak, that is pneumothorax, or a empyema. So it is mandatory that whenever you are admitting a child, you have to do a X-ray. So baseline X-ray is mandatory. But in home management, routine management, there is no role of X-ray. So if you have not done X-ray, you do X-ray. If you have already done X-ray, you can easily see whether the child is improving or not, or their complications. So then you have to revise your treatment plan. Okay, so the child may be harboring one organism which is not responding to your antibiotic. So you may change the antibiotic. Suppose there is a empyema. So again, you have to change your antibiotic. You may have to put a chest tube. If there is a pneumothorax, you have to drain it. So coming to triaging in children of 3 to 59 months. So if you are working at referral level, you have to assess for fast breathing. In children of 3 to 11 months, fast breathing is more than 50 per minute, and those more than or equal to 1 year, it is more than 40 per minute. You look for chest injury, hypoxia, or any general danger sign. That includes stridor, grunting or head bobbing, poor feeding, lethargy, convulsion, unconscious, or severe malnutrition. So you assess as non-severe pneumonia if the child is having only fast breathing and or lower chest injury but no hypoxia. Presence of any danger sign or hypoxia will upgrade the assessment into severe pneumonia. So as you are working in a referral facility, you have to refer the child to a facility level. So you have to take care of simple things. Give paracetamol if the child has fever at referral. Give bronchodilator if only there is a audible wheeze or past history of wheeze. Please remember, pneumonia is a parenchymal disease. It is not a primarily airway disease. Okay, so there should not be wheeze actually in pneumonia. So there is no routine use of bronchodilator because cough occurs because of some other mechanism. It is not because of bronchoconstriction. So no left and right use of bronchodilator. But if there is marked wheeze, child has already history of taking nebulization, or you are thinking it may be multi-trigger wheeze or asthma, then only use the bronchodilator. Because if you use bronchodilator that is not required, it may increase the heart rate. So once there is tachycardia, so you will have a problem in the assessment whether the child is having non-severe or severe pneumonia. You may be thinking that the child may be going into shock, also early shock, because the child is having tachycardia. So you have to be very careful while using bronchodilator. Then give pre-referral medication, injection ampicillin or penicillin plus gentamicin or amoxicillin. Oral amoxicillin 25 milligram per kg per dose. So this is the start dose you have to give if there is problem in putting the IV line. Okay, so that is one option. Or you may give oral amoxicillin. Suppose the child you have assessed the child is having severe pneumonia, but the parents are reluctant to go to the higher center. They are telling we will not go, we'll stay at home. Whatever will happen to the child will be responsible for that. So in those cases, what you can do, you can give oral amoxicillin 25 milligram per kg per dose. Okay, in 2 divided doses. Then you have to follow the child. Okay, so at any point of time the child is worsening, you have to explain the parents and immediately refer. But oral amoxicillin is not the first line treatment, has to be given at a referral setting. That you have to remember. Only in compelling situations you have to give. So at facility level, you have to check for airway, breathing, circulation, check for the clinical signs. As I told, you auscultate the child, look for air entry or presence of any added sounds. Then you assess whether the child, because whenever a child is coming to facility level, you assume that the child may have severe pneumonia. Okay. So you naturally have to admit the child, start oxygen inhalation, do a chest X-ray, give supportive treatment, and start injectable antibiotics, ampicillin plus gentamicin. Then you can upgrade or change as per your hospital policy or facility level policy. Add cloxacillin if any signs of staph infection is present. So after 48 hours, you have to reassess. You may reassess SOS. Whenever there is worsening, you have to reassess the child. Okay, rule out complications. That includes air leak and empyema. And also look for the bug. It may be a different bug that is not responding to your primary antibiotic. So you have to revise treatment accordingly. If you have a very good investigation facility, you have a biofire, something like that, you can easily identify the organism and start treatment accordingly. So now coming to when and how to refer. This is very, very important. This is important for those who are working at the referral level. Okay. So these are the signs and symptoms that will tell you that you have to immediately refer the child. Okay. Presence of marked tachypnea more than 70 per minute in infants and more than 50 per minute in children. This is as per the British Thoracic Guideline. This has already been told by Dr. Modi. Second is poor feeding or refusal to feed, severe chest injury in infants, cyanosis, grunting, head bobbing, lethargy, convulsion, the child is unconscious, or there is presence of severe malnutrition or any underlying chronic condition. Please remember, if your child is having chronic underlying condition, it is better to refer to the child because you don't know the child may because these children have a poor physiological reserve because of underlying disease. So pneumonia is an additional burden on them, so they may not tolerate. Okay, so if you want or if you cannot manage the child at your level, better to refer the child early. So how to refer? This is very, very important. Please remember, many children they die on the way or when they reach the facility because the referral was not good and it was not a timely referral. So if you start treatment early, recognize early, your referral is very good. You can nearly save 99% of children with severe pneumonia also. So how to refer? So first you have to prepare the child. For that you have to stabilize the child, take care of temperature, airway, breathing. Suppose the child is having severe stridor, you think that during a referral he may collapse or he may develop apnea. So you have to intubate the child and send. Okay. Look for the circulation, whether the child is having tachycardia or having a prolonged CRT. He may be in early shock. So you give fluid bolus or you may start ionodrop and refer the child. Please do not directly send the child without starting taking care of this airway, breathing and circulation. So blood sugar you have to see, because these children are sick, their oral intake is very less, so they have a high chance of hypoglycemia. Okay, so you have to take care of that. As I told you, may give breastfeeding, expressed breast milk or some fluid also if the child is accepting orally. If not, you have to start intravenous fluid after putting IV line. So give fast dose of antibiotics, oxygen if you require. But please remember, whenever you are referring the child, always send oxygen with the child. Okay, it is better to put the child in the oxygen, because you don't know how much time they will spend while reaching a hospital. Sometimes they may be kind of trapped in a heavy traffic jam. So you know you are referring to a hospital which is just half an hour away, but there is a traffic jam. There is some problem, so they may stuck up there for 6 hours. So then there will be a problem. So always send the child with oxygen if the child is having severe pneumonia. So then before sending, prepare for the transport, counsel the parents and family, explain them all the details of the child, what are the possible course, why you are referring, okay, so that they will also understand in decision making. And if something untoward happen also later, they will not blame you, or they will not kind of take some action against you. Okay, communication with and write a referral note also. So it is always a good idea, whenever you are referring a child to a facility, always pre-communicate with the doctor. Tell them, okay, this is the condition of the child, what is the physiological status, whether he is requiring an oxygen, whether he is requiring on inotropes, whether he will require ventilation at arrival or not, so that they will be prepared, and whenever the child reaches the hospital, without any delay, he will be taken care of. So if you take care of all these small things, the survival of the child will increase dramatically. Okay, and there will be no medical legal issue. So there is no role of verbal communication. It is always a written communication. For anything you do, you always document and write. So that will also help you medical legally. Arrange a trained personnel who has already experience of transport, because transport is not a kind of easy job. So somebody has to be there who has already exposure, previously has transported sick children. And if nobody is there, you have to explain to the mother and relative to accompany. Okay, okay, what are the things they have to take care of during transport. And you may give your phone number also. Suppose any problem occur, they will communicate before they reach the facility level. Assemble supplies and equipments including oxygen source and cylinder. Please do not send a half cylinder. Whenever you are referring, as I told you, send with a full cylinder, because you don't know, there may be a tire puncture on the way. They may get trapped in a traffic also. So all the oxygen will be exhausted and the child may die on the way. So then you know what will happen if the child die during referral. Okay, until the child is received in a good condition at the facility level, all the onus is on you. So you have to be very careful. So care during transport, monitor frequently, uh, monitor the vitals, IV cannula, fluid and infusion and oxygen if a trained person is ongoing. Otherwise, you have to explain the mother and relatives what are the things they have to look for while transporting the child. So to summarize so far, triaging done to classify the severity and decide whether the child will require a domiciliary treatment or a hospitalization. Severe pneumonia at referral level, if the child is less than 3 months, fast dose of antimicrobial, feeding advice and temperature maintenance has to be done. And in children 3 to 59 months, bronchodilator you have to give if there is documented wheeze or history of asthma or a multi-trigger wheeze, along with fast dose of antibiotics. At facility level, so take care of all the problems the child have, give antibiotics, oxygen and supportive care. If there is no response after 48 hours, rule out complications and revise your treatment plan. So thank you for your patience hearing. If there is any question, we will take. Thank you so much.
Thank you, Dr. Rashmi, for that wonderful deliberations on triaging, assessment of severity and classifications. Let me, Rashmi, if you can stop sharing the screen.
Yes, sir. Yes, sir. Yes, sir.
Yeah, thank you. See, basically, when we started the module, let me also tell the viewers here, because many of you are going to be the trainers in future. We had a lot of dilemma, including myself, as far as the vision is concerned, and the mission, with which mission means mission of the slides, with which way we go. Because already we have ARI guidelines by WHO and Government of India on assessment of severity. And what else we have got in the pot? Did you understand? So there are IMNCI guidelines, etc. Now the point was that there was a kind of feel from the pediatricians that is for the health workers, not for us. That is for the PHCs and government doctors, not for us, etc. And they were assessing in their own style. Do you all agree? Assessment of severity is based on whether I can manage or I can't manage, rather than what is the assessment of pneumonia as such. So again, coming to assessment and categorization of pneumonia on an uniform basis, we have taken a challenge, and this set of slides is some kind of hybrid between the WHOs and non-WHOs. Did you understand? So that's the balance that we have struck so far. And let me tell you what was the WHO thinking before 2014 was no pneumonia, pneumonia, severe pneumonia, and very severe disease. All of us, do you remember? All of us, you remember, isn't it? Now, there was an interesting study which was published in New England Journal of Medicine from wonderful scientists from Karachi, which involved around 4,002 children who challenged the need for hospitalization and intravenous antibiotics in children with chest retractions. Am I clear? Did you understand? Suppose a child has chest retractions. Can I be bold to give oral antibiotics? That study proved that yes, you can give oral antibiotics. So therefore, when we can give oral antibiotics and save the child, particularly amoxicillin, do you want to call it as severe pneumonia? From monitoring perspective, whether it is severe or non-severe, or whether it is severe or just pneumonia, you have to just keep on monitoring. There is no excuse. Please don't think that by telling a pneumonia non-severe or just pneumonia word, it does not mean you can be complacent. Absolutely no. Any pneumonia can become severe little later on. So therefore, my dear friends, it is not about monitoring. It is about initial empirical choice of antibiotics. Can I give oral antibiotics, and can I give cost-effective amoxicillin orally? So therefore, that study was a breakthrough study. I want all of you to please open up WHO pages and read completely the background papers of guidelines on pneumonia. It is just around 50 pages, and it will just take one day for you to read. And you can browse through. You need not read every word of it. The beauty of that on the website of WHO says, let me give you the gist of it, that the children with minimal chest retractions can yet be managed on oral amoxicillin. So therefore, that takes me to a categorization of pneumonia into two. One, those pneumonias in whom I can manage with oral amoxicillin. Those pneumonias who should be managed beyond just oral amoxicillin. I'm too, what should I say, too simplistic in categorizing them into two categories, amoxicillin responsive and probably amoxicillin may not be responsive pneumonias. You understand? Or may not be just enough. The second thing about WHO studies also is that we don't want any failures of amoxicillin. See, first you give amoxicillin. Don't give half-hearted and fail. So there are studies which say compare dose of 40 milligram per kg with 80 milligram per kg of amoxicillin. And please permit me, for want of time, I'm going to discuss that after Dr. Usha Rani's presentation. What should be the dose of amoxicillin? Please ask me in the chat box, remind me, and I will give you the logic. The idea was that the studies were very few, 2 or 3, not many studies. And what they said was that we don't want to fail with lower doses of amoxicillin. And the resistance to amoxicillin across the globe varies, and therefore WHO authorities can't give an uniform guidelines on doses of amoxicillin. So they were erring on the safer side of higher doses of amoxicillin, but the evidences were lacking. So still we are stuck with lower doses of amoxicillin. And I will explain you the complete rationale of doses of amoxicillin. It will be discussed in the treatment section. Okay. Now, lastly, all that I wanted to tell you from triaging is, Please identify those children who are less than 3 months. They are not pneumonia, they are just sepsis. They have to be hospitalized and managed as inpatients. Is this point number 1 clear? Triaging and assessment. Either treat if you are capable or refer. Number 2, all cases of hospital-acquired pneumonia until proved otherwise are severe. Fine. Third, all pneumonias in an immunocompromised host like malnutrition or otherwise are severe. Don't bargain antibiotics or your aggression of management on any one of them. So suffice for me to tell you that in other cases, it does not mean that you can be complacent. Now, let us freeze our thoughts on recognition and assessment of severity here. Just to recapitulate from morning what we have done. We have understood the problem. We have enhanced our knowledge and skills to diagnose pneumonia. We have sensitized ourselves to recognize pneumonia and assessment of severity. And last line from me is assessment of severity of pneumonia is best done by assessment of severity by saturations by pulse oximetry. It's a beautiful tool, and we are going to come out with some kind of guidelines on pulse oximetry, cutoff values. We will just read some more references before we come out with proper cutoffs for you. Just before we finish the module only, we'll give you the references and we'll update you. But what I wanted to tell you, why define 94, 92, 93? Why you bother? Understand oxygen dissociation curve. You know, up to 90 or so, it's fine. But afterwards, the saturations don't mean anything. Even 1% drop will mean a huge difference in the PaO2. Did you understand the point? If you recollect your oxygen dissociation curve, I don't think I have to explain you pulse oximetry. Second, a child is 99 on pneumonia on pulse oximetry. After 4 hours, it becomes 97. What was 99 has become 97 or 96. You think it is safe? No, it is not a value. It is the trend. So serial assessment of pulse oximetry will give you the trend of worsening severity in pneumonia than any time one reading of pulse oximetry as a cutoff. Can this be a strong message? Do you all agree on this point? Let's say, sir, it is 93 now. It's above the definition of 92. No. Please don't be after numbers. All of you want numbers from us. See, number is a gamble. Trend is the reality. The trend of pulse oximetry in a given child is the reality of progression of the disease. And I think we have given very good messages for you. Now, we have done recognition. We have done the diagnosis. We have assessed the severity. Now, the biggest challenge for all of you is to investigate or not to investigate. Let's know all the investigations first. And I will tell you, the next session is an academic treat for you. It's mouth watering. And Dr. Suman Podar has done wonderful efforts to make those slides. And we will bring you the investigations from Dr. Podar. You are in the next session, no? Correct? So Dr. Podar, welcome to you. Just go through the investigations now. And let me come to you with a couple of words of wisdom at the end of the investigations for you. We will go through investigations in general and X-ray, ultrasound and CT. And at the end of all the sessions, let me come back to you with role of investigations. Is that fair enough? Okay, over to Dr. Podar, sir.
Thank you, sir. Am I?
Yes, screen is visible and you are audible.
It's a visible or audible.
Yeah.
Okay. Thank you, Subramania, sir. Thank you. Yes, I have done a part of it, and it has been immense pleasure to be a part of this IIP respiratory chapter. A very warm regards from the heart of Kolkata. So the investigations, we all know that pneumonia is a clinical diagnosis. Mostly it's a clinical. We have been knowing how to triaging this and how to recognize pneumonia and all these things. Now, when to investigate and what are the things that we look for? So the learning objectives or the main crux of this part is the basic and advanced laboratory investigation, the chest x-ray, how to read and interpret, and what are the findings in various types of pneumonias, USG chest, the basic. Nowadays, USG is coming up with a huge potency that it can be used in a lot of cases as a point of care test as well, and how to interpret the basic USG chest. Then comes the CT indications and findings in various pneumonias. Let's go with the lab data first. So there are two types of investigations. One is to confirm the etiology. And the other part is to know how the patient is behaving. So monitoring of the patient and the supportive evidence. So we are all aware that antimicrobial resistance is creeping up. So it gives little more confidence if we know the etiology better. And also in today's era of consumer forum, we are very much afraid of the patient associates. We don't know which patient is going to where. So supportive evidence, monitoring, and always, I would say, documentation. That is very, very important, especially in the severe pneumonia cases. To come with the first part is the CBC, the basic one, CBC. But as I have already said, and also my previous speakers, especially Subramania sirs, repeatedly we have been emphasizing that pneumonia is a clinical diagnosis. So you need not to do CBC in all OPD setting cases. It is required in hospitalized patients to confirm it and to track the course of the illness. You need to know whether the antibiotics are responding or not. So to track the course of the illness. If the hemoglobin is low, then there is underlying iron deficiency probably, then the pneumonia may be a severe one. But classically, we try to look on the TCDC, that is a total WBC count and differential count. Traditionally, we believe that if it is a bacterial pneumonia, there will be neutrophilic leukocytosis, but not always. It can be even normal total count in a case of mycoplasma, even in case of chlamydia. Typically, viral pneumonia will have lymphocytic leukocytosis. But again, it's not a rule of, it's just a rule of thumb, but not always it is true. It was a nightmare in 2019 from, it is from January to April, these 4 months, it was a nightmare in Kolkata. We were facing a lot of patients of proved, PCR proved adenovirus cases, and they were initially presenting with neutrophilic leukocytosis. So just lymphocytic leukocytosis would be a case in case of viral pneumonia, and neutrophilic leukocytosis that gives you negative value to bacterial, to viral pneumonia is not always true. Adenovirus can behave like neutrophilic leukocytosis. Then comes the passing neutropenia. That means the neutrophils going down below 1,500 per cubic liter. In viral infection, that usually occurs from day 3 to day 8. Having said that, severe infection, normal total count. So always judge the patient, Severe infection, the child looks toxic, is in a very, really bad shape. Severe infection with normal total count, that can be a case of PVL producing staph, that is pentan valentine leukocidin producing staph. Here, this particular toxin causes lysis of the WBC. This occurs especially in case of necrotizing pneumonia. Here you will find a normal TLC, but it will be a severe infection. So always judge the patient, not the report per se. Next comes the sputum. Yes, it is fancy to think of, but it is very difficult in young children. If the children can manage to generate sputum, especially in the upper age group, then morning sample is always preferred. Most of the time, it is actually the saliva that we get. So how to know that it's adequate sputum? In adequate sample, The adequate sample is indicated by more than equal to 10 WBC with mucus and less than 25 squamous epithelial cell per low power field. Having been said that, minimum of 100 field has to be checked. So that denotes adequate sputum sample. Very difficult to get. Classically ZN stain, because we are in a country where Mycobacterium tuberculosis is so rampant. So acid-fast bacilli should be sought of even if the child has present with pneumonia, especially if the child is coming with a history of TB contact, or if the child is having a long duration of the malaise, long duration of low grade temperature, or there is enough loss of weight, then we should definitely think of this. Endotracheal aspirate and bowel fluid. If the child is intubated, then these are the samples that we should think of in a case of pneumonia, because always to remember, any respiratory sample closer to the pathology, more deeper to the pathology is always better. And even we can go for RT-PCR with these samples. Next comes blood culture. It is specially indicated in severe or complicated pneumonia before initiating the antibiotics. Now, blood culture in pneumonia becomes positive in a very small handful amount of cases. Then why should we go for this blood culture? This is needed because if at all, if you get pneumococcus there, you will know the sensitivity pattern there. Having said that, the data says that globally, in the best of the centers, the pneumococcus culture positivity comes to be in the tune of around 4%, 4% or 5%, something like that. So the sensitivity, the positive the culture to become positive is very, very low. But if you get it, it helps in the management, because in PDOP study, in BASIS study, and so many studies in India, we have seen that penicillin resistance in pneumococcus is creeping up. We have seen that cotrimoxazole is almost resistant in the pneumococcus. Even the macrolides, that is azithromycin, that has been used outright in the community, is getting resistant in case of pneumococcal pneumonia. And we know that pneumococcal pneumonia is the leading cause of bacterial pneumonia in kids. But every system has got some problems. So false positive or the contamination in case of blood culture may be a problem. So again, here comes the decision making, the clinical judgment. Whatever you get in the blood culture, you have to think of whether that particular bug is fitting into your diagnosis or not. So again, always judge it in the background of the clinical picture, not the report per se. Having said that, I will again re-emphasize, in this era of antimicrobial stewardship, every possible means is to be tried to identify the offending organism and the drug sensitivity pattern. Cold agglutination test, very age-old test. In our PG days, we were asked about this. It was supposed to be a bedside test. It is basically a heterophile tube agglutination test to find out the pneumonia, classically for Mycoplasma pneumonia. A titer of more than 1:32 or fold-fold rising titer is considered as positive. But is it that it is specific for Mycoplasma? No, not at all. Certain other organisms can have this test to be positive, like CMV, Epstein-Barr virus. Even in some instances, Klebsiella can also give this result to be positive. Not only in the infective condition, certain conditions like lymphoma, that can lead to cold agglutination test positive. Other way around, even if it is a case of Mycoplasma pneumonia, it may be positive only in around 50% of cases. So it has very low sensitivity and positive predictive value. It can be used only as an adjuvant. Then comes the serology. A lot of, number of avenues are there, like complement fixation test, immunofluorescence test, ELISA. What we are looking for? We are looking for the rapid diagnosis of IgM and IgA. But these antibodies need some time to generate, and also it may stay for a few days, maybe up to a month. So this again helps in diagnosis to some extent only. Again, it is not a telltale sign that this is the only organism that we are dealing with. Pneumonia caused by other organisms, especially the fungus like Aspergillus, Histoplasma, these can be diagnosed by these serological tests as well. Next comes the urine latex agglutination test. This is mostly used as a screening test. In pneumococcal pneumonia, this organism may be found in the urine as well, and that is the rationality of using this urinary latex agglutination test. But again, it lacks the specificity and sensitivity. In one such trial that was published in Pediatrics in 2003 by Newman, where he found that 76% of lower pneumonia patients had a positive rapid urine antigen assay. So it lacks specificity and sensitivity. But if the test comes positive, what if? If the test comes positive, it is more specific for the serotype and is more sensitive than the culture of blood or lung aspirates. Next, what we mostly rely on, the inflammatory markers. Sometimes we see that our PGs or under our postgraduate trainees, they are very much keen to it. Sir, if the CRP is negative, it's a viral. If the procal is negative, it's definitely a viral. Yes, it has got certain value, but we cannot rely on these tests individually and specifically on a particular marker. Like just CRP or just procal will not be sufficient. There is always a lag time between the onset of infection and the rise in the inflammatory markers. The IL-6 is usually the first one to rise within few hours, but it comes down very fast. Sometimes even if the infection is persisting, then also IL-6 may come down. So it is a good one, but not always the best one. PCT, the procalcitonin, very costly test in Indian market. But trust me, my friends, procalcitonin is not a very costly test. Procalcitonin to the institute, I get only at rupees 550. I tell you on record, I get it in my institute at only rupees 550, and I serve this test to our patient at only rupees 700. And it is possible. It is not a ball game of thousands and thousands of rupees. It is us who can make the difference if we give some stress to the labs or to the hospitals. So PCT starts rising after IL-6, but within 24 hours, whereas CRP increases after 24 to 48 hours. However, procalcitonin correlates better with bacterial infection than CRP. Again, having said that, only single test is not sufficient. It is a combination in a background of clinical picture. So you have to correlate it. A combination of procalcitonin, CRP, and total leukocyte count gives better correlation with the bacterial etiology. To be precise, they have more negative predictive value than to assay the etiology per se. But again, I like to emphasize it is the combination in a background of clinical setting. Now, molecular techniques. Nowadays, in this COVID era, we are having so much of PCR labs. So we are a little bit of conversant with these molecular techniques nowadays. There are a number of molecular techniques like hybridization techniques, RT-PCR, multitops, etc. Very costly affair. But the costs are coming down day by day. Especially, I'd like to emphasize on this multiplex PCR. It is relatively a fast assay. You can get the report within a day or two in case of pneumonia. What are the samples that you choose for? Always keep in mind, deeper the sample, better the clinical correlation. If the child is intubated, try to have the bronchial washing, even the tracheal washing. If not, then nasopharyngeal swab is the least that you can get. But nasopharyngeal swab, it's again a Pandora's box. If you cannot collect nasopharyngeal swab properly, then you will end up in diagnosing multiple flora. You will be getting maybe adenovirus, maybe bocavirus, respiratory syncytial virus, and so on. But this will give you more confusion. What is the organism that I am dealing with? This will give you more confusion. I am telling you, my friend, with confidence and boldly, in our institute, we take this sample properly and we are getting either single or at best maximum of 2 organisms. And I have been doing this PCR in my institute for last 2.5 years, and I'm considered as the PCR man of ICH in Kolkata. So I can tell you with confidence that if your sampling is proper, then you will not be confused. You may get the proper organism. Now you may ask, what is the role of this organism to know about? I'll come into it. But what I am doing is Recipe Finder 2 Smart. This is the one from Pathofinder, and there is another such very famous respiratory panel. Dr. Rashmi also said about it, that the BioFire facility, this is very famous in India, BioFire Respiratory Panel 2 from Biomeru. These are very common. Now, this Recipe Finder 2 Smart, these are the organisms. 20 microorganisms can be assayed in a single run, and that too in a matter of time, only a 4 to 6 hours time. Why you need this? As I said, we had a nightmare in last year when we were dealing with so many cases of adenoviruses, and they were behaving like bacterial pneumonia. Not only that, we were treating adenovirus, so by supportive care, the children were going back to home, and then again to come back again after a month or maybe after 2 months with bronchiolitis obliterans. So that is very, very difficult. If you know the etiology, confidently you can say, or you can treat the children with more robustness, and you have the confidence that yes, we are dealing with this. Again, having said that, it has to be clinically correlated, because whatever diagnosis you get, that has to fit in the diagnosis that you are seeing in the other clinical setting, as well as the other biochemical parameters. BioFire, very famous here, BioFire Respiratory Panel 2, and also there is one BioFire Upper Respiratory Panel, that is 1. So Respiratory Panel 2 is specifically designed for pneumonia. All the organisms that I showed that you will be getting here, only the difference is here you will be getting Bordetella parapartosis and the H3N1 in place of Legionella pneumophila. This is not included in BioFire Respiratory Panel 2, and but BioFire is little costly. It costs somewhere in few thousand bucks, but in Recipe Finder that we are doing, we are giving to the patient at a minimal cost, and that is somewhere around 7,800. BioFire will cost you somewhere around 15,000, 16,000, maybe in little more. But the same panel, you can give it to the patients at a handful amount, maybe around 7,000 to 8,000 rupees. And again, I tell you, this is not a routine test. This is a test when the child is struggling with pneumonia. Then you will do this sort of assay. Otherwise, day-to-day basis, just in the OPD setting, we don't even think of this sort of advanced techniques. BioFire Pneumonia Panel has got another advantage, because here you can diagnose not only the organisms, but also you can diagnose these resistance genes. And then again, why this is important? Nowadays, as I said, that we are in the era of so much of MDR organisms. If we grow it in culture, then we get the culture report, and then we are directed to use the antibiotics as per the sensitivity pattern. But there is always a 90-60 rule. That means the drug sensitivity pattern that you are seeing, if the drug is sensitive, given in the CS report, then the drug in vivo will be sensitive in up to 90% cases. And if the drug is resistant, that is given in the report, that drug may be sensitive in up to 60% of cases. This is called 90-60 rule, and that is why there is difference in the in vivo and in vitro result. Here, this BioFire Pneumonia Panel offers you these resistance genes. If these genes are present, that means you have genotypically diagnosed that these genes are present in that particular bug, then your treatment will be tailor-made. You will know which bug is this and what are the ammunitions that this bug have, and accordingly you can judge your treatment. And this is the future, my friend. I don't know when it will be affordable, when this will be very much accessible to all parts of our country. But this is the future and this is the reality, especially in case of complicated and severe pneumonia. As per the manufacturer, the sensitivity and specificity is very high here. Now, in this regard, BioFire is a costly one, as I said. So always I search for, because search for something cheaper and more robust, because India is, after all, a poor country. We are not very in the affordable group, not like the first world countries where this has already become already become a norm now. Here, this is the new one, sepsis flow chip, and it is coming from Master Diagnostica, Granada, Spain. This is a novel microarray assay. Not only the blood culture, where you will get this report in 3 hours time, and you will be assaying 40 microorganisms with 20 resistant genes, including the endium bugs as well, that is New Delhi metallobeta-lactamase as well. Especially in the very young kids, if it is a gram-negative organism, and in the hospital acquired setting, Klebsiella pneumoniae, it is very, very notorious to deal with. So here it will be diagnosed in only 4 to 6 hours if the bowel fluid is assayed or nasopharyngeal swab is assayed properly. So this is the future. This is what I myself find, that this should be available in every tertiary care center, or in the, to be more robust, to be more optimistic, it should be even available in all the government setting as well. Once we thought molecular diagnosis as something very fascinating, something Hebrew to have. But here, after the onset of COVID-19 pandemic, nowadays PCR labs have increased a lot, and hence, once a difficult test to thought of has now become well within reach. With this, I'd like to conclude. Thank you. Thank you, Subramania sir, and thank you, IRP Respiratory Chapter.
Dr. Podar, can you stop sharing the screen for a while?
Yes, sir.
No, I want just the audience to just type. Was it not an academic treat to watch Dr. Podar presenting his investigations? It was a treat, no? All of it. Podar sir, you can take a screenshot of all, yes, and keep it in your, heart as an encouragement from all of us for wonderful slides and for wonderful deliberations and presentations on investigations. And now, looking at investigations, there are two things that you do in investigations. Everybody, Padar sir, my apologies, because everybody demands me to tell 2 lines at the end of the day. So therefore, for making such a lucid presentation, to be very brief, take home for them, I will tell you 2 lines. One, you have 2 things in pneumonia. One is investigations which will be directed at the organism. Number 2, investigations that are directed at the host response. Am I very clear? So the investigations that are directed at the organism are usually specific. That means the challenge is the organisms that are not pathogens are also getting isolated. Is that clear? Either be it antibodies, be it antigens of the organisms, or be it components of the organisms, be it the whole organism in the culture, so on and so forth. It also depends on the extents, the nature of the bacteremia, viremia, age of the child, our ability to isolate the organism, cost, and other factors. Am I done with clarity on the efforts to isolate the organism? But remember, it is not a mandatory to start antibiotic in a clinically diagnosed child. But these efforts are must and should and required for all hospital-acquired organisms and in severe diseases and diseases with complications where the organism can pose a challenge as far as morbidity and mortality are concerned. So for day-to-day management of pneumonia, investigations may not be required to isolate the organism, but if you end up with complications, if you end up with severity, or if you are in a research setting where you want to, increase your inputs on improving our empirical treatment and guidelines, in that case, excellent, you need to isolate the organism. That is point number one. Second, regarding the host response, like say rising the counts, rising the leukocytes, rising the lymphocytes, rising the CRP, rising the calcitonin, rising the IL-6, rising the titer, so on and so forth. It depends on the host. Some hosts respond, some hosts don't respond. If I ask you to chat in the chat box, out of 257, some of you chat, some of you don't chat, some of you agree but don't chat, some of you chat but don't agree on whatever you have chatted also. By force, you must have written yes, but in the heart of hearts, you may have no answer. Do you all agree on this point? So the host response is variable. If I ask Suman, have you seen, do you know Sushant Mane? He may say, yes, I know him, but yet he may not know him. He may say, no, I don't know him, but yet he may know him. He may say, I think that guy, I have seen him. Yeah, somewhere I remember. You know, the host response will be very, very variable based on the age, immune characteristics, context, and the disease itself is an immunosuppressed state. Disease, pneumonia itself is an immunosuppressed state, and in that state, you are asking the host response. You got my point. And it's a function of time also. Day 1 is different from day 2. Day 2 is different from day 9 of illness. And based on the severity of the disease. Severe the disease, the host response may be much more poor. Obviously, because the host is poor, the disease is severe. You know, it is other way around. So please understand all the parts of the triangle before you would analyze the investigations. I think we have not confused you, but yet made you sensitized that don't read investigation after investigation. So, sir, first day the count was 14,000. Today it has become 17,000. Should I increase the antibiotics? Sir, the counts are now 7,000. Should we repeat the lab? Please don't ask such stupid questions. If you feel confused about an investigation, the answer does not lie in repeating investigation or doing it from a better lab. The answer lies in go back to your patient and see is he alive or dead, or is he fighting to be alive. That's all. And the clinical science again speaks volumes about it. But why we have had such an extensive session on investigation is because, you know, whatever I am talking is subjective. To be very objective, you need investigations, and that's the crux of the matter. And this will be an emerging science and will add and improve our clinical acumen and our rapport and the way we are going to assess the children in future. So with these kinds of climbers and disclaimers, we will close the session on investigations, but you can put all your academic questions on the chat box. But when it comes to management, be bold and treat, don't have to read even the reports. You can send investigations, but don't read the reports. This is one line from me, last line. Did you understand? Send investigations, but don't read the reports. Now, next set of investigations that are heart of pneumonia, or I would say which are integral part of pneumonia, radiological investigations. And therefore, I'll invite now for radiological investigations, including X-ray, ultrasound, and CT. I will invite Dr. Sushant Mane to take over from now and enlighten us about radiological investigations in pneumonia. And a big clap for Dr. Suman Podar for being wonderful, extensive, and so nice and elegant on investigations in pneumonia other than radiology. Now let's look at the images and illusions of images from Dr. Sushant Mane.
Yeah. Thank you, sir, for that introduction. So after going through all the investigations, first we started in the morning with epidemiology, then we went about identifying pneumonia, then triaging pneumonia. Dr. Suman has wonderfully, given us all the investigations, and now like everybody is waiting for, I saw in the checks board, what about X-rays? What about X-rays? So yes, this is a session where we would be discussing X-rays in detail and the principles and bits about ultrasound and CT scan in pneumonia. CT scan we have included because today we see a common practice for each and every person or each and every patient of a pulmonary complaint or a respiratory complaint which comes in. X-ray is done on day 1, day 2, day 3, and day 4 a CT scan is done. So then we must know what to do when and what not to do basically. as far as radiological investigations are concerned. So before we jump onto what are the different X-ray patterns in pneumonia, what we must understand is what are the basic indications for doing an X-ray. So indications would be like any patient coming to us with a complaint like fever, or any patient coming to us with a complaint like cough or cold. We have seen so many times X-ray is ordered just for a simple cough cold because the cough cold is running for a week, or maybe say 5 days or 6 days. So that should not be the case. So if we have a severe pneumonia, which is present into, we have already seen in the identification of pneumonia, what are the criteria where we label a child to be having a severe pneumonia: saturation less than 92, danger signals, chest interactions, you have a grunt, you have a severe pneumonia child. Second, you have diagnosed the patient with pneumonia, you have put the child on treatment and the child is not responding to your treatment. So pneumonia which is not responsive to a treatment which is given properly in adequate doses and in proper regimens. Third condition would be a recurrent or a persistent pneumonia. We all know in pediatrics, we have conditions where the child may be having certain underlying lung disorder like a congenital malformation, something like that, where or a heart disease where the children comes with recurrent episodes of pneumonia. So this is the indication where chest X-ray is definitely mandatory, not only to diagnose pneumonia, but yes, sometimes we may pick up the underlying lung disorder. If the pneumonia is not responding, as in the signs and symptoms, the clinical features, the patch, everything is persistent, we want to know what is actually going wrong with the patient. Secondly, when we are suspecting any complications of pneumonia, like as we said, the child of pneumonia had responded, day 4, day 5, the fever had gone down, maybe a couple of days the child was afebrile, now again the fever is coming up, we start suspecting complications like an empyema or maybe a lung abscess, something like that. There again an X-ray chest would play an important part. And last but not the least, yes, in conditions such as tuberculosis, where you have a chronic pneumonia or a chronic chest complaints kind of a thing, where a chest X-ray is supposed to be done. What we must remember is, as we have been reiterating since morning, pneumonia is definitely a clinical diagnosis. We don't start with the chest X-ray, or we don't start with a PCR or a CBC. We have to start with the clinical symptoms first, diagnose pneumonia, triage pneumonia, and then think about writing any investigations, whether it is a chest X-ray or whether it is a PCR or a CBC. And therefore, it is not indicated for any symptoms, respiratory symptoms coming to a ED. Now, how to diagnose pneumonia on X-ray? Now, before we actually talk about how to diagnose pneumonia in X-ray, what we must remember is when we have a chest X-ray in our hand, or maybe in these days when we have a digital X-ray on our computer screens, before even we start to read an X-ray, there are certain things what we must keep into mind. First, check the name of the patient. Is the X-ray of the same patient which patient you are considering right now? Second, check about the position, the right left marking on the X-ray, whether it is done properly. Third, what we must look for is whether it is an inspiratory film or an expiratory film. In an expiratory film, the diaphragm is pushed up, the lung areas or the lung shadows or film areas are much less, the heart may appear enlarged. Whether the film is rotated, look at the position of the clavicles, look at the position of the medial ends of the clavicle, look at the shoulders, whether they are rotated, whether they are slanting. All these things matter as far as reading X-ray is concerned, because if we don't consider all these things, we may end up diagnosing wrong things. Maybe artifacts look like a patch or something like that. And therefore, these couple of things are most important when we start or before we start reading an X-ray. Now, normally, as we know, the lung fields are radiolucent in a normal child or a normal patient. Any opacification in the lung field indicates a pathology, and the commonest DD of opacification, what we think first, is a pneumonia. Now, as far as the opacification of pneumonia is concerned, what we can have is either it could be a well-defined homogeneous white opacity, or it could be small multiple opacities scattered in either a single lung field or both the lung fields. It may be restricted to one particular lobe, or it may be spread, or it may be a diffuse picture. What we must remember is when we are thinking or talking about a consolidation, the opacification which is there is not going to cross your anatomical boundaries. That is, it will not cross your diaphragms or your lateral chest walls. So you have to look carefully what actually you are seeing into an X-ray chest, whether it is a consolidation or whether it is something else. And last but not the least, correlation with clinical presentation is must. This is again, we are reiterating time and again, don't just read an X-ray. First read the patient clinically, then decide whether you want an X-ray, and then read an X-ray. Otherwise, we are going to either overdiagnose or we are going to underdiagnose pneumonia. This has been explained by Dr. Modi in his presentation. when we saw about the sensitivity, specificity, and the predictive values of investigations. Now, X-ray chest, as far as X-ray chest is concerned for a patch or a lobar pneumonia. So this we are talking mainly about a bacterial etiologies. It has a very good negative predictive value. That means if you have a child present into you with the clinical features which are fitting into pneumonia, but the X-ray test is normal or not having a characteristic patch or effusion, it rules out pneumonia. So the sensitivity and specificity of chest X-ray is less. It has a better negative predictive value. Coming to the types of pneumonia, so there are three basic types, as we all know. We have a lobar picture, we have a bronchopneumonia kind of a picture, and we have an interstitial picture. As the pathology goes, we have the pictures on X-ray. So lobar, as you can see here, it is a well-defined homogeneous patch which will be restricted to one particular bronchopulmonary segment or lobe of the lung. What can see in lobar pneumonia, I don't know whether it is very visible, but if you can see this area which is marked here, you can see a air bronchogram which is there. So air bronchogram is a characteristic feature of a lobar pneumonia. Coming to a bronchopneumonia, in bronchopneumonia, the picture is much more scattered because the pathology is scattered throughout the alveoli. So it could be either a unilateral picture or a bilateral picture, which is seen in this X-ray. Small areas of consolidation, they are non-homogeneous, they are ill-defined, and they are of variable sizes and shapes. The uniformity is not there as far as bronchopneumonia is concerned. The third picture is our interstitial pattern. Now, what you see in interstitial pattern is because it is in the interstitium and not in the alveoli or parenchyma, you can get various pictures. So you can get a mesh-like structure, which we call as fine. We can see as fine lines or linear opacities, which we call as a reticular pattern. If we get small round opacifications, it could be either a nodular pattern. The thing is, you do not have a definite particular pattern as a lobar pneumonia, what you see, or a air bronchogram sign in a case of interstitial pneumonia. Vascular markings may be much more prominent. Ground glass kind of a picture can be seen. Now, the main thing, what we all strive for as clinicians is how do we differentiate between a bacterial and a viral pneumonia on chest X-ray? Now, when we are thinking of a bacterial pneumonia, we think of two possibilities. Either it could be a lobar picture or it could be a bronchopneumonia. We have already discussed. Now, before we actually start interpreting an X-ray, let's go to what Dr. Manjunath taught us right in the morning. How does a bacterial pneumonia present to us? The child would be more severe. The child would be more sick looking. Okay, as compared to viral pneumonia, the child would be less sick looking. The child would have an upper respiratory prodrome, the gradual onset of progression. So we see for the clinical background first, then we see the X-ray. If an X-ray shows a lobar pattern, an air bronchogram, if there is a necrotizing, sometimes, bad pneumonias like staphylococcal or streptococcal, they may be necrotizing. A cavity can be seen in an acute pneumonia. If these patterns are seen on a chest X-ray, it is more suggestive of a bacterial etiology. If you see non-specific interstitial infiltrates, ground glass opacities, effusions are rare in a viral etiology, you are maybe dealing with viral etiology or viral pneumonia. Having said and done this, what we must remember is in most of the cases, it is difficult or impossible to differentiate bacterial from viral pneumonia just on the basis of X-ray. And that again brings us back to what Dr. Subramania said, that what we are treating pneumonia even today is a guess as far as the etiology is concerned. So again, what we go back to having talked about all the investigations and X-rays, look at the clinical presentation of the child. So these are some of the pictures what a viral pneumonia would show. The first X-ray here is showing you ground glass opacities. What do you mean by ground glass opacities is you can see non-homogeneous opacities, but you can still see the vascular markings and the airways inside. Now, these are the interstitial infiltrates, characteristic linear opacity, which you can see. Now, here there is a small consolidation kind of a thing which is seen. May not be consolidation. Viral pneumonias with these interstitial infiltrates can come up with mucus plugs like this, which can mimic actually a consolidation. Now, we run through certain characteristic X-ray pictures of some characteristic etiologies. So this was an X-ray which was done for a 3-year-old child who was having high-grade fever, sick looking. He was actually in septicemic shock and having breathing difficulties. X-ray is showing, as you see, there is an area of consolidation with these large air pockets on the left side. These are nothing but nematoceles, and the commonest etiology for nematocele with that clinical background is a staphylococcal pneumonia. In this X-ray, what you can see in the right upper lobe is a very well-defined round shadow, a homogeneous white round shadow. This kind of a picture is what is known as a round pneumonia. It is characteristic of a pneumococcus or streptococcus pneumoniae, though some fungal infections like histoplasmosis may also come with a characteristic round pneumonia kind of a picture. But in a normal community acquired setting, we would think of streptococcus pneumonia or pneumococcus as a cause of round pneumonia. Now, this is a picture from a 8-year-old boy who had come with only history of cough, which was going on since around 8 to 10 days. And in the initial 2 to 3 days, he had fever. The child was absolutely fine, walking to the clinic or the OPD. And what we saw was this bilateral interstitial infiltrates. So this is a kind of a picture what we see in atypical pneumonias, where clinically the patient is not very bad, but the X-ray is showing interstitial pattern. We could do a PCR test for this child and mycoplasma was isolated from this patient. So it was a picture of a mycoplasma pneumonia. This we all know, bilateral millet-like patterns which are scattered in bilateral lung fields. On the left upper lobe, you can see opacity. This is nothing but miliary tuberculosis. This X-ray was taken in a 15-month-old infant who was having failure to thrive, and he was having fever for going on for around 1 to 1.5 months, and sputum of this gastric aspirate which was done for this grew Mycobacterium tuberculosis. So if you compare this X-ray with the bronchopneumonia X-ray, these shadows here in bilateral lung fields are much finer or much smaller as compared to a bronchopneumonia picture, and they are much scattered in a more homogeneous variety. This was an X-ray of a 13-year-old boy. He was a case of a post-liver transplant child, and he was on immunosuppressant medications. He came with a history of fever ranging for more than a month. All investigations were done, and an X-ray showed this cavitatory kind of a thing, which is seen in the right upper lobe with ill-defined opacity infiltrates in both the lung fields. Now, this was a fungal pneumonia. Aspergillus was isolated from the bronchoalveolar lavage secretions of this child. So these are the various pictures where once you have a clinical background of the patient and you see these kind of pictures, you can guess what could be the etiology of this and start appropriate empirical antimicrobials. So this table just gives us a summary of features in pneumonia. So bacterial pneumonias mostly will come with a lobar consolidation, well-defined consolidations, cavitatory round pneumonias, and complications like pneumatoceles. Viral would mostly be having multifocal consolidations, interstitial infiltrates. ARDS is more common in viral. Atypical pneumonia may have a normal X-ray chest. They may have reticular pattern, hilar lymphadenopathies. Tuberculosis or mycobacterial, as we all know, they may come with hilar and mediastinal lymphadenopathy, miliary shadows in bilateral lung fields or a fibrocavitary disease, and fungal can be anywhere ranging from cavitatory pneumonias to reticular patterns, reticulonodular and round pneumonias. Having said and done all these things, all this has to be interpreted again depending upon the clinical presentation of the child. So the message as far as X-rays are concerned is pneumonia is a clinical diagnosis. Look at the clinical presentation first. Before getting an X-ray done, look whether you are actually needing an X-ray. The indication has to be right. Check the quality of the film before you even start reading of the X-ray. And once you get something on X-ray chest, go back, correlate that findings on X-ray with your clinical presentation, and then this will avoid us in over-diagnosing or under-diagnosing. As far as UAG is concerned, so this is just a short presentation on ultrasonography. Believe me, friends, ultrasonography in thorax is the most underutilized investigation as far as our experience goes. We as clinicians don't mind writing an ultrasound abdomen for every abdominal pain which comes to us in the OPD. अरे पेट में थोड़ा दर्द है 2 दिन से है चलो सोनोग्राफी करके देख लो. But as far as thorax goes, I don't know, there is some resistance among the clinicians that thorax ultrasonography is not used, and believe me, it is a beautiful investigation. Basically, when we have a patch sitting on the X-ray and we don't know whether it is a consolidation or whether there is an effusion, ultrasound is going to easily differentiate between consolidations, effusions, whether there are any other masses. Now, what basics we want to know in ultrasound is when the probe which is used for ultrasonography in pediatrics is a 5 to 15 megahertz probe. Now, where is the probe put on the chest is we have spaces. So we have intercostal spaces, we have a subcostal space, and we have suprasternal approaches. So the probe is placed over that spaces so that the ultrasound beam goes inside and you get, the various pathologies are picked up. And as far as the scanning of the thorax is concerned, the entire thorax is divided into 3 components: the anterior component, the posterior component, and the lateral component. Now, each component is divided into an upper half and a lower half, and then your transducer probe is kept into the intercostal space, and it is moved from the center going laterally towards the lateral area, and then towards the posterior, so that all the areas of the lung are covered, not even a single area is left. So you start from the parasternal line, going to the mid-clavicular, mid-axillary, anterior axillary, and you go back. And you observe the lung through that intercostal windows. Remember, sonography, if possible, if the patient is allowing us, is done in either a sitting or a semi-recumbent position. That is because if we keep the patient lying down, fluid is going to, spread across the lung. In a sitting down or a recumbent position, you can get better idea of the fluid. Now, this is what a normal lung would look like on an ultrasound. If you see this, now this is the rib shadow which is seen here. This is the pleural shadow. This requires a little amount of imagination because it is not a 3D investigation, it is a 2-dimensional investigation. So this would be a pleural line which is seen here, which is a dark homogeneous line. Now there are two kinds of normal lines which are seen in a normal ultrasound of the lung. So this is something known as an A line. A line are nothing but parallel lines which are seen parallel to the pleural lines. These are nothing but echoes arising from the pleural line. The second lines what we see here are the perpendicular line. These lines are the B lines which are running perpendicular to this pleural line. This is your pleural line here, which is seen horizontal. These B lines are running perpendicular to the pleural lines which represent the interstitium or the interlobular septa. This is how a normal lung looks like. What happens in a pneumonia is the air is displaced and you get the alveoli are filled with fluids or your debris. So what you see here is, if you see, this is the pleural line which can be seen above. Now there are no A lines which are seen in this film. Absence of A lines is an indication of consolidation. If you see, B lines have become more denser, more thicker, and they have coalesced together. This is another feature how a consolidation would look on a sonography. Now, if we see carefully inside this area, the radiolucent area, we can see small linear specks or small white lines which are seen. These are nothing but your air bronchograms, which are known as sonographic air bronchograms. So the lung assumes a liver-like appearance when the area is consolidated. The next common thing what is picked up in an effusion is your fluid. So fluid is definitely radiolucent, so it is anechoic, or it does not produce any echoes, and therefore you see a totally dark area of collection. So here is a diaphragm, here is your lung which is pushed upwards, and here is the fluid which is collected in the pleural space. Now sometimes you may also be able to see fibrin stands and loculations in a case of effusion. If you see the picture down here towards the lower end, you can see multiple areas of loculation. This is a loculated pleural effusion because there are fibrin stands which are seen. So this is one illustration where the confusion can be sought out once you have an sonography. This was a 5-month-old boy who had presented to us since 2 months, who was having fever since 2 months and breathlessness occurring around last 10 to 15 days. Child was mildly febrile, his respiratory rate was high, heart rate was high, SpO2 was 92%, air entry was decreased on the left side. Now this is a typical case fitting into a clinical presentation of pneumonia. What we saw on the X-ray were bilateral homogeneous opacities seen in both the lung fields. Now prima facie, we would be treating this child as a pneumonia unless and until we don't suspect anything, because he's having fever, he's having breathlessness, he's having all the clinical background of suspecting pneumonia in this child. When we did an ultrasonography in this child, what we saw is it was not actually a patch. It was a large homogeneous mass, which was inhomogeneous mass, which was there. If you see the mass here, it is a mass with these blackish structures. So these black mixed echoes. So this is a hyperechoic and hypoechoic areas. This was actually an anterior mediastinal tumor with those hypoechoic areas, which was confirmed later on a CT scan. So this is the importance of ultrasonography, that mainly it helps us to differentiate between a consolidation, a collapse, or a mass regions. There is no radiation exposure as far as lung ultrasound is concerned. If you are suspecting synpneumonic effusions, minimal effusions, it can be picked up easily on a ultrasound, where an X-ray may miss the synpneumonic effusion. Ultrasound guided tapping of the effusion can be done if it is indicated. If the child is not responding, you want to see what is the nature of the pleural fluid, you want to send for bacteriological examination and biochemical investigations, you can do tapping. It is a bedside investigation if you have an ultrasound machine in your ICUs or wards. And the wonderful utility is you can use this as a non-radiation investigation for follow-up of your cases. So if you do a ultrasonography on day 2, you're having an effusion on day 4, you can repeat on day 7, you can repeat to see how the effusion is responding to your management. So that is how ultrasonography is beautiful as far as lung is concerned. And I think we must utilize this when we are talking about conditions like pneumonia, empyema, and other complications. Coming to the last section, that is CT scan. Now, before we actually go about CT scan, what we will be doing in this section is, as it is a specialty investigation, we would be only focusing upon the indications, and we will run through certain characteristic pictures of CT scans, what we are seeing. But to understand the pictures, we must know what actually are the different patterns on the CT scan. So we must know what do they mean. So a ground glass opacity, what do you mean by ground glass opacity is the attenuation is increased. That means normal lungs are seen black on CT scan. If it is a opacification or whitish structure seen, but the difference between a ground glass and a consolidation is, in a ground glass opacity, although the attenuation is increased, you get an opacity, you can see the vascular markings and you can see the adjacent airway walls in that opacification. As far as when consolidation is concerned, this increased attenuation is going to totally obscure your vascular outlines and your adjacent airways, and what you get is an air bronchogram. Now, there is something known as peribronchiovascular opacity, where you get in certain viral infections, where the opacity is characteristic only around the airways. So if you see the airways look like a circular structure or maybe an elliptical structure on CT. It depends upon where is the cut of the CT scan, which cut of the CT scan you are seeing, and around that airway you can see an opacification, that is your peribronchovascular opacity. Reticular fashion is a mesh-like structure. You can see a linear opacity which is seen. Bronchiectasis, yes, bronchiectasis is a permanent and irreversible dilatation of the airways. So you can see the airways which are dilated. If you happen to have a vessel surrounding the in the adjacent to the airway, the vessel will be seen as a prominent white structure with a dilated airway, and that gives the appearance of a signet-ring. So this is a signet-ring sign which you see in bronchiectasis. And then you have septal thickenings and perilobular patterns. So what are the indications of chest CT scan? Believe me, like what Subbu sir just said, day 1 counts, CBC, WBC shows 14,000, day 3 17,000, day 2 is 7,000. Do we change an antibiotic? Do we do some other investigations? No. Similar way, if you have started the patient on treatment at day 3 and day 4, okay, tachypnea is reduced, fever is still present, that does not mean that this child goes for a CT scan. Fever is not an indication that the child has to go for advanced investigations. You have to have specific pointers where you will order a CT scan, or where we will order a CT scan. So if we are suspecting complications, for example, a lung abscess or an empyema, definitely it is indicated to rule out an underlying abnormality in recurrent pneumonias. As we all know, we have discussed, children can have pulmonary sequestration, congenital pulmonary adenomatoid malformations, and all those congenital lung disorders where the child can come with recurrent pneumonias. In an immunocompromised child, if you want to delineate, suppose if you're suspecting a fungal pneumonia, your X-ray may not be showing you the characteristic features. You have certain signs on X-ray, you have a halo sign, you can get a fungal ball appearance. So in that case, CT scan may be useful to guide tissue sampling. Suppose we are contemplating doing a bronchoalveolar lavage, or we want to do a transbronchial biopsy, then we must know what exact area to sample. In that cases, CT scan is going to help us delineate the exact area from where sampling can be done. And yes, sometimes to assess the sequelae, for example, if we had a bad influenza or a post-viral lung disease or bronchiolitis, and a very bad necrotizing pneumonia following measles or something like that, and we are anticipating or we are expecting that the child is going to have a lung damage, there we can do a CT scan to see what was the amount of damage or the sequelae of these things. So if you see in this, the figure A in the CT scan, this is, you can see a classical area of increase. So this is the black lung which is normally seen. This is a white homogeneous area, increased attenuation, where you can see air bronchograms. This is nothing but a consolidation. Now this was a 4-year-old boy which had come to us with fever and breathlessness and cough. You can see here on the X-ray, what you can just see is a prominent or a bulging of the fissure. Nothing specific is seen on the X-ray. In this child, a CT scan was done, and you can see in the right middle lobe or the in the right lower lobe, you can see a well-defined consolidation which is seen in the right middle lobe. Again, you are seeing a characteristic air bronchogram here. So this is again a consolidation which is picked up on CT scan. This is a classical lobar consolidation. Viral pneumonia, non-specific features, bilateral interstitial opacities can be seen, hyperinflation or air trapping, because as we had seen in the X-ray, if you remember, there could be mucus plugging of the airways, due to which there could be air trapping. Ground glass opacities, a patchy or a mesh-like mosaic pattern. We must remember effusions are rare in purely viral lung infections. So this is one child who had presented with cough and respiratory distress I think the child was symptomatic since 2 to 3 days. The child was having fever. Nothing was seen on the chest X-ray, and the child was actually very bad. The saturations were less. ICU child. When we did a CT scan, what we could find out is, if you see this, if you see the arrows which are pointing here, these are the bronchial wall thickenings. And if you see here, okay, this is the normal blackened lung in the upper part, you can see, and the lower part, in addition to the bronchial thickening, you can see ground glass opacities which are there scattered in both lung fields. Even though opacities are there, we are able to see the vascular areas, we are able to see the airways. So this is the difference between the ground glass opacity on a CT scan and a consolidation. This child was actually diagnosed to be having para-influenza on our PCR tests. This again are 3 different types. This first is a CT scan of a varicella zoster pneumonia, where you can see these small linear nodular markings. They are non-homogeneous. Second is a CT scan showing a cytomegalovirus. This is again a ground glass appearance. So this area, these areas you can see, these are increased attenuation areas, but still you can see the vessels inside, you can see the airways inside. This is a bilateral ground glass appearance. And here is a picture of the picture C, the influenza A virus. Now here, in addition to the ground opacities, what you can see here is large fluffy areas of whiteness. So these are areas of bronchopneumonia or bronchopneumonic consolidation. So here is a mixed picture, which is this child actually had ARDS. He was there in the ICU on a ventilator. And so this is a picture where you are seeing ground glass appearance along with your consolidations or focal consolidations bilaterally. Now, this is a CT scan. This was a 6-year-old boy who had presented to us in actually a septic shock. The child had high grade fever. The child was in the ICU on inotrops on day 1. The X-ray, if you see figure A, it had showed a large hydropneumothorax on the right side. On the left side also you can see a consolidation and some funny opacities which are seen. When we did a CT scan of this child, which is the figure B, what we saw was, if you see on the right side, there is a huge, the star which is there is a huge cavity, and the cavity is communicating with the pleura. So this was the cavity which had ruptured into the pleura. There was empyema here sitting into the pleura. On the left side also, what we could not see on the X-ray was a large irregular cavity with multiple areas of consolidation. So this was a case of staphylococcal pneumonia with staphylococcal septicemia. So this is one picture where CT scan has picked up where things are not very clear on the X-ray. Now figure C actually is not of the same patient, it's of the different patient, but these are the different pictures of CT where we see in different pictures of CT scan in a staphylococcal pneumonia. So if you see here, these are in figure C, there are small nodular opacities which you can see, okay, scattered in bilateral lung fields. A staph pneumonia can present like that also on CT scan. If you see picture D, on the right side, what you see is a large pneumatocele. Actually, there are 2 pneumatoceles. One is large, one is a little small. So these are the various CT pictures of a staphylococcal pneumonia. So it is a complicated pneumonia. Last slide, last 3 pictures. So if you see here, that is figure A, what you can see on the left side is a area of consolidation, and in that consolidation you can see a large, again, a radiolucent pocket. So this was again a case of pneumatococcus with a cavitation, but here the organism which was isolated was not staphylococcus, it was Klebsiella pneumonia. If you see the figure B, this figure, what we saw was this cavity. If you see, it has a thick edges or thick walls. It has a very shaggy margins, and you can see some material inside the cavity. This was a patient who had a lung abscess, who had presented to us with pneumonia-like features, but on X-ray, what we saw was a little ill-defined structure. When we did a CT scan, we could pick up a lung abscess. Last but not the least, this is what we are talking about, a signet ring appearance of a characteristic bronchiectasis. If you see the left side of the CT scan here, you can see multiple airways which are dilated. Okay, and if you see, you can see white spots at the edges of this, giving the appearance of a ring, which is known as a signet ring appearance. So this is a characteristic signet ring appearance of a cystic bronchiectasis. If you see the other areas of the lungs, okay, they are also not normal. There is areas of increased attenuation. So this is definitely what we are dealing with, is a chronic lung disease. So that is all about my session.
Thank you, Dr. Sushant, for that wonderful lucid presentation. And can I request all of you for clap CLAP? Type now, so we'll know how many of you are awake. Now, for want of time, I will not, re-summarize the whole X-ray, ultrasound, and CT for you. But all that I would tell you is only 2 lines on this. Now tell me whether radiology will tell anatomy or physiology in pneumonia. Please type whether it will tell anatomy or physiology. Okay, fine, understood. Who is the killer? Is it anatomy or physiology? Who is the killer? Okay, physiology is the killer. Who raises our curiosity? Is it anatomy or physiology? Anatomy is our curiosity, physiology is our responsibility. Did you understand? So physiology is our responsibility, my dear friends. Lastly, one more question. Is the right upper lobe pneumonia management different from left lower lobe pneumonia management as far as first 4 or 5 days are concerned? Is it different? No. Why document and tell, see, look here, I have treated a right upper lobe pneumonia, it's fine now. No need. So therefore pneumonia is pneumonia, but it's right upper lobe, left lower lobe, left upper lobe, lingular lobe, whatever. So to this extent, for initial diagnosis of pneumonia, X-ray is not a must. Are we clear on this particular concept? Then why you need anatomy? When the pneumonia is severe, when the pneumonia is complicated, or when the complications have gone for further complications, let's say empyema is there and then there's a bronchopleural fistula and pneumothorax, definitely you need an X-ray. You don't tell me that you don't need an X-ray. Did you understand? So therefore, whenever there is complications, whenever there is diagnostic dilemma, when you anticipate complications or when you document complications, you must go for, and in all severe pneumonias and pneumonias in special situations like immunocompromised or malnutrition, etc., where complications are very much imminent, you must go for radiological investigations. Or can I tell you in simple lines, in all hospitalized children, we will get an X-ray done. And where hospitalization itself is not required, X-ray also may not be required. Did you understand? To admit or not to admit, you do the X-ray. No, that is not correct. Please. I think, Shashank, you agree with me? People do X-ray to
Yes,
decide
sir.
whether I should
Absolutely.
admit or not admit.
Yes,
See,
yes,
एक X-ray
absolutely.
करके आ जाओ, मैं decide करूँगा, उसमें कुछ है तो मैं admit करूँगा. That's not fair and it is not correct. Please understand this point, and that's the strongest message from us. Now the second, you know anatomy, you want to know more about anatomy, then you must do CT. Is that one line enough? You want to know more about anatomy. In a particular situation, you want to know much more about anatomy. Beyond X-rays, go for CT. Basically, CT is sigma total of X-rays. It is that all the X-rays in a software put together is a CT. CT is sum of X-rays. That's all. So the next one, ultrasound, to do or not to do. If you are not doing, please start doing ultrasound. Ultrasound is better than chest X-ray. It is observer dependent, but all of us are not observant. That is the only problem. You learn ultrasound. My last question is, when an obstetrician can do an antenatal ultrasound without a radiologist, why a pediatrician cannot do ultrasound of the lungs in absence of a radiologist? And my postgraduates are doing ultrasound of the chest now, not me. I've taught them and they are doing further. They're doing even thesis on ultrasound versus chest X-ray, and it is proving to be better than chest X-rays. Tomorrow, my dear friends, we may not have any patients. We may have only COVID patients. We may have less immunizations also. So only source of income for you could be your bedside ultrasound. I'm sorry to tell you in a lighter way. At least pediatricians are poor rationalists, and only ultrasound may be the only money-making probe for us in future. It's not necessarily money-making. I'm sorry for those words. What I meant was scientific. I'm just in a lighter way when I was commenting, but it is possible that all of us will do ultrasound of the chest in future. And last line from me, to realize all these dreams, we are having an upcoming module in the pipeline, which is going to be pulmonary radiology from the chapter. It is going to be in future going to be released for all of you. So with this trailer of pulmonary radiology, which will be brought to you as an academic session, we are going to the next line. How to become a pediatric trained sonologist? Please become a member of the chapter and join the module. So that is the answer for me. So right now, the next 1 hour, we are going to discuss on management of pneumonia. I think we have done enough on clinical diagnosis and investigations. Please concentrate on the management. I will not interrupt any of the sessions unless there is one line which I have to tell you on amoxicillin. I'll come to that later. But for this, don't post too many questions. Wait for some time because the answer may be in the second slide and may not be in the first slide. So go through all the sessions and note down all the things and then put it in the chat box. Are you fine? Now we will invite Dr. Usharani Madam. She's professor in the department at Nilafar Hospital, Hyderabad, and she's going to take us through the session on antibiotics and management in pneumonia. Over to you, madam.
Thank you, sir. A very good afternoon to all the panelists and all the participants. And at the outset, I'd like to thank Dr. Subramania, sir, for making me the part of this module. And I'm sure this module will bring in a lot of positive changes and also uniformity in managing pneumonia by us. And in this last session, in third session, we'll be learning about what is a specific therapy for pneumonia, supportive care, complications, and also the course outcome and pneumonia in special situations as well as prevention. So I would be dealing with antimicrobial therapy. So far we've very well learned how to diagnose clinically pneumonia, how to assess the severity and imaging modalities. Now we have come to a conclusion that therapy is based on a smart guess. As sir said, we have to guess smartly to start antimicrobial therapy. And before learning about the protocols for specific types of pneumonias, let us see what are the outlines in this presentation. So what are the drugs which are useful for pneumonia? What are the doses and routes of administration? And we'd also be learning duration of therapy. So to learn the protocols, we need to have certain knowledge about the drugs. We need to be very well versed with the pharmacology of common drugs used in pneumonia. So it's almost 100 years since the penicillin is discovered, the miracle drug penicillin is discovered by Alexander Fleming. And even 100 years later, still the penicillin derivative amoxicillin, it remains as a wonder drug for we pediatricians. I think it is the most commonly used antibiotic. And amoxicillin, if you know amoxicillin, we can treat most of the childhood conditions, especially respiratory infections. And amoxicillin is the first choice for domiciliary treatment of community-acquired pneumonia. So as the common organisms like strep pneumonia and Hib are well covered by this antibiotic. And the dose, so there is a lot of debate on the dose, whether 40 or 80. But this is depending upon the resistant patterns in various countries. So fortunately in India, pneumococcal resistance is not so common as it is in the West. So most of the Western evidence shows higher doses recommended. But in India, 40 mg per kg per day is sufficient for treating most of the case of pneumonia. 80 mg we use when we anticipate a failure. Like if you use if the child has used amoxicillin in the last 1 month, or if the child is malnourished, or if there is a documented pneumococcal resistance in the community, then we recommend 80. Otherwise, 40 mg per kg per day is sufficient. And again, there is debate on twice a day or thrice a day. So whatever that BID or TID, as long as you use the same total daily dose, the efficacy is same. The efficacy and adverse effect profile is same as long as you use the same total daily dose. So you can decide on twice a day or thrice a day based on the convenience. And the duration again, usually 5 to 7 day duration is sufficient for non-severe pneumonia for a domiciliary treatment. There is a debate on the short course also. So there are a lot of studies on 3-day course, which is sufficient for domiciliary treatment. But as of now, at least minimum 5 days, because larger studies are needed to get it into a recommendation as 3 days course. And another important point we need to remember is dispersible tablets are better than syrup formulation because we can calculate the doses precisely, compliance would be better, and TTs are easily available. So it is difficult to find a plain amoxicillin syrup in pharmacy rather than a disposable tablet. And even cost-wise, disposable tablets are less expensive compared to syrup formulations. And please remember, never prescribe amoxicillin clavulinate as first line for non-availability of amoxicillin. Why amoxicillin is not available? Because we have forgotten to prescribe. Most often we are prescribing amoxiclav, and most of the representatives also marketing amoxiclav. If you go on prescribing, if you consistently prescribe amoxicillin, it will be more freely available. If you see, even in the government sector, the government supply is more of amoxiclav rather than amoxicillin. So we pediatrician must insist on availability of amoxicillin. So by prescribing plain amoxicillin, we are not only helping the child's parents by reducing the cost, but we need to remember that we are doing a great favor to the human race by reducing the antimicrobial resistance. So this is all about amoxicillin. And amoxiclav, the spectrum is same. We need to remember the spectrum is same, except the clavulinate, the component, it is useful in beta-lactamase producing organisms. So the indication is used mostly as a second line drug and not as a first line. It is available both orally as well as parenteral forms, and the dose is same as amoxicillin component of 40 mg per kg per day. And what you need to remember is you need to advise the parents to store in the refrigerator once the solution is reconstituted. And the IV dose is 100 mg per kg per day in 3 divided doses. And coming to parenteral penicillins, ampicillin is used as the first line for inpatient treatment of non-severe pneumonia in more than 3 months age. And also, as Dr. Rashmi has told, prior to referral, you can give a dose of ampicillin. And it is available in oral and IV forms, but oral is not easily available. The dose is 150 to 200 mg in 4 divided doses. And as soon as the child improves, we can switch over to oral amoxicillin. Coming to the role of cephalosporins in pneumonia, the oral cephalosporins which are useful are cefuroxime, cefpodoxime, though we are dealing with only 2. The other drugs which can be useful are cefalexin, which has anti-staph activity, cefdinir, and also cefazolin. The commonly used are cefpodoxime and cefuroxime. So both the drugs are used as second line drugs in community acquired pneumonia. The dose of cefuroxime is 10 to 15 mg per kg in 2 doses. And even parenteral form of cefuroxime is available. The dose is 50 to 100 mg per kg per day. And cefpodoxime we all commonly use, and the dose is 10 mg per kg per day. And this is always used as second line or as a switchover therapy. Suppose if you use ceftriaxone or cefatoxime, after the child improves, you can switch over to cefpodoxime. And then coming to parenteral cephalosporins, the third generation cephalosporin, ceftriaxone and cefatoxime, the indication is in severe and complicated pneumonias. So what we need to remember here is ceftriaxone in young infants, especially in neonates and preterm babies, and in those who have hyperbilirubinemia, it may displace the bilirubin from the binding sites and may predispose the child to kernicterus. So better to avoid ceftriaxone in young neonates, especially preterm babies and those at risk of hyperbilirubinemia. And another important point you need to remember is ceftriaxone may get precipitated in calcium containing infusions. So it may precipitate into calcium containing precipitate, and it can cause fatal reaction. It may cause fatalities. So in young children, we tend to use more of calcium containing solutions. So that is why it is better to avoid ceftriaxone in young infants. The dose is 100 mg per kg per day in 2 divided doses. And you can switch to oral cefpodoxime once child improves. So taxime, that is cefotaxime, it can be used safely even in young infants, and the dose is 150 mg per kg per day in 4 divided doses. Coming to macrolides like azithromycin, clarithromycin, erythromycin, they're predominantly used in atypical pneumonias like mycoplasma, chlamydia, and pertussis. And commonly used among them is azithromycin, which is used in a dose of 10 mg per kg per day on first day, followed by 5 mg per kg per day from day 2 to day 5 for 5 total courses, 5 days. Even IV formulation can be used in severe cases. The clarithromycin dose 15 mg and erythromycin is another alternative. Coming to fluoroquinolones, the respiratory fluoroquinolones are ciprofloxacin, levofloxacin, as well as moxifloxacin. Though it is useful in pneumococcus, microatypical organisms, and also in pneumonia and pseudomonas, as it is used as a drug of choice, drug in drug-resistant tuberculosis, we have to spare these drugs for use in tuberculosis. So do not use it commonly when other alternatives are available. So use fluoroquinolones in cystic fibrosis. If a child with cystic fibrosis has pneumonia, you can use fluoroquinolone as a preferable drug. Whereas other common pneumonias, as we have many other drugs, so better to spare fluoroquinolones as they have anti-tubercular activity. They are used in drug-resistant TB. The levofloxacin, the dose is 16 to 20 in children 6 months to 5 years, and in age groups of 5 to 16 years, 8 to 10. And ciprofloxacin is usually used in children more than 1 year. Though there are a lot of side effects mentioned, but the human studies have not proven any effects on the cartilage. So we need not to have to be very much worried about the adverse effects of fluoroquinolones. The oral and IV dose for ciprofloxacin is 20 mg per kg per day in 2 divided doses. Coming to staphylococcal antibiotics, we have very well learned how to identify staph pneumonia based on the clinical features when there are pustules, abscesses, pneumatoceles. So the antibiotics, oral antibiotics which are useful are cloxacillin, cefalexin, and cefazolin. Cloxacillin is antistaphylococcal penicillin. Both oral and parenteral forms are available. It's used as a dose of 150 to 200 mg per kg per day in 4 divided doses. These 3 drugs are predominantly used in methicillin-sensitive Staph aureus. So cefalexin is a first generation cephalosporin. It is used usually as a step down after the child improves, after the clinical condition improves, in a dose of 75 to 100 mg. Usually in other infections, we use a lesser dose, skin and soft tissue, upper respiratory, we use only 40 mg. But in pneumonia, we use a higher dose of 75 to 100 mg per kg per day in 3 divided doses. Cefazolin is another first generation cephalosporin. The dose is 150 mg per kg per day in 3 divided doses. The other antistaphylococcal antibiotics are clindamycin, vancomycin, and linezolid. So when to use clindamycin? Clindamycin is used in severe and complicated staph pneumonias by the methicillin sensitive and also community acquired MRSA. If the resistance to clindamycin is less than 10% in a particular community, and also in aspiration pneumonia, clindamycin is a drug of choice. The dose for parenteral as well as oral is around 30 to 40 mg per kg per day in 3 divided doses. Coming to vancomycin, vancomycin is predominantly used when you suspect methicillin-resistant Staph aureus, which is usually a common setting in hospital-acquired and ventilator-associated pneumonias. And the IV dose is around 40 to 60 mg per kg per dose. It's not available as an oral formulation. So after the child improves, you can switch over to oral linezolid. The linezolid again is used only in severe and complicated pneumonias. The efficacy of vancomycin and linezolid were comparable in various studies on pneumonias with MRSA. And it is also the drug of choice in situations where there is penicillin hypersensitivity. And the oral and IV dose is same for linezolid, 30 mg per kg per day in 3 divided doses as infusion. So it has to be used only where there is indication. Just because it is oral formulation is available, don't unnecessarily use it in pneumonias other than MRSAs. And switch to oral linezolid once the child improves. So pseudomonas, we suspect whenever there is hospital-acquired pneumonias. And the drugs for pseudomonal as well as ESPIL microorganisms are piperacillin and meropenem. I would say these two are the most misused antibiotics. Any child gets admitted, even with community-acquired pneumonia, people tend to use piperacillin and meropenem along with vancomycin. So we need to avoid such habits and start them only when there is clear indication. These two are broad spectrum antibiotics and we need to preserve them only for severe hospital-acquired and ventilator-associated pneumonias where we expect drug resistance. The dose, the piperacillin is a broad spectrum penicillin and the dose is 300 mg per kg per day of piperacillin component in 3 divided doses. And meropenem, the indications are severe pneumonia as similar to piperacillin tazobactam and the dose is 60 mg per kg per day TID. So that is about antibacterial agents. So whenever you want to give a combination with vancomycin among these two drugs, meropenem would be better because a combination of piperacillin with vancomycin, the chances of acute kidney injury are higher. So when you want to give a combination, mero with vanco would be better. Then coming to antivirals, the commonest antiviral used in pneumonias, that is influenza, is oseltamivir. So the indications for oseltamivir usage is any child who is hospitalized with presumed or confirmed influenza, and children with influenza who have severe, complicated or progressive illness. And if a child has underlying problems like a chronic lung disease or a heart disease or a chronic renal disease or other systemic illnesses, if such a or an immunocompromised state, if such a child develops influenza infection, then we have to give oseltamivir. So the clear-cut government guidelines on categorizations of A, B, and C. So both category B and category C, we need to use oseltamivir. And the dosage guideline is as per the weight, below 15 to 23. So you can keep this table on our office, and then we can see the dosage. There's no need to buy hat, and the commonly used formulation available has a strength of 60 mg per 5 ml, and we can give the doses as per the weight. In children below the age of 1 year, we can say per kg. It is usually 3 milligram per kg of oseltamivir can be given. Coming to antifungals. So antifungals are used in severe fungal pneumonias caused by Aspergilla, blastomycosis or mucormycosis or candida pneumonias, or cryptococcal pneumonias, which we come across in HIV children. And the dosages, in the amphotericin deoxycholate, the dose is 0.7 to 1 mg per kg as infusion. But liposomal amphotericin is safer and it can be used in higher doses of 3 to 5 mg. And once the child improves, you can switch to oral fluconazole or itraconazole or oriconazole. So usually the dosages, the duration is longer for aspergillosis, cryptococcosis. We may have to use for months together, whereas for candida pneumonia, you can use for 2 to 3 weeks. So these are the oral antifungals. Fluconazole, the dose initially IV is 12 and it can be switched over to 6 mg orally. And itraconazole is around 3 to 5 and oriconazole 5 to 7. So this is about the drugs. Now, what are the principles of treatment for pneumonias? As it is difficult to differentiate, so after all the previous sessions, we have come to the conclusion that it is not accurately possible to differentiate a viral from bacterial pneumonia. So hence, any child who has a diagnosis of pneumonia must receive antibiotics and start antibiotic as soon as possible after establishing a diagnosis, preferably within 4 hours. If you suspect sepsis in a particular child, within 1 hour, you have to start antibiotic. And always oral route is preferred. Parental use only in severe cases. And if the child is vomiting persistently and not tolerating oral therapy. And as soon as you need to reassess every 48 to 72 hours, and as soon as the child improves, we can switch over to oral therapy. And what is the duration recommended? In non-severe pneumonia, when using oral treatment, 5 to 7 days of treatment is enough. In severe pneumonia, initially you start parenteral. As soon as possible, you switch over to oral and continue for 7 to 10 days. When you suspect staph pneumonia or complicated pneumonia, always start with parenteral, then switch over to oral. And in staph, the duration is around 2 to 3 weeks. If it is a complicated pneumonia like an empyema, you need to use at least for 4 to 6 weeks. So these are the recommended durations. Coming to treatment, what are the regimens for various types of pneumonias? So for non-severe pneumonia, which is a community acquired, the treatment is outpatient treatment. In a child below 3 months, of course, you should not use because it is tend to be rapidly progressive and children, young infants tend to be more sicker. They always need hospitalization. So there is no role of OP treatment for children below the age of 3 months. If a child is between 3 months to 5 years, as we suspect pneumococcus is the commonest organism, amoxicillin is a drug of choice as first line. If there's no improvement, a second line you can use amoxiclav or a cephalosporin like cefuroxime or cefpodoxime. The child is above the age of 5 years. Again, same pattern of organic. If it is a classical bacterial pneumonia, then amoxicillin is a drug of choice. But if you suspect, if a child has the features of atypical pneumonia, then you can use macrolide, doxy or levoflox. But as I said earlier, macrolides are preferable and preserve fluoroquinolones for tuberculosis. So unless you have if you have an alternative, do not use a fluoroquinolone. And coming to penicillin hypersensitivity, some of the children may be allergic to penicillin. So the two types of hypersensitivity, type 1 is more serious, that is IgE mediated. So if a child has IgE mediated type 1 hypersensitivity, then there can be cross reactivity with cephalosporins. So in such children, you cannot use cephalosporin. You need to go for alternative groups like levoflox, clindamycin, or a macrolide. If a child is not having type 1, non-type 1, which is IgG or IgG mediated, in such cases, you may use cephalosporins. Similarly, if a child has Steven-Johnson, serious reactions like Steven-Johnson or toxic epidermal necrolysis with the penicillin group, then you should not use cephalosporin. Coming to treatment of severe pneumonia, the indications for parenteral antibiotics in pneumonia are age less than 3 months, if a child has immunocompromised state, either primary or due to acquired, and in all cases of severe pneumonias and complicated pneumonias, or if a child has persistent vomiting or is not able to tolerate oral medications, and also when there is no response to oral antibiotic therapy and child is deteriorating, then you need to use parenteral antibiotics. So what are the drugs? Suppose if a child is less than 3 months, a third generation cephalosporin, preferably ceftriaxone than ceftriaxone. If you suspect staphylococcus, then you can, the drugs which are useful are cloxacillin or cefazolin. If you suspect MRSA, vancomycin or linezolid. If chlamydia is suspected, you can use azithromycin. In a child above the age of 3 months, non-severe pneumonia, if you need a parenteral antibiotic, ampicillin is a drug, and also amoxicillin. Whereas in severe pneumonias, better use third generation cephalosporin, either ceftriaxone or ceftriaxone. When staph is suspected, the same as below 3 months. If it is MSSA, you can use cloxacillin or clindamycin. When you suspect MRSA, you can use either clindamycin, vancomycin or linezolid. If the atypical organisms are suspected, then either a macrolide or a fluoroquinolone. Coming to hospital-acquired and ventilator-associated pneumonias, the empirical treatment, always with every hospital should have a policy of doing cultures and deciding antibiotic protocols based on the cultures. But empirically, the protocols or regimen should cover Staphylococcus aureus, Enterobacteriaceae, Pseudomonas, and anaerobes. So on a broader regimen can include an aminoglycoside like amikacin to cover for ESBL producing organism, and also piperacillin tazobactam or meropenem or ceftazidime or a clindamycin. So whenever there is a type 1 hypersensitive to beta-lactam antibiotics, you cannot use cephalosporin. In such cases, you can use clindamycin. And if MRSA is suspected, you can use vancomycin. VAP, almost similar regimen you can use, either a piperacillin tazobactam or meropenem, plus an aminoglycoside, plus or minus vancomycin based on the prevalence of MRSA. So these are the regimens for HAP and VAP. Coming to antibiotics for aspiration pneumonia. So if the aspiration occurs in a community setting, the drugs are different than an aspiration which has occurred in a hospital setting. So for community acquired aspiration pneumonia, the drug of choice would be either amoxiclav or clindamycin. Whereas for hospital acquired, you need to use a broader spectrum, which covers drug resistant organisms also like piperacillin or meropenem. And when you suspect MRSA, you can use vancomycin. But a point to be remembered here is never use metronidazole, as anaerobes are covered by clindamycin, also covers, piperacillin also covers. So all these above antibiotics also cover anaerobes. So there's no need to add metronidazole for aspiration pneumonia. Coming to viral pneumonias. So most of the viral pneumonias, there are no effective antivirals are available. There are very few exceptions, like influenza A, either influenza A or H1N1, you can use oseltamivir. In case of resistance to oseltamivir, you can use zanamivir or peramivir, but we usually commonly use oseltamivir because resistance is not yet established in India. Ribavirin, of course, there are no more recommendation. Earlier, they were using for respiratory syncytial virus, but the present recommendation to use prophylaxis with palivizumab rather than use ribavirin for children who are at risk of RSV severe pneumonias. And acyclovir is recommended for herpes zoster and simplex, which is more common in neonates and also in immunocompromised patients. Similarly, CMV pneumonia, ganciclovir is a drug of choice. And a word about remdesivir. So COVID-19 fortunately is not so severe in children, but in severe cases of COVID-19 pneumonia, remdesivir is used only in children above the age of 12 years who are weighing at least 40 kg. But an emergency use authorization remains in place to treat children between 3.5 to 40 as well as children younger than 12 years if the situation warrants. So if it is really severe pneumonia, there is an emergency use authorization is in place. And another point we need to remember is at least 30% of the cases of viral pneumonias have a coexistent bacterial component. So an antibiotic also should be added to the regimen in all severe cases of viral pneumonias. And a word about PCP. So you suspect PCP pneumonia in children between 2 months up to 1 year of age with HIV infection or HIV exposed status. And the drug of choice is trimethoprim sulfamethoxazole. And the dose is around 15 to 20 mg per kg in 3 to 4 divided doses, and we need to give it for 21 days. That is about drugs and protocols. Sir, shall I go ahead with the cases, sir?
Yeah, I think we will cut short the cases for a while because they're all trainers. They will answer all these things.
Yes, yes, sir.
So I will just summarize it for them. If you want the cases to be discussed, then say 1 or 2 cases we can discuss. But
whatever you say.
Yeah, because it's already 1:51. We'll finish off in next 45 minutes or half an hour. So I think that concludes your session. We will discuss the cases at the end.
Yes, yes, sir.
We'll discuss them at the end.
I'll stop sharing.
Stop sharing, madam. See, there were questions, and I have to first of all compliment Dr. Usharani for making that antibiotics the most controversial area so simple. Only small correction, madam, is that less than 3 months, we have written only cephalosporin. We have to just add an aminoglycoside there in that slide.
Okay.
We'll just add. I think this was a slip miss. We will add it in the slides. The second point is that there are questions on only one drug which I have to answer to you. Other drugs you don't bother. Amoxicillin. Why amoxicillin? That is because amoxicillin is widely available, cheap, both injectable and oral are available. It is better than cotrimoxazole from all large RCTs that have been done across the globe in developed as well as developing countries. Is that clear? There is no extra advantage of clav over amoxicillin, except that it covers moraxella. So therefore, my dear friends, so if you want to extend the spectrum, then you should go for clavulanic acid. That is very, very important. Third, what is the why amoxicillin? That is because amoxicillin is going to overcome the resistance by increasing doses. I mean to say, amoxicillin at 40 milligram per kg you give. Suppose you have intermediate resistance to amoxicillin on your swab culture. Then you give 80 milligram per kg of amoxicillin, it breaks through that resistance. Am I clear? So amoxicillin is the only drug which by increasing the doses overcomes the resistance, and yet it is safe. 3 to 4 times the therapeutic doses if you give amoxicillin, nothing happens to the child. No other drug has this advantage. So it is one of the most ideal drug or near ideal drug for domiciliary management of pneumonia across all ages. The most safe, oral, injectable, wide therapeutic margin, safe, palatable, available, and what else you want? What else you can ask for in domiciliary management or outpatient management of pneumonia, but for amoxicillin? Next, how we should give amoxicillin? People were asking me, sir, syrup is not available. You have prescribed amoxiclav, so amoxiclav is available. Not, you have stopped prescribing amoxicillin syrups, therefore it is not available. And always pharma wants to make money, and therefore they are coming out with clav, not amoxicillin plain syrups. So what is the solution? So let me give a solution to you, and that is the case which Usharani madam want to discuss. So this is the scenario. I'm going to tell you one simple line. 10 kg child would require amoxicillin on domiciliary management of pneumonia. What will be your prescription? 10 kg child, 40 milligram per kg per day. So it will come to 400 milligrams. So I will give not syrup but dispersible tablet of amoxicillin. What does that mean? It will be 250 milligram of amoxicillin twice daily. Am I clear? DT, dispersible tablet, 250 milligram twice daily is much better than syrup. Because if you prescribe syrup and if your calculation is 400 milligram, then you may end up telling 77 ml BD, 3.5 ml BD, 4.2 ml BD. This no mother on earth will give as per your 0.2 ml, 3.5 ml, 3.75 ml. No mother will give. Please understand how many of you have taken antibiotics for 5 days. Please raise your hands. How many of you have honestly taken antibiotics for 5 days? The moment the fever goes, the mother is going to titrate the dose for her steel spoon, which is available in the kitchen, not for your ml. Please understand the point, and therefore we don't want any failures. Compliance issues are there. So therefore give dispersible tablets. This is a strong practical message. Please give dispersible tablets, not syrups. And dispersible tablets are better, pharmaceutically maintained, do not require refrigeration, and also that the mother cannot give half-hearted treatment in dispersible tablets. The next case scenario, a child, so somebody was asking me, should we give twice daily or thrice daily? I'm coming to that now. Suppose a 15 kg child is there. What is the total dose that you would get? 600 milligram per kg, correct? Do you agree? 40 milligram per kg. So what will you give? Will you give 500 or 750 now? You will give 750 tablets. That means 250 milligram dispersible tablet 3 times a day. So for a 10 kg child, you would give 250 milligram twice daily, and for a 15 kg child, you will give 250 milligram dispersible tablet 3 times a day. Is this message simple, loud, and clear to all of you? Then type yes. Simple way of prescribing amoxicillin. Please understand, I don't want you to get into all those things. Now, can I prescribe cefuroxime, clarithromycin? All these questions are asked. Where are the studies available globally? Do you have safety of the drugs, wide availability of the drugs, recommendations available across the globe in low middle income countries as a recommendation from the chapter or from the academy that we can give for all of you? Answer is no. The time tested, the most widely available lovely drug is amoxicillin. Then when amoxicillin fails, or if they have used amoxicillin in the past 3 or 4 weeks, for some upper respiratory tract infection, I give amoxicillin last week only. Now there is pneumonia. Should you give amoxicillin then? Then you can go for amoxiclav. Is this clear? Why and why not ampicillin orally? Ampicillin has to be given 3 or 4 times a day. It cannot be given twice a day like that. So therefore, amoxicillin is preferred over ampicillin. Next one is, can the diarrhea be treated with probiotics? Answer is no. 1 or 2 loose motions can be given reassurance and some fluids. No need to prescribe probiotics. No need to worry about diarrhea. You stop worrying about diarrhea, then the parents will not worry about diarrhea. Please tell them about diarrhea, which is a common accompaniment of amoxicillin, and nothing to worry. And higher doses are not associated with more diarrhea. So do not worry at all. See, dispersible tablets make sense because if you tell them 7 ml twice daily, mother knows how to give 5 ml, not 7 ml, 7.5 ml, 8 ml. It would be very difficult. Now, the last last answer from me. Should it be 40 milligram per kg, 50 milligram per kg, 80 milligram per kg, 90 milligram per kg, or 100 milligram per kg? There are 2 or 3 studies in the WHO website. If you go, what they say is they don't want failures from lower doses of amoxicillin. 1 or 2 studies have been done with an intention that let the oral medication be loud, be clear, and be robust, so that there is no failure of oral medication to give injectable antibiotics, which calls for hospitalization and an expense and a cost. And therefore, they were going for higher doses in order to even cover for the known and unknown resistance in the various parts of the globe. Is that clear? So now I will leave it to you in your area. If you have documentation, guess, or availability of resistance patterns, then you go by that. Otherwise, we can go for 40 milligram per kg. Last line. Sir, how to decide? That means amoxicillin kills by the peak of the levels. Amoxicillin, I'm repeating, the drug levels are like mountain. The height of the mountain, not the volume of the mountain, decides killing by amoxicillin. Am I clear? It is not the area of the mountain, area of the curve. It is the peak of the curve that decides killing for penicillins, like amoxicillin. Did you understand? So what does that mean? You must give higher the dose you give, better is the killing. Now, higher the dose you give, longer is the stay in the blood. Did you understand my point? So if the mountain is tall, it is also going to be longer in 24 hours. So my question to you is, if you have pneumonia child with you in front of your eyes, let's say there is no chest retractions and there's fever and fast breathing, you can get away with 40 to 50 milligram per kg. Let's say a child is there with chest retractions and they cannot afford intravenous antibiotics. You can comfortably go from 50 to 80 milligram per kg of amoxicillin. Let's say chest retractions is there. You understand? The mother cannot afford hospitalization. Please don't compromise. You can go ahead. So 40 to 80 milligram per kg is the recommendation. Now, what does that 80 milligram per kg means? 40 milligram per kg means that 40% of the time in 24 hours, blood levels will be above the level of MIC. 50 milligram per kg means 50% of the time in 24 hours, the drug levels will be above the level of MIC. 80 milligram per kg means 80% of the duration in 24 hours, the drug levels will be above the level of MIC. 100 milligram per kg means 24 hours, for 24 hours will be that the drug levels will be above the level of MIC. Am I clear now? You decide how you are killing. You want to kill how long you want to have the battle in the body above the level of MIC. If you think 40 to 50 milligram per kg is sufficient, stick to that. If you think that you are in the intermediate level, you can even calculate the dose. Don't be so numerical. Round it up to dispersible tablets and give. Don't give it, let's not confuse you for amoxicillin. Now, please tell me, can you take a call on how, when, and why to give amoxicillin? If you type yes, I will go to the next concept. Are we clear on amoxicillin? All other drugs, don't worry. If there is any confusion on amoxicillin, I will stay for a minute because that's the strongest message. Please give amoxicillin properly. Please give dispersible tablets. Round up the dose for the availability from 40 to 80 milligram per kg. Give sufficient number of tablets to the mother. See in front of your eyes that so many tablets she purchases and takes home, and show you the empty sachet or empty tablet this thing at the end of the prescription for you. Please watch the child for 24 to 48 hours. How does that do? I think the message on so-called non-severe pneumonia, domiciliary management of pneumonia should be loud and clear from us, so that there is no errors done. See, after 48 hours, you are the clinician. We need not give you a homogeneous solution for management of case. Each case differs after 48 hours. And there is a reason to differ. Is it non-compliance? Is it complications? Is it resistance? Is it something else? or is it not pneumonia at all? So based on that, you take a call. Are we clear? Fine. So therefore, to me, pneumonia means, is it amoxicillin or non-amoxicillin? That's all. And do not worry about clav and all those things. Please shut all those discussions. And if you are giving clav, please calculate the dose of amoxicillin. Don't add the clav. Last question, which was there in the chat box. If clox is not available, what to do? If clox is not available, and if there is ampiclox or amoxiclox available to you, calculate the dose of clox only and not the combo dose in that and give. And the ampicillin or amoxicillin is complementary for that child when the clox is calculated. Did you understand? You can co-calculate along with your dispersible tablet if at all you are giving simultaneously. I will tell you this, for example, for a mother with suspected staph, it could be few ml of ampiclox tablet or syrup plus amoxicillin plain, or amoxiclox tablet plus tablet amoxicillin. Did you understand my point? So clox could be 50 milligram per kg, while amoxicillin could be 80 milligram per kg in that child. So therefore it could be a tablet of amoxicillin plus tablets of amoxicillin plus clox in that particular child. Don't say, sir, it is not available, I want to give Vanco. Cloxacillin in MSSA is still effective and you should be able to use. Are we done with the second concept of clox availability versus non-availability? If you type yes, we will go next. I think simple. We have made the messages simple. See, to simplify is very difficult for me. If you are an individual pediatrician and in a given case of pneumonia, if you take exceptions, you can still go ahead. See, we are not going to prevent you. But there has to be some kind of uniformity in management of pneumonia, at least on outpatient basis. At least on outpatient basis. In an inpatient, please go for evaluation completely and take the calls, and we are going to send you all the slides you need, not worry. So I think that takes me to the next section for want of time. So BD or TID, don't get confused. BD, TID, even people have tried even OD. I mean, there are some researchers that are coming up. Please remember the pharmacokinetics. Understand, amoxicillin acts at the highest peak. Then what about aminoglycosides? Aminoglycosides don't act at the peak level. They act at the base level. That means the trough level of an aminoglycoside should be above the level of MIC. And that's why give a loading dose followed by a OD dose, and that dose is maintained throughout the day above the level of MIC. See, that makes them less safe drugs because, you know, the therapeutic range is closer to the toxicity levels as far as aminoglycosides are concerned. And because amoxicillin acts at the peak level, the safety levels of amoxicillin are higher than the therapeutic levels. I think that takes me to complete pharmacology. I can speak 1 hour on combination of amoxicillin or penicillins versus plus an aminoglycosides. For want of time, I'm closing the session on discussion only for the reason of, see, amikacin, can it be used instead of gentamicin? Answer is yes. There's hardly anything. See, if you are choosing aminoglycosides, the mechanism of action is same. There are some small little pharmacokinetic advantages of gentamicin versus amikacin in terms of resistance, in terms of mechanism of action. Therefore, don't worry. The larger logic is you are combining an aminoglycoside with a penicillin group of drugs or a cephalosporin group of drugs. Are we done with this? So whenever you anticipate bacteremia, sepsis, it should not be monotherapy. It should be 2 drugs. So what are the conditions? Children with malnutrition, immunosuppression, and children less than 3 months of age, and in all hospitalized children with severe or complicated pneumonia. So you cannot expect monotherapy, then you are going for polytherapy. Is that clear? Fine. I think we have simplified and given a loud and a clear message on antibiotics. You know, with this knowledge, take a call. Now you have a chest x-ray of right upper lobe pneumonia and child is not running much fever, is comfortable and respiratory is just above the definition of tachypnea. Can I give 40 milligram per kg of amoxicillin in that child? Answer is yes. You agree? And the same mother is coming from 50 miles away and she cannot get admitted. Will you give 40 milligram per kg or send? Or She is from a rural background. There are no facilities to come if there is a complication. Will you give 80 milligram per kg in that mother who comes from a distant place? See, dear friends, you are the judge. Decide whether you want to give 40 milligram per kg, 50 milligram per kg, or 80 milligram per kg. Let's stop the debate and start treating those children. And recovery at the end of the day is more important. This is not the place where you misuse an antibiotic. This is the place where an antibiotic is indicated. Be bold, be clear, and give. And don't be over enthusiastic to give 80 milligram per kg in all cases where it could be irrational and may not be required. I think fine. So therefore, ampicillin injection is cheaper and easily available compared to amoxicillin. So therefore, we are going for ampicillin as injection. Compare the cost. MP is cheaper and widely available. Therefore, when you give injectable, anyway, you are hospitalized the child. So whether you give 2 times a day injection, 3 times a day, 4 times a day doesn't make any difference. And ampicillin is widely available. And therefore, ampigenta or ampiamicacin in the beginning. That answer also we have given. Can I quickly go with the permission of all of you, because we have to end the session in another 30-40 minutes. So therefore, all of you can have your lunch while you watch. So therefore, I'll go for the next concept, that is supportive care. And for all of you, I'll go quickly. Am I audible? And are the slides seen? Usharani madam, one of you please tell me. Slides are seen? Any one of you please tell me?
Yes, sir. Now it is seen.
Seen, fine.
Yes, sir. Yes, sir.
Okay, fine. I just wanted a nod from you, because sometimes slides are not seen. I will not know from the chat box. Fine. Supportive care or additional care. I will tell you, supportive care is also required in outpatient management. Don't say only in admitted patients we require fluids. And I would say supportive care is more required when you are not around and when you are monitoring. So this is very, very important. Why you need a supportive care? Aims are to improve oxygenation, to reduce the work of breathing, for faster recovery, reduce hospital stay, reduce morbidity, mortality, complications, and counseling for the patients and family support, children, family. And the child is a small child. He doesn't understand, isn't it? So a lot of emphasis has to be paid on supportive care. So treatment of pneumonia is not antibiotics, it is antibiotic plus. And a plus is this supportive care. So let me go for what are the supportive care for in home setting. Reduce the fever. You must give paracetamol. And here, I don't mind if you overuse the paracetamol. It may reduce the pain, chest pain, pleuritic pain, this, that, etc. Doesn't matter. See, fine. In already diagnosed pneumonia, be liberal in using paracetamol. Cough suppressants, no use. Bronchodilators, no use. If vomiting is there, if 1 or 2 times child vomits, please don't give anything. If there is a persistent vomiting, consistently persistent, then only you can give antiemetics, otherwise not required. So therefore, don't overuse antiemetics also. So identifying the signs and symptoms of deterioration and serious illness is very important. Supportive care is something where I can't give you recommendations. Please understand, you have to know the family and the context, and therefore act accordingly. The safety net involves provide the caregiver written information, warning signs and symptoms. Please write it in their own language that they can understand, and when to come for follow-up. Liaison with other health professionals or some other people for providing aggressive care. In a hospital setting, I'm not talking of domiciliary now. Hospital setting, fluid therapy. See, when it is indicated, fluid therapy is indicated because of the following reason. There is the inability to maintain their fluids because of fatigue, breathlessness, not able to feed, etc. Remember, children who cannot feed well are the ones who are going to die. In I would say just pneumonia, breastfeeding should be continued. Oral feeding or feeding should be given as an option. Nasogastric tube can be inserted. Remember, in these, I'm talking of resource poor settings. When the setting is fine, you can go for intravenous fluids therapy in cases where newborns are there, less than 59 days are there, severe distress is there because nasogastric tube can obstruct the passages, persistent vomiting is there. You may have to give additional corrections for hydrations, which you are the clinician at the bedside. You may have to increase 10 to 20 ml per kilo or even up to 50 ml per kilo based on the assessment of hydration. You can go for Holiday-Seeger formula for calculation of the fluids, monitor the fluid balance and serum electrolytes. SIADH may be likely in severe and complicated cases, especially if you have hyponatremia. And in severe or complicated cases, please remember that SIADH can occur, and you need to recognize presenting features can be nausea, vomiting, cramps, lethargy, personality changes, seizures, or coma. And the electrolyte imbalances can cause all these problems. Oxygen should be given whenever there is SpO2 less than 94% as per PALS guidelines, less than 92% as far as IDSA guidelines or infections are concerned. So if you go by PALS, then 94%. If you go by IDSA guidelines or infectious disease guidelines, most of it tells that above 92. Let's not battle it, but our target should be to keep the SpO2 above 94. Is that fine? Or I would say above 96. So let's aim for a good target. And in a pneumonia, when it is hypoxia, please don't try to bargain oxygen, because these are not newborns, and oxygen is not a bad thing to be given in pneumonia. This is the only thing that you would give. So please give properly, appropriately, in a non-threatening manner. And indications are basically severe lower chest intrawing, respiratory rate more than 70, and in severe pneumonias. Please remember, you must give oxygen in all these conditions. Suppose pulse oximetry would guide you, but more importantly, clinical evidences of hypoxia are equally important. You can give heated, humidified oxygen. You can give via nasal prongs, nasopharyngeal catheters, or nasal cannula, head box, whatever. You can give by low flow device or high flow device based on the severity of hypoxia. You can go to CPAPs, HFNC, or invasive ventilations. And I'm not going to tell you, this is the question of the call that you are going to go by based on hypoxia, not by recommendation of pneumonia. Bronchodilators, chest physiotherapy, and Heliox. Bronchodilator is useless in a case of pneumonia if you are thinking pneumonia as a parenchymal disease. But if you have a bronchopneumonia and airways are also involved, bronchodilator can be tried, and if effective, continue. Otherwise, just go on giving bronchodilator in a child with consolidation makes no sense. And chest physiotherapy in acute inflammatory state, there is a relative contraindication for chest physiotherapy unless you have acute and chronic pneumonia like cystic fibrosis child, or a given child with pre-existing comorbidities like bronchiectasis, where chest physiotherapy can be additional benefit. But a simple consolidation of right upper lobe, don't go on percussing right upper lobe. See, if in case of viral pneumonias where you have an obvious viral airway syndrome, there you can go for physiotherapy and suctioning following nebulizations, but that should be restricted. Nutrition is very, very important. Malnutrition is a cause of pneumonia. Therefore, aggressive nutritional approach should be there with regard to protein diet, vitamins, trace element, minerals. Complicated cases, you may have to go for PPN or TPN. Appetite is poor and intake is poor. So please concentrate on nutrition. Counseling, I think all of you are good in counseling. Please remember where you are counseling, whom you are counseling, how you are counseling. Are you giving the danger signs to them and the anticipated complications and prognosis? There has to be one-to-one discussion in a way that they can understand patients are under financial stress, non-availability of a care, aggression, intensive care situations, danger signs, and a deteriorating picture. All should be explained in the way that they can understand. Complications of pneumonia would be the next discussion, which will be taken by my friend, Dr. Hema Mittal. Is there any issue regarding supportive care? Because I've rushed through the slides, please let me know. I think it's enough. All of you are good in giving sufficient of fluids and oxygen, anticipation of some of the problems. Lot of common sense is required in, giving a good supportive care. Fine. So we will go, because the person who was supposed to take supportive care was not available today due to Diwali. I have taken by extempore, and I'm sorry for going so fast. So can I invite Dr. Hema? Hema, it's your session now. Yeah.
Yes, sir.
Please go ahead with complications, and I should be able to finish off in next half an hour or so. Over to you.
Okay, thank you, sir. So good afternoon, everybody. I'll be talking about complications of pneumonia. Last but not the least, because this is what we dread of while treating a patient. So I hope I'm audible and my screen is visible. Okay. So talking about complications of pneumonia, the complications of pneumonia may include both the pulmonary as well as extrapulmonary complications. The pulmonary complications commonly involve the parapneumonic effusions, empyemas, pneumothorax. The less common would be necrotizing pneumonias, lung abscesses, and ARDS. The extrapulmonary complications include secondary infections and septicemia, DIC, and hemolytic uremic syndrome. So coming to the first one, we have the parapneumonic effusions and empyema. So the parapneumonic effusion is defined as a collection of fluid in the pleural space, we all know, with underlying pneumonia. It occurs in around less than 10% of the pneumonias, and the frequency is highest in the children less than 5 years of age. Pleural disease in isolation does not contribute to significant mortality. The causative organisms are same, which are the organisms for pneumonia. These are Streptococcus pneumoniae, Staph aureus, H. influenzae. In unvaccinated populations, community-acquired MRSA and Streptococcus pyogenes are the growing concerns now. So coming to the stages of pneumonia, we all know empyema, we have stage 1, stage 2, and stage 3. The stage 1 would be the exudative phase, which is there for initially 3 to 5 days and is characterized by increased permeability of the pleural space and capillaries. If we have the aspirate, the characteristic would be a low WBC count. The biochemical characteristics would be normal blood glucose, pH, and LDH, and the cultures would often be sterile. When we go for a chest X-ray, there'll be a layering of effusion, which is seen on the lateral chest X-ray, which is there. Now, coming to the stage 2 would be a fibrinopurulent phase, where the duration would be after 7 to 10 days of the disease, which might be there. There is bacterial invasion in the pleural space, and there's neutrophilic accumulation leading to fibrin depositions, septations, and loculations. Over here, we may have a high WBC counts, which may be there. When you have a pleural aspirate, there'll be a decrease in glucose. The pH would be increased. LDH would be increased due to lysis of neutrophils. The aspirate may show a bacterial growth, and there is no layering present on the chest X-ray. Coming to the third stage, which would be an organizational phase. This is seen characteristically 2 to 3 weeks after the initial infection. We have a formation of an inelastic membrane, that is, we call it a pleural peel, due to the growth of the fibroblasts and pleural surfaces. Over here, we find that the lung has restrictions to expansion, and therefore there might be a compromise. The counts would be high in this case, and the pleural aspirate, we would have a decreased glucose, the pH would be reduced, and the LDH would be markedly raised. Once we have an aspirate, there might be a dry tap, or there might be a very thick fluid, and the culture may show a growth. On an X-ray, we may show a pleural thickening might be there. Next, coming to the clinical presentation. Any child with pneumonia not responding to more than 48 hours of appropriate antibiotic therapy should be evaluated for complications, including a parapneumonic effusions. So normally we see that when we assess a child of pneumonia, we see for a response, how is the child after 48 hours? Normally the child should start improving within 48 hours. Otherwise we go for other things, like you check the antibiotic compliance is there or not. So one of the important things would be there, we have to check for complications also. So what will be the symptoms in these children whom we suspect for a parapneumonic effusion? These symptoms, in addition to the symptoms of pneumonia, would be persistent fever and dyspnea. There might be chest pain because of pleuritis. There will be splinting involving the sides of the hemithorax to provide a temporary pain relief, which might be there. When you examine this child, you may find signs of worsening respiratory distress. Signs of pleural involvement such as fluid might be there. Splinting of affected side may result to shallow breathing, and a child may have scoliosis and a pleural friction rub, which might be there. Then you can have additional systemic features which may be present in this child. Now, what are the investigations we do when we suspect a child of pneumonia effusion, which might be there? So we first go for chest X-ray. Chest X-rays help us to diagnose the effusion. It does not often differentiate between a simple from a complicated effusion or an empyema, but yes, you have a characteristic thing which you can diagnose as a pneumonia effusion. If air fluid level is present, then we may consider for pneumothorax or a bronchopleural fistula or a gas forming organisms. A complete whiteout opacity of the entire hemithorax can be caused by a fluid or in consolidation. And for this, now we have a bed test which is there available, which that is the ultrasound, which is very good test for a point of care evaluation in cases of pneumonia, where we can quickly see whether it is a consolidation or effusion and can quantitate that too. So chest x-rays and ultrasounds are the main things which we can use for complications of pneumonia. Now coming to the ultrasound thorax is the mainstay these days. So it is a preferred modality for evaluation of pleural effusions due to easy availability, better accuracy in detecting early loculations and septations than CT. We do not have any radiation exposure as similar to a CT scan or a need for sedation, and mark the optimal site for thoracocentesis chest tube exertion. So you see that ultrasound is a very simple test. You can do it bedside for a patient without all these things, radiations, marking the sites, chest, painful chest tube insertion, etc. So this is the mainstay of diagnosis in pleural effusions. Now coming to CT chest, when should we go for a CT chest? So CT chest should not be routinely performed. It is more useful for evaluation of parenchymal disease rather than to determine the nature of the pleural fluid and the presence of empyema. So the role of CT is more or less limited. If you have a suspicion that there might be lung necrosis or an abscess which is present, to rule out a non-infectious cause of effusion if you suspect that, or prior to open for thoracotomy to delineate the anatomy better for surgeons, it is a indication. So it is a surgical indication rather than a medical indication. So more or less these indications are very found less in a pediatric setting. So now coming to the pleural fluid analysis, what do we get if you aspirate the pleural fluid in cases of pneumonia effusion? So the biochemical characteristic would be a low pH, that is a pH less than 7.0. The glucose would be low, less than 40 milligrams per dl. The LDH is raised more than 1000 international units. It occurs in empyema, but usually do not help in decision making to drain the fluid. Cell counts, if we see, the cell counts would be usually more than 10,000 cells per microliter, and neutrophilic predominance is seen in untreated patients. If we have a partially treated patients, you might have a 50-50 lymphocyte and a neutrophilic counts which might be there. Now we can go for cultures for the pleural aspirates, and blood positivity rate is 2 to 20% in cases of pneumonic effusion, and in cases of pleural fluid you may find again it is a poor one, up to only 1/4 of the patients. Now, positivity is influenced by the prior usage of antibiotics. Of course, if we have antibiotic use, the positivity decreases. And the yield may be increased by performing additional techniques like latest agglutination for pneumococcus and multiple PCR analysis on the samples. So now we can go for many more tests, just not relying on the culture growths. Now this is just to summarize that what do we do if you have a suspicion of a patient with a pneumonic effusion. So over here we have to confirm whether on the whether the diagnosis of pneumonia and a pneumonic effusion, and then categorize it on the basis of the size of the effusion. So you categorize it as a small effusion, moderate effusion, and large size effusion. So the size would depend upon small effusion is less than 10 millimeters of a rim or less than 1/4 of the thorax opacified on the chest X-ray. So if I will go one by one. First, I'll talk about the small effusion. The small effusion is treated with antibiotics. You do not obtain a pleural fluid for culture and do not attempt for any pleural drainage, and it mainly responds to the antibiotics. If the response is coming to the antibiotics, then yes, please continue the antibiotics. If the response is not coming, then we have to again go and reassess the effusion size. And if the effusion still remains small, we can just complete our antibiotic course. However, if the effusion has now been increasing, we might think of moderate or a large effusion and then manage accordingly. So now coming to moderate effusion would be something which is greater than 1/4 but less than half of the thorax which is opacified. And now we have to see for the degree of respiratory compromise which is there. If the respiratory compromise is low, that the patient doesn't have any tachypnea, then we can treat for IV antibiotics alone. Otherwise, you go for chest ultrasound, obtain the aspirate, culture thoracocentesis, and we may go for a chest tube placement and for fibrinolytics. If the condition is worsening despite of antibiotics, then we proceed the algorithm for the large effusion. Now, supposing in this case only the effusion is moderate, but the respiratory compromise is more. So again, we go to directly to the large effusion protocol. So the large effusion protocol, that is when more than half of the thorax is opacified, what do? we go for a chest ultrasound, which is the first thing. If that is not available, then you can go for a CT to assess for the effusion size and the degree of loculation. Then you can go for a pleural fluid for culture and drain the pleural spaces. And then the options would be, if the fluid is not loculated, it is simple. We can go for a chest tube insertion and go for chest tube with fibrinolytics, or we can go for VATS depending upon the stage of the disease and the availability of the procedures. Now, if the fluid is loculated and it is now labeled as a complicated one, then we have two options. Either you go for a chest tube insertion with fibrinolytics if it is not responding, and then proceed to VATS, or you can directly go for VATS depending on the availability of VATS, the affordability of VATS at particular centers. Now, VATS versus fibrinolytics is very controversial, and there is nothing which is standardized in pediatrics. We have the studies which are inconclusive that what should be the first modality of treatment. The second complication would be a necrotizing pneumonia. So necrotizing pneumonia is a severe complication of a community-acquired pneumonia in children, and it is characterized by lung necrosis, which is might due to toxins produced by the invasive bacterial strains secondary to vascular changes, which includes vasculitis and intravascular thrombosis. Most common etiology is Streptococcus pneumoniae and Staphylococcus, which is seen in our settings. Then necrotizing pneumonia is commonly complicated by a parapneumonic effusion, empyema, a bronchopleural fistulas, septicemias, and respiratory failure. So we see that necrotizing pneumonia is never seen in isolation. It may be present with other complications also. Prolonged antibiotic therapy is recommended. It may be up to 4 weeks, and prompt recognition and management of complications are mainstay of management. Prolonged pleural drainage is associated with increased risk of bronchopleural fistula and should be avoided. Therefore, we should decide early when to stop our tubes. Now, third complication would be a lung abscess. So, destruction of the lung parenchyma as a result of inflammation and necrosis can lead to thick-walled pus-filled cavities. The presence of respiratory comorbidities, for example, diminished clearance mechanisms and recurrent aspirations, are the risk factors for abscess formations. It occurs as a primary complication of community-acquired pneumonia. Then gram-positive organisms are the most common, whereas gram-negative anaerobes may be the causative organisms when it is secondary to the underlying conditions or comorbidities which are present in a particular patient. Now, what do we see on a chest X-ray in a case of lung abscess? Chest X-ray shows a thick-walled cavity or with or without a air fluid level, and the diagnosis may be missed in 20% of the cases, and hence a CT scan is the investigation of choice. The lung abscess, the prolonged antibiotic therapy is necessary. It is usually recommended for 3 weeks. However, sometimes we may continue unless the chest X-ray shows clearing and there is a stable residual lesion might be there. So uncomplicated abscesses usually respond to the medical management alone. Now, what may be the risk factors for non-resolution? These are obstructed bronchus, very large size lesions with infections with resistant organisms in children with risk factors like Pseudomonas, percutaneous or endoscopic drainage procedures by insertion of a pigtail catheter, or in refractory cases, lobectomy may be required. These are the procedures which are very less and limited experiences because they occur in very small percentage of cases. So normally lung abscess mainly responds to your antimicrobial therapies. Now, the other complications can be pneumothorax in cases of pneumonia. It may occur as a complication of pneumonia with gas-producing organisms or due to mechanical ventilations also seen in the ICUs. And now coming to non-pulmonary complications, we see that there might be a SIADH, which is a common in hospitalized patients with community-acquired pneumonia, and it may be seen up to 1/3 of the patients. As far as the main management would be there, fluid restriction should be done in patients, children who are not dehydrated if hyponatremia is detected and attributed to SIADH. And we may avoid use of hypotonic fluids. Rest of the part of the SIDH remains stand as for the other diseases. Sepsis, pneumonia is the most common cause of pediatric sepsis. And we cannot discuss sepsis over here because it is a complete another section. So I think we just conclude with this, that sepsis is seen in a lot of cases of pneumonia. Coming to hemolytic uremic syndromes, rarely pneumonia due to Streptococcus pneumoniae can lead to HUS, and the incidence is very small, up to 0.5% of the cases. HUS, we all know, is a triad of microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury. So as far as the management goes for HUS, we have antibiotics, we have a dialysis support, which may be needed into 70 to 80% of the cases, and supportive measures including antihypertensives, blood products, transfusions as indicated, and role of plasma therapy, plasmapheresis is controversial. Now coming to, these were the complications. Now let us discuss what is the course of a typical pneumonia and what is the outcome beyond these complications. So now talking about clinical resolution, most children we see recover within 2 to 4 weeks and require no follow-up. The mild symptoms like persistent cough, which may persist up to 4 weeks or longer, specifically in cases of pertussis and mycoplasma, where it may persist longer. That is the only thing which is left in the patients, but otherwise we normally see that most of these patients resolve in 2 to 4 weeks. So when should we ask a patient to follow up? So we ask a patient of pneumonia to follow up when you have persistent or recurrent episodes. So this is one thing, whether the patient is having persistent or recurrent pneumonia, then you should ask the patient for follow-up, because there might be some other etiology or a condition which is should be investigated. Then if my patient has some atypical symptoms like hemoptysis, then also I would like to follow up that child. Then in cases of severe disease like requiring ventilation, difficult extubation, where we might suspect sequelae like subglottic stenosis, vocal cord palsy, airway malicious, etc., we should definitely ask our patient to follow up. Another thing would be when there is a family history of deaths or pulmonary disease, which might raise a question that there might be other etiologies for pneumonia. Failure to thrive and other systemic involvement may be another indication. In a normal course, they should be called once after 2 to 4 weeks. But if there are clinical symptoms for any persistence or of any other complications or any other underlying etiology, we may require more follow-ups of the patient. Coming to radiological resolution in a normal course of pneumonia, complete resolution of radiological abnormalities may take up to 4 to 6 weeks. However, this is very variable. It may be late and prolonged and maybe extend even months. For example, in children with adenovirus infections. And radiological improvement definitely lags the clinical improvement. So there is no point in getting a repeat X-ray, as some of you may ask that before discharge, do we get a patient repeat X-ray done? So that is not recommended for it. Then indications of chest X-ray on follow-up would be if the child has persistent cough or has any other signs of incomplete recovery, we may get a repeat X-ray to see for any other etiology or a complication. If there might be a persistent lobar collapse, there might be recurrent pneumonia, there might be same lobe lesions occurring again and again, there might be a persistent atelectasis, there might be complicated pneumonia as in form of effusions, abscesses, or there may be rhine pneumonia which may suspect other etiologies. So these are the indications for getting the repeat X-rays in children with pneumonias. So now coming to recurrent and persistent pneumonia. So we know both these conditions, that recurrent pneumonia is any pneumonia where we have more than 2 episodes of pneumonia in a year or 3 episodes in a lifetime. That would be defined as a recurrent pneumonia. Coming to persistent pneumonia, where the features of lower respiratory tract infections, that is cough, tachypnea, and fever, with or without chest retractions, and with radiological evidence of infiltrates or a consolidation, which may persist for greater than 30 days or more despite receiving antibiotics. So these are 2 important terminology which we want to remember, that is recurrent pneumonia and persistent pneumonia. So now as far as the etiology goes, most of the etiologies for both the diseases are discussed together because the etiologies patterns are common. So these are the some Indian studies which are there. We have studies by AIMS, that is by Dr. Lodha et al. And Dr. Kabra et al. And another study which is there. So most of the common etiologies for both recurrent and persistent pneumonias include post-TB bronchiectasis, aspirations, immunodeficiency disorders, structural anomalies, infections, and foreign bodies, and asthma. So these are the common etiologies. Just to sum up these etiologies, so etiologies in developing countries would be persistent pneumonias, would be prolonged infection, example pertussis, mycoplasma, respiratory syncytial viruses. Post-infected bronchiectasis is also known to follow pertussis, measles, and TB. Then in children with other structural malformations like most commonly acyanotic heart disease, where there's a left to right shunt, patient normally presents with recurrent episodes of pneumonia. Other thing would be neurological dysfunctions and aspiration syndromes, normally seen in children with cerebral palsy or other swallowing defects or tracheoesophageal fistulas, where you have recurrent episodes of pneumonia which might be there. In an Indian setting, we cannot forget TB, which may persist an important cause of persistent pneumonia, and other chronic lung disease, which may also be a mimickers. So just to say in between that persistent pneumonia has a lot of overlap with recurrent pneumonia, pneumonia mimickers, and chronic pneumonias like TB or eosinophilic pneumonias, etc. So now let us first talk about recurrent pneumonia. We've already defined recurrent pneumonia. So now what are the risk factors for recurrent pneumonia? Recurrent pneumonia may be seen in up to 7 to 9% of the children with community acquired pneumonia. The risk factors would be the host. This would be the prematurity and bronchopulmonary dysplasia. These may be important risk factor due to inadequate immunity, low maternal antibody levels, and impaired lung functions, and immunoregulatory responses. These may be the important causes. The second would be atopy. That is effective innate immunity response to the epithelial cells, interleukin 13 dependent reduced mucociliary clearance. The environmental factors would be indoor and outdoor pollution, which is one of the main things even in today's world. The other would be overcrowding, that is increased exposure to pathogens. Another thing would be the tobacco smoke exposure, which have an effect on an immune response, suppressed phagocytic activity, increased bacterial adherence, and impaired lung functions. So these are the main causes for risk factors for recurrent pneumonia. So now, in a case of a recurrent pneumonia, the approach would be whether it is a single lobe involvement or a multiple lobe involvement. So a single lobe involvement, the more common etiologies would be a right middle lobe syndrome. The other etiologies which may lead to a localized airway obstruction would be enlarged lymph nodes, endobronchial foreign bodies, which are very common in pediatric age group, congenital airway malformations, rings, plugs, and enlarged chambers due to life flight shunting and cardiomyopathy. The other would be a parenchymal disease, specifically talking about congenital malformations like congenital lobar emphysemas, infection in a residual cyst change after a cavitating pneumonia or TB. That is again a cause for a recurrent pneumonia in a particular site. And the third would be malignancies, which are though less commonly seen in pediatric age group. The other thing would be a multi-lobe involvement. So multi-lobe involvement is seen in systemic immune disorders, specifically the immunodeficiency disorders, the primary immunodeficiency disorders, the localized immune disorders like certain anomalies of the mucosal defense. The other would be genetic disorders like cystic fibrosis and primary seed dyskinesias, which though thought to be rare, but are not uncommon even in Indian setting. Third would be neuromuscular disorders, like there may be central neurological disease, peripheral nerve or functional disease, and conditions causing weakness of the expiratory muscles. Fourth would be airway anomalies like post-infective or idiopathic bronchiectasis, multiple complete cartilage rings, and generalized bronchomalacia, which may lead to a recurrent pneumonia. Other would be major airway obstruction, that is airway compressed by enlarged heart or great vessels, most commonly the vascular rings and the slings and the absent and the abnormal course of arteries like pulmonary arteries, etc., which we commonly see in the clinical conditions. So now, what are the pointers which we get for cases of recurrent pneumonia? So the first thing would be the atypical age of onset and the cause of a disease. If I have a recurrent pneumonia in a 2-month-old child or a 3-month-old child with other things, then I might think of some certain genetic or a structural causes or even early immunodeficiency. So these are the marker for it. Then unusual organism or features of systemic immunodeficiency. Supposing if I have a children, unusual organism would mean, supposing if I have a child who has a pneumonia, which is Pseudomonas pneumonia. Now, Pseudomonas is not a common infection in a community acquired pneumonia, as we have all seen in the previous slides. So once a Pseudomonas pneumonia is there, the thing which I look at is a cystic fibrosis. So unusual organisms is definitely a important clinical marker. The other thing is features of systemic immunodeficiency. Supposing if I have a infection which is not limited to the respiratory system, but it is involving the GI system also, there are boils, pustules. So that is again a pointer that the child may have a systemic immunodeficiency disorder that is just not beyond this pneumonia. Now, failure to thrive. Again, normally a child with pneumonia should not have failure to thrive But if I have a failure to thrive, then it may point towards underlying etiologies like cystic fibrosis, etc. Chronic rhinosinusitis or otitis media from early age is against a pointers toward diseases like cystic fibrosis and primary severe disc kinesias. Then presence of moist cough and sputum production. So these are again an indication that they might be have a chronic abnormality, and the children may suffer from underlying bronchiectasis. Then more severe symptoms or irritability after feeds and lying down. This may point towards your aspiration syndromes, tracheoesophageal fistulas, etc. Then sudden onset of symptoms. Sudden onset of symptoms are commonly related to foreign body aspirations and other things. Then you have continuous unremitting or worsening symptoms. So again, non-improvement is a sign that the child may be suffering not just from a simple pneumonia, but from other things. Death, severe infections, or a multisystemic disease in the family again points towards a genetic etiology. Delayed passage of muconia may be a pointer towards a cystic fibrosis. So what are the points in physical examination if you look for? The examination, simple things like digital clubbing. So clubbing should not normally occur in a child of pneumonia unless there are complications like necrotizing pneumonias, or you have other etiologies like cystic fibrosis, which has been leading to chronic hypoxemia, etc. So clubbing is an important marker that the child is not simply suffering from a single episode of pneumonia, but there is something other complicated. Similarly, failure to thrive and signs of weight loss are again an important pointer. Unusually severe chest deformities is again a feature that the child is suffering from a chronic lung disorder. Simple things like absence of tonsils, which may indicate an immunodeficiency disorders. An examination of fixed monophonic V's or an asymmetric V's may suggest that the child may have another structural abnormality or a pointer towards that. Then signs of cardiac and systemic disease may point towards other systemic involvement. Persistence of Krebs on auscultation more than 8 weeks is again an indication that the child may have different. Then a same lobe disease. If the child has recurrent pneumonia in a particular position, as we saw in a previous slide, it may suspect the child of some structural malformations. Now over here, we just see simple things like presence of cleft palate, cleft lip, presence of bifid uvula, which might be there, absence of tonsils. These are common indicators that the child have other associated symptoms. Then over here, we can see that the child have a nasal polyps might be there. So again, these conditions are most commonly seen in cases of cystic fibrosis or pulmonary severe dyskinesias, which may be a pointer towards underlying these etiologies in cases of pneumonia. Now coming to atypical pathogens, we already said that it may, in immunocompromised children, we may have atypical pathogens like pneumocystis might be there, or CMV might be there in cases of immunodeficiency. We may have Pseudomonas and Burkholderia, which might be present in cystic fibrosis. Now coming to radiological clues. So radiological clues, we may have the important things like a right middle lobe syndrome, where we have involvement of a limited middle lobe, which might be there. In cases of, if we have situs inversus in cases of pneumonia and other features are there, that it may point towards a primary severe dyskinesias or any other cardiac malformations. Then we have another structural lesions which might be indicated in x-rays like cystic adenomatoid malformations or presence of bronchogenic cysts. So how do we work up these children of recurrent pneumonia, and when, how should we refer? So for a single lobe disease, because we feel that structural malformations are the most common things, we should get a chest CT done and a bronchoscopy, which are the first line of involvement. When we talk about a multilobar disease, we think of a generalized disease which is more systemic. Hence, we go for things like sweat test, immunological workup, and swallowing evaluation. And then we can go for chest CT and bronchoscopy in these diseases. Now, we should refer all the cases for pulmonologists for evaluation, because in most of the cases of recurrent pneumonia, we have an underlying etiology which might be missed. So, when should we refer a child to a pulmonologist? If the child has severe infection, persistent of infection, failure of expected recovery, that the child is taking very long, there is prolonged interstitial pneumonia with no detectable infective cause. So in all these conditions, we might not just keep on giving antibiotics and waiting for a slow resolution, but we should suspect something else, and we should ideally refer this children for a specialist evaluation. Now, what does additional things which happen when the child comes to a specialist or a pulmonologist? For aspiration syndromes, he may be worked up for by barium swallow and pH monitoring for looking at complications like gastroesophageal reflux disease or presence of any other malformations which might be there. For foreign body, the child may undergo bronchoscopy, which may be both diagnostic and therapeutic. For cases of bronchiectasis, the child may undergo HRCT, and if you are suspecting other disorders like cystic fibrosis or primary scene dyskinesia, the child may go for high-speed video microscopy or electron microscopy, sweat testing, and immune studies where we are suspecting your immunodeficiency disorders. Talking about structural and anatomical abnormality, that may be detailed with CT scan, barium swallow, and a bronchoscopy. So indications of bronchoscopy in a cases of recurrent pneumonia might be when the child have additional things like they might be hemoptysis, persistent stridor or a wheezing, when you suspect a foreign body, when there's a persistent or recurrent atelectasis which might be there, or there might be a localized disease or a difficult extubation. So in these, the indication would be exploring the airways. The second indication would be obtaining samples for bronchoalveolar lavage, brushings, or a biopsy. For example, when you have chronic interstitial pneumonias in the children with eosinophilic pneumonias, hemosidrosis, or ILD, where you might get a cytological diagnosis with the BAL. Then you have lumen lesions and obstructions, where it might be important for taking a biopsy. Or if you suspect atypical organisms in immunodeficiency disorders or in other diseases, where you have non-responsive pneumonias that can help you in guiding for antibiotics as well as etiologies. As a part of a therapeutic procedure, the bronchoscopy would be required in difficult intubations and for foreign body removals. Now, how as far as the management goes, the management would be supportive management, would be nutritional management as similar to any other chronic condition. Like in cases of cystic fibrosis, the exact recommendations for calories, proteins, and fat consumptions might be there. Chest physiotherapy and other lung clearing techniques are required. Then non-pharmacological methods may be told to the children. Then specific treatment would differ for each disease. It may be medical treatment or a surgical treatment. Surgery in cases of malformations like supraglottopexy, lobectomy, sling corrections, etc., might be done by a CTVS surgeon or a pediatric surgeon. Immune therapy and BMT would be recommended in cases of immunodeficiency disorders. Then other thing would be specific treatment for cystic fibrosis. The third would be prevention of infections, which remain the mainstay of infections. So we may promote pneumococcal and flu vaccines in children with recurrent and persistent pneumonia. Then in children with immunodeficiency, we may have prophylactic antibiotics like azithromycin in cystic fibrosis, which may act as an immunomodulator. Antifungals and Ciplan, which are normally recommended in children with immunodeficiency disorders. The other specific treatments we are not discussing over here, and they relate to a particular condition. Now, just 2 words about persistent pneumonia. Persistent pneumonia, the main organism, as a part of a developing country in India, the first and foremost would be Mycobacterium tuberculosis, which should be thought of first. The other organisms can be many. To talk about few, it may be Legionella, cytomegalovirus, pneumocystitis, chlamydia, fungi. These are the organisms which we commonly see. So just to sum up, the diagnostic algorithm in cases of recurrent or a persistent pneumonia, we would go for if an immune status assessment, that is what we get from a CBC, looking at the lymphocyte percentage which might be there, or a neutrophilic count which might be there, which might give us an important clue. The other will be going to our antibody levels, IgG, IgM, IgE, etc. And then finally going for a flow cytometry if we suspect immunodeficiency disorders. If you're suspecting cystic fibrosis, then you go for a sweat test, which may be followed by a genetic analysis for the mutations. Then you go for nasal nitric oxides and nasal brushings if we are thinking of primary severe dyskinesias. Talking about tuberculosis, you go for tuberculin skin testing, which might just does not give us much clue. Then for swallowing defects and for gastroesophageal regurgitation, we may go for a 24-hour esophageal pH monitoring. Nasal fiber optic endoscopy might be done to look for any other associated nasal lesions. Echocardiogram to look for any structural defects which might be there. And you go for a pulmonary function testing to assess what is the current status of your lung functions. If these tests do not give any conclusion, then you proceed for a chest CT scan. You go for a bronchoscopy, plus you're associated with BAL. You go for a esophageal manometry. And if you suspect of connective tissue disorders like SLE, rheumatoid, which may be specifically pointed out by the history, then we go for additional testing of these disorders. Last step, if you do not get any clues to all these primary and secondary investigations would be a lung biopsy, specifically in cases of interstitial lung disease or other disorders. So this is the summary in total that what a specialist or a pulmonologist would be evaluating in cases of recurrent or a persistent pneumonia. Thank you.
Hema, you can stop sharing while Bella
Yes,
madam
sir.
can
Yes,
share.
sir. Yes, sir.
I request all the attendees just to bear only 2 more minutes. See, I think I would compliment Hema and Dr. Bella madam. You know, it is not easy to be the last faculties. Bella madam, over to you. And please bear with us only for 5 minutes. Let's give due respect to madam from Mumbai. She has done a lot of efforts, even in other parts also. And I'll tell you, this pre-test and post-test has been done by Dr. Bella madam. So mind you, so therefore, let us give full respect to madam and stay for another 5 minutes. Thank you very much.
Yeah, thank you everyone. Good afternoon. So regarding preventive measures, we have seen throughout the TOT that there's a high incidence of pneumonia in children, which leads to significant morbidity and mortality. And therefore, it becomes imperative to understand and implement effective interventions which will help in prevention of lower respiratory tract infection. So regarding nutrition, one would be promoting exclusive breastfeeding for the first 6 months of life and continuing it till 2 years of age with appropriate introduction of complementary foods. And the second would be management of malnutrition. We have seen that malnutrition and anemia play an important role as predisposing risk factors for contracting lower respiratory tract infections. Therefore, since malnutrition increases the frequency and severity of pneumonia episodes, and it has a direct impact on the mortality of the children, here I would mean not just undernutrition and wasting, but also management of obesity. Initiating appropriate nutritional intervention and rehabilitation is necessary. Regarding vaccines, vaccines are one of the most important strategies to bring down pneumonia incidence, morbidity, and mortality. And therefore, we will be seeing the use of some effective vaccines. In environmental factors, we know that exposure to tobacco smoke, household smoke, smoking in parents, outdoor pollution is another environmental risk factor for promoting increased incidence of lower respiratory tract infection.
Dr. Bela, just to interrupt that the slides are not moving.
Yeah, I have not yet started them. I'm going to start my slides. I'm just giving an overview first. And lastly, I would also like to add that we should not forget our respiratory hygiene and cough etiquette, which we have learned the hard way throughout this year in the pandemic. So coming to nutrition in pneumonia. So when a child is having pneumonia and is being treated for it, we know that infection increases the metabolic demands in the body. Also, because of fast breathing, there is a restricted oral intake, leading to a state of semi-starvation. Hence, there's a need to give high-density energy food, which can be started through the enteral tube feedings in these children. Therefore, in newborns and infants, express breast milk can be given every 2 hourly. And in older children, we can give calculated semi-liquid preparations like rice, moong dal, khichdi or gruel, suji, ragi, dalia through the nasogastric tube or the orogastric tube. And the calories of the food can be increased by addition of sugar, jaggery, oil, and milk. And therefore, we can maintain adequate nutritional and hydration status of the child. Nutritional supplements may be required in some of the patients because we already have pre-existing malnutrition in most of our patients. And therefore, these supplemental vitamins and minerals can be given orally or parenterally. So vitamin A single dose of 1 lakh unit for 6 to 12 months of age and 2 lakh units for more than 12 months age patient can be given if he has not received it previously in the last 6 months. Vitamin D3 can be given as oral 60,000 international unit per week for 10 weeks, or in cases of severe vitamin D3 deficiency, an injection Arachidol 3 lakh units intramuscularly stat can be given if we notice pre-existing vitamin D3 deficiency or we investigate for it. Now, oral zinc has been proven to prove beneficial in respiratory infections and improve the immunity of the child. Therefore, 20 milligram per day for a child older than 6 months and 10 milligram per day for a child less than 6 months old is given. It is advisable to give extra 2 to 3 weeks of aqueous supplemental multivitamins and minerals by the dose of 2 recommended dietary allowances after a child recovers from pneumonia. Oral iron is started only after the infection has been treated completely, as per the standard guidelines and pre-existing nutritional status of the child. Now, vaccines, we all know that immunization is a well-known method and intervention for controlling and even for eradicating diseases. It has emerged as a branch of preventive medicine, and it is one of the most cost-effective health investment. Comprehensive immunization program under the age of 5 years has shown to reduce the morbidity and mortality resulting from vaccine preventable diseases. So briefly, I will just speak on 4 vaccines. That is measles containing vaccine, Haemophilus B vaccine, pneumococcal vaccines, and influenza vaccine. So measles vaccine is available as a monovalent preparation, combination with rubella vaccine, or a combination with mumps, rubella, and varicella vaccine. It is given in the right upper arm or an anterolateral thigh as a 0.5 ml dose subcutaneously. It is given at 9 months and at 6 to 24 months. A third dose of MMR is advisable at 4 to 6 years of age to boost the immunistic response. Influenza B vaccine is available as a monovalent vaccine as well as a combination known as pentavalent vaccine with DTP, hepatitis B or IPV, given 0.5 ml intramuscularly in the anterolateral part of the thigh. It is extremely safe and immunogenic with an efficacy of 85 to 95%. In the national program, pentavalent vaccine has been incorporated and given as a 3-dose vaccine at 6, 10, and 14 weeks of age. As per the IIP schedule, 3 doses 4 weeks apart, same as above, are given with a booster at 15 to 18 months age. Older children will need vaccination only if they have a sickle cell disease or they are being planned for splenectomy. Now, pneumococcal vaccine available as unconjugated polysaccharide vaccine PPV23 as well as conjugated vaccine PCV13 and PCV10. The unconjugated vaccine is given as 0.5 ml intramuscularly or subcutaneously in the deltoid region. It does not produce nasopharyngeal or it does not reduce the nasopharyngeal pneumococcal carriage or provide any herd immunity. The efficacy in high-risk categories is to the tune of 70%. 2 doses are recommended. In the IIP schedule in high-risk category, 1 dose is given after 8 weeks after the primary course with conjugate vaccine, and it can be repeated after 5 years of age. Conjugated vaccine is given as 0.5 ml subcutaneously anterolaterally in the thigh or the deltoid. It provides robust immune response and an immunological memory. It reduces the nasopharyngeal bacterial carriage and results in herd immunity. The protective efficacy is to the tune of 95 to 99%. As per the IIP schedule, 3 doses are given above the age of 6 weeks, 4 weeks apart, 1 booster at 15 to 18 months, and after 60 months, 1 dose can be given if the patient is a high-risk patient. Influenza vaccine are available as inactivated influenza tri or quadrivalent vaccine containing 2A or 1 or 2 influenza B strains and a live attenuated intranasal vaccine. The inactivated vaccine in a child less than 3-year-old is given as 0.25 ml and more than 3-year-old child is given 0.5 ml intramuscularly in the upper arm or the anterolateral thigh. Highly immunogenic with minimal adverse events and recommended for high-risk groups. 2 doses are given 4 weeks apart at 6 months to 9 years of age. And if the child is older than 9 years, then only 1 dose is given. Annual vaccination is advised in India, 1 dose before the rainy season every year. The live attenuated intranasal vaccine is given using an intranasal spray, 0.25 ml in each nostril. It is recommended for healthy children older than 2 years of age. It is more immunogenic and therefore to be avoided in high-risk categories. Following reports of unsatisfactory efficacy, WHO has recommended the discontinuation of this live vaccine. And in the national program, it is not included. This completes regarding the vaccine. Coming to environmental risk factors, which can be classified into modifiable risk factors and non-modifiable risk factors. So the modifiable risk factors are the demographic factors like parental illiteracy, low socioeconomic status, overcrowding, and partial immunization in the child. Nutritional factors such as lack of breastfeeding, early weaning, anemia, presence of rickets, malnutrition, and vitamin A deficiency, and the environmental factors such as overcrowding or indoor pollution, family history of smoking, use of kerosene lamps in the house, mud and cow dung flooring, level of industrialization of the place, and biomass fuel pollution with lack of ventilation. All these predispose to high incidence of lower respiratory tract infection. Non-modifiable risk factors are underlying chronic systemic illnesses like congenital heart disease, cystic fibrosis, cerebral palsy, etc. Now, many of these risk factors are amenable to corrective measures and can effectively prevent incidence of pneumonia. Now, these are some of the slides that were shared by the Child Health Foundation on 12th of November on Pneumonia Day, which very comprehensively depict the prevention of pneumonia. One is by immunization, second breastfeeding for first 6 months, adequate nutrition, reducing air pollution. Breastfeeding, exclusive breastfeeding to be promoted. Immunization against pneumonia not only protects your child, it will also protect others in the community who may not be vaccinated. It reduces the hospitalizations and it also saves treatment cost. So to summarize so far, good nutritional diet and supplementation of minerals and vitamins are required as a preventive measure also and for treatment also. Appropriate vaccines, measles, Haemophilus B, pneumococcal and influenza vaccines are helpful in reducing and bringing down, controlling the incidence of pneumonia. Effective interventions to reduce morbidity and mortality also required for the environmental risk factors by bringing in legislative rules and stringent measures. And we should not forget the respiratory hygiene and cough etiquette, which the pandemic has taught all of us in this entire world, which people had forgotten, and that is social distancing, covering the nose and mouth while sneezing and coughing, sanitizing and washing hands frequently, which will also bring down the incidence of transmission of infection and respiratory pathogens, as well as the incidence of pneumonia. Thank you.
Thank you very much, Madam. While I thank all the faculties, I'll thank much more the delegates who were there, more than 200 for the whole length of the module. It's nearly, what should I say, 10 to 2 plus 1, 5 hours of learning. And all of us can, from the faculty, we can clap for the delegates first. And then the effort from all of us would be meaningful. See, I will tell you basically what we will do is we will first format the slides. We will post the slides to all of you. Please suggest corrections. Don't share it in the groups loosely because there is a lot of effort involved in it. So what we will do is you please suggest all the corrections. You are free to make any correction. WhatsApp to me. We'll incorporate all the corrections that have to be done. We are open-minded and it's a TOT. And on a virtual platform, we can't ask you and discuss. It is very difficult for us. Please understand. Each one of us have our limitations. So therefore, we will see that everything is fair and we'll give a gap of around 2 weeks or 3 weeks. We are going to have events like Respicon in the coming and a new year to start. Probably plan all your events in the new year where you want to conduct the program, everything. Keep it ready and our team will approach you and announce that we will go for dissemination of the module further to each and everyone. This was done in a hurry to impress upon the reason because we have number 12th as World Pneumonia Day. And in December, I don't think there'll be rushing of academics and people would be interested to listen. And in a new year, probably they will have some kind of new energy levels and it will be perceived across by everyone. So thank you very much. And all of you from the faculty, you can also take thank you. And certificates will be given to you. Slides will be given to you. Need not worry. All that we request you should be the members of the chapter. Then only you will get the slides and the certificates. We will verify and then we have to give you. It's a TOT. So I will thank my co-panelists for being so wonderful. And I'm only speaking on behalf of all of them. Maybe everyone wants to speak. And can you see the enthusiasm of the last speaker also? She did not leave even a single word, even though it was 3 p.m. So this is the commitment from all of them. So thank you very much. And can we break? And any of the faculties can tell bye-bye from each one of you at the end. Each one of you can tell bye-bye.
Thank you, everyone. Bye.
Thank you. Bye. And we
Bye,
would
bye.
thank ClearNet for.
Thank you, everyone.
Yeah, we also thank ClearNet for being supportive and patiently working even on a Diwali day. ClearNet, thank you very much, ma. Thank you for being so supportive. We would thank all the office bearers of the respective chapter, President Dr. Jagdish Channappa and all the EB, and also President of IAP, Dr. Bakul Parekh Baswaraj and the whole team. Thank you very much. So with these words, we will end the session and see you again in the next modules to come. Many more are there in the pipeline. Don't worry. We will trouble you with academics in the year ahead as well. Thank you very much. And please join for Respicon, which is the pride of the respiratory chapter as a national conference in the coming month on December 12th and 13th, Saturday and Sunday, with wonderful academics as well as mouth-watering sessions for you. Thank you very much.
Thank you. Thank you.
Bye-bye.
You all
Bye.
bye. Okay.